Hello, good morning, doctors. Welcome back to the Game Changer session by Dr. Sasi. Today, we'll see medicine, surgery, and obstetrics gynecology. Before moving to the session, could you please confirm me that I'm visually correct or I'm audible to you? Just a second. 1 minute. Hold रखना. Hello, good morning, guys. Welcome back. Yeah, thank you for information. Yeah, small glitch. Yeah, I guess everything is fine. Yeah, welcome back to this Game Changer session. I hope you are doing well. Did you revise the yesterday topic, guys? Did you revise the yesterday topic one? Yeah, good morning, Dr. Aishi, Dr. Abhijit, Dr. Parul, Dr. Anar. Yeah, well, good morning, Dr. Ashley, Joy, Diana, KP Singh, Dinesh, Chota, Doctor. Okay, good, Dr. Anonymous, Rahul, Rekha. Yeah, good morning, guys. Yeah, good morning, Ambika. Yeah, perfect. Yeah, then we'll move on to our session, and today we'll be having these 3 subjects which are most important for you. And if you do these 3 subjects, the cumulative mark of these 3 subjects, it's not 5, 10, 15, it is around 90 questions will be asked from this from these 3 subjects. Okay, around 90 questions. Okay, you see how big it is. It is a very big number. Yeah. Rahul, let me check from my end. I guess we shared it. I'll check in the break and I will update you back. Don't worry about the PDF. Actually, it need to go through the channels to be received to you, and we shared it. I'll check it in the break. Don't worry, Rahul. The PDF will be given. Okay, to you. Yeah, sure. I will share you the contact. Like, if any doubts, you can comment in the comment section, or else you can reach me out in my Insta at the rate of Dr. 𝗓𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏. You can reach me out, or else you can reach me out to the team of Dr. 𝗏𝗏𝗏𝗏𝗏𝗏 sir's channel. They also will help you out. Okay. So this is the thing, and today it is really, as I told you, it is 90 marks. Like the minimum marks you will get is 90 marks, which is around 30 marks in each subject. Okay, and before going to the sessions, let me give you a few tips like how to solve this medicine and surgery part. From medicine and surgery part, like 50% of the questions you should attempt with your knowledge, and 50% of your questions you would attempt by your common sense. What is the common sense? For example, if there is a trauma patients come to you, okay, if the trauma patients comes to you, or if then they will ask you what is the initial modality of investigation. So the initial modality should be easy and simple. Okay, the initial modality should be easy and simple. First, what you will do, either X-ray procedures or ultrasound procedures, and to the max level will do CT procedures. So likewise, you should use your common sense. You should not directly go to a very different and difficult examinations. And if they ask you some scenarios, they will ask you to think. For example, you are the first point of contact. For example, a patients come to you with a case of abdominal trauma. Okay, first you need to know whether the patient is stable or not. So it is the first thing. You will check the BP pulse, whether he is responsive or not, and next you need to give the IV fluids. So this is what they want at the level of MBBS level. So think based on this level as an initial management part and answer based on it. And if you answer such like that only, you will able to get at least 40% of the questions correct from this medicine and surgery part, and the rest 40 to 50% questions I will help you out. Okay, that is the motto of the sessions, and totally it will be 90 questions. And if you do the sessions well and good, and if you use your common sense, you can get at least 70 questions from this 90 questions to be correct, and it will be your game changer for sure. Okay, and about this length of the session, many of you are asking, like the length will be like medicine will be around for 1 hour 45 minutes. Okay, yeah, maximum for maybe go up to 2 hours, and surgery part it will be a bit longer. We'll do some part of surgery and some part of surgery post lunch, and after that we'll continue with gynecology. It also will be 1 hour 45 minutes to 2 hours. Okay, this is our expected time. So you will be finishing as usual. Okay, there is no many hurry-burries, and if you have any doubts, please make sure you are writing in the chat section, or if you have any other queries, you can post during the break. We'll discuss it. Okay, that is our main motto of the session, and without wasting time, we'll move ahead. Fine. Yeah, sure डॉक्टर दलजीत जात, ठीक है ना, will हम कुछ बीच में बात करेंगे. Fine. Yeah, like if you're in 10th grade, like as of now, like focus on your goal, and you will be becoming a surgeon. Just dream big. That is the motto. Like dream big. You can do it. You just take few steps. Don't think about vast things. Don't think about the things. For example, in a case of any examination part, don't think about the results. Okay. If you do your best, obviously you will get the best results. So if you are in any class or anything, or if you are doing your MBBS now, then just make sure you are doing it in a proper way. Whereas when you come to a point like giving to the examination like FMGE or USMLE, then you should be able to tackle the examination. That should be your main motto. Yeah guys, yeah, let's go. Fine. First about this medicine part. And one more thing, we'll be sharing you this PDF as I told you. And this PDF will be containing most of the informations. But the thing is that the linking the words and linking them into the question part, that is what we'll discuss during our sessions, and that is how you will be able to solve the questions. Okay, so make sure you are using the PDF and watching the video. Okay, if you ask me, yes, the medicine is mostly it is enough to solve the MCQs. Okay, in the FMG examinations especially. Fine. First we'll see into this asthma part. Okay, if you see about this respiratory system, the two important systems or three important systems in medicine, it is what? It is respiratory, cardiovascular and endocrine. Okay, respiratory, cardiovascular and endocrine. These are the three important systems that you should know for your FMG examination. Fine. We know asthma, it will be having which type of curve in spirometry? Yeah guys, the spirometry curve of this asthma, it will be scooped or it will be small in nature. Yeah, good morning, Dr. Complete Man. Yeah, how will be there? Will it be small, or this FEV1 by, yeah, it will be in obstructive pattern. Remember, it will be in obstructive pattern. And how about, yeah, it will be the scooped. Fine. And we know here the FEV1 by FVC ratio, will this be more or will this be less than 80%? What will be the answer? Yeah, the FEV1 by FEVC, it will be decrease or it will be less than 80%. Yeah, good guys, good Dr. Gautam, Anna, and rest of you guys. Yeah, good Dr. Diana and Dr. Nita. Yeah, good, well said. Fine. Yeah, good Dr. Divya Reddy. Fine. So these are the things you know about this spirometry mota. Then mostly they will give you this history. In a winter season, like in a winter season, mostly in the early morning or during the night, the patient or mostly the young patient, he's experiencing these episodes of breathlessness, episodes of wheezing. So the patient comes to you in the night. At the moment, you need to provide this management. So first, what he will do means the patient came to the OPD. First, he will start with what? He will measure his oxygen saturation and he will start with this oxygen. Then he will think of giving what are the drugs must be necessary. You can start with LABA along with the SABA. Okay, so it is the first point. It is giving the oxygen to the patients in a case of asthma. So this is the initial management for most of the cases they will ask you. Fine. And next about this asthma, as I told you, it is this reversible airway disease. And how we can say this is reversible is this, like the FEV1 of this is less than 80%. It will be increased once we give any bronchodilators like 𝗧𝗵𝗶𝗀 or 𝗧𝗵𝗶. So once we give them, the bronchodilation will happen and it leads to increase in this FEV1 by FVC ratio more than 12%. Okay, then. So initially there are few drugs we use. One of them is 𝗧𝗵. Okay, short acting beta agonist. What are the 𝗧𝗵 drugs, guys? That is the 𝗧𝗵𝗶𝗀. That is the 𝗧𝗵𝗶𝗀. And next we can use this 𝗧𝗵 as well, like salmeterol and formoterol. So these are this 𝗧𝗵, guys. Yeah, this is known as, previously it is known as post bronchodilation test. Yeah, good, guys. Then to decrease the mortality of these patients, then we can use this inhaled corticosteroid. So most of our management part will be this 𝗧𝗵, 𝗧𝗵 and inhalatory corticosteroids. Okay, so first what we'll do, if there is episodes are very less or in initial stages, we'll start with low dose ICS. We know this inhalatory corticosteroids, what will do, it will decrease the inflammation part. So if there is decrease in inflammation, obviously there won't be more mucus formations and there will be less mucus formations and lead to this bronchodilation. So then after this low dose ICS, you can add this 𝗧𝗵. Okay, as a prophylactic measures, you can add this long acting one like formoterol. If the patients maintains, well and good. If not, you need to move them from this low dose into medium dose. Okay, low dose into medium dose. And if this patient still not maintained, then you need to medium to high dose. Along with this, you need to add 𝗲𝗵. Okay, we used to use previously ICS, then 𝗲𝗵, then we need to add in a case of severe cases like mild to moderate cases, we need to add this 𝗲𝗵 like muscarinic agonist like ipratropium and 𝗬𝗏𝗏𝗏𝗏. And next, if still the patient is unable to maintain, then we'll use this anti-IgE antibody which is known as omalizumab. Remember, it is the omalizumab which is an anti-IgE antibody. Then or else we can use this interleukin 5 or interleukin 4 receptor antagonist or others drugs like montelukast. So remember, it is the initially the low dose ICS, then along with this low dose ICS, we can use this 𝗧𝗵 as a preventive measures. And if there is no response to this initial dose of low dose, then we can increase the dose, or else later part we can add along with the 𝗲𝗵, which is this ipratropium and 𝗬𝗏𝗏𝗏𝗏. If still the patient is having this recurrent episodes of asthma, then we need to use this omalizumab. Okay, omalizumab. Yeah, we can also use in a case of episodes, we can use this theophylline as well, Dr. Divya. Fine. And next about this COPD management, we told asthma, it is a reversible condition, right? So that's why when we give this bronchodilation, it will be positive for this bronchodilatory test. Whereas in a case of COPD, it will be consisting of two parts: emphysema along with chronic bronchitis. And we know this emphysema, it is what? It is this irreversible dilatation of, is it irreversible dilatation of which of the following? Is it bronchus or alveoli? It's especially the part of alveoli. It is the irreversible, it is the irreversible part of this dilatation. And in chronic bronchitis, it is also known as 𝗵𝗶𝗶. Yeah, 𝗵𝗶𝗶. Just remember. Okay, and then here, what is the management protocol they will ask you? We know there is a classification which we use for this severity, which is known as gold classifications, but here you need to know about this management part of the COPD. Initially, if there is only 0 or there is less exacerbations, in such cases you need to give this bronchodilators like 𝗲𝗵 or 𝗲𝗵 on daily basis. On daily basis, you need to give them this bronchodilators. Whereas in a case of group B, okay, means in the case of group B, then like you need to give a long acting bronchodilators like 𝗲𝗵 or 𝗲𝗵. Okay, for example, if there is 0 or no episodes or very less episodes, then we'll consider giving only bronchodilator. Whereas in a case of 1 or moderate more exacerbations when compared to the 0 one, then we'll add a 𝗲𝗵 or 𝗲𝗵. Okay, on continuous basis. Here, if it is intermittent basis, if it is less, if it is more, we'll give in continuous basis. Then if there are more episodes, 2 or more exacerbations, or few of them leading to hospitalization, then what will go? You will give direct 𝗲𝗵, or else we'll give 𝗲𝗵 along with 𝗲𝗵, our 𝗲𝗵, formoterol or like formoterol, or else we can add them with inhalatory corticosteroids and 𝗲𝗵. Okay, and mostly we'll use this instrument which is known as metered dose inhalers, like metered dose inhalers and oral drugs. Okay, in a case of very sick patients, then only we'll give IV steroids. Okay, so initially we'll use these drugs and along with this MDIs. Okay, usually it will be given as puffs and drugs. Okay, like LAMA, like in a case of LAMAs, we'll use them as oral drugs. So this is the management part. You need to know about this asthma because you know it is a reversible. You know about this bronchodilatory test. But what they usually ask is that what is the thing you will do. And can anyone tell me what is the drug which we use in a case of brittle asthma? Brittle asthma. The patient is having this brittle asthma episodes. In such a case of brittle asthma, what is the drug you will use? We studied in pharmacology. A good Dr. Divya, good Dr. Creations, like for P1 chance. Fine. So brittle asthma, it is what? It is this subcutaneous adrenaline. Yeah, good Dr. Punit, it is the subcutaneous adrenaline, or we call them as EpiPen, right? So we'll use this subcutaneous adrenaline for a case of brittle asthma. Okay. For in a case of anaphylactic shock, which type of adrenaline mostly will prefer? Yeah, guys. Yeah. No, remember in a case of anaphylactic shock, remember, we'll give IM adrenaline, we'll prefer IM adrenaline. Whereas in the case of cardiovascular shock, you will prefer what? IV, remember, yeah, good doctor. Brittle means like, brittle means, you know, like it is again, means it is tend to broke, okay, it's tend to broke the patient, that's why it's known as brittle asthma, okay, remember. Brittle means it is very fragile kind of brittle, okay, remember, yeah, severe attack. Then about this pneumonia. Means mostly in a case of this pneumonia, they will give a typical history each for one thing. For example, there will be a patient who is presenting you with typical features of cough along with sputum expectoration. Okay, fine. And you asked, what did you do? He told nothing, sir. I was roaming here and there, and I got this cold, and this cold progressed to this, and now he's having this fever and episodes. Okay, fever and episodes along with this tachypnea. You took up this X-ray and you will able to see the presence of lobar consolidations. Okay, consolidations. So they will give this typical history of fever, cough and cold, and they will, if you on X-ray you will able to see only one lobe of this lung is involved. If there is lobar consolidation, then you need to think of this typical pneumonia like community acquired pneumonia, which will be caused by this pneumococcus. So pneumococcus will be responsible for this community acquired pneumonia. Okay, community acquired pneumonia. Fine. Yeah, it is because of this streptococcus pneumonia. Then if you able to see this child, means are any patients who is presenting with the same cough and expectoration, but here the patient is having this presence of pneumotocele formations. The questions it will be mentioning there is a formation of this pneumatoceles in his lungs, and the X-ray will show the same. So which of the following organism will be responsible for this pneumotocele formation? What will be answer, guys? Which of the following organism will cause this pneumotocele formation? It is what it is, the Staph aureus. Okay, it is a Staph aureus. Remember, it is, we'll discuss about this PCP, but this is this Staph aureus which causes this pneumotocele formations. Whereas in a case of PCP or pneumocystis jirovecii, it forms cysts. It forms small cysts. Whereas if you see, this is very large. It is very large pneumatoceles, and sometimes this pneumatoceles can even rupture. Okay, once they rupture, they can cause pneumothorax. So remember, in history, pneumatoceles will be given. It will be suggestive of Staph aureus pneumonia. A good Dr. Henry, good Dr. Dr. Nain. Good. Next, yeah, this will be, if you take up your DPG and the FMGE MCQs, this will be given. Okay, this is how you will come to the conclusion, because everything looks same on the paper, but there will be a small catch point where you need to catch, and this small catch point in one question will convert your mark from 149 to 150. So you need to always wait for the chance. Okay, and next you saw this alcoholic patient who is presenting with this red currant jelly photo. Okay, and yeah, and there is a presence of this sign. If you are able to see this sign, or if they didn't told about this nature of the sputum as well, they will, you can see this image. Then there is this bowing, or this fissure. If you are able to see, Yeah, it is known as Fred-Landis bacteria. Yeah, if you're able to see this bulging fissure, it is really typical for which of the following? It will be typical for this Klebsiella pneumoniae. It is typical for this Klebsiella pneumonia. Fine. It is typical for this Klebsiella pneumonia. Fine. So usually there are typical pneumonia. It will be affecting only one lobe. Okay. And mostly it will be restricted to one part of the lung. Okay. One part of the lung. Okay. Then if there is pneumatocyl formations, you will answer about this Staph aureus. Then if you are able to see in questions written, there is a alcoholic male presenting with these features of red currant jelly sputum, and on X-ray you will be able to see this type of bulging fissure. Now this is the normal fissure, and when it comes like this, it is known as bulging fissure. Okay, so this bulging fissure will be seen especially in a case of Klebsiella pneumonia. Then you saw this patient who is presenting with these features of, is coming just casually to the hospital. Sir, like he is having features of dry cough. Okay, there is no features of any fever. He is having these features of malaise. So if you see this kind of atypical features along with this bilateral, involvement of lung. This bilateral involvement of the lung, it is typical for this atypical pneumonias and viral pneumonias. It will be typical for this atypical pneumonia and viral pneumonia like COVID-19. Okay, for example, in COVID-19, no, like most of them, they won't complaints with sputum formation, right? Mostly it will be a dry cough. They'll be having this malaise and anosmia. And if you see, it will be involvement of both the lungs. It won't be specific to your one lung. So remember, in a case of atypical pneumonia, there will be this patchy consolidations. They will mention this word as patchy consolidations. Yeah, in COVID you will be able to see one more thing which is known as ground glass opacities. Here in the case of atypical pneumonia, you will see this patchy consolidations or patchy opacities. ठीक है, आपको इतना याद रखना है और उसको देख कर ही आपको पकड़ना है आंसर को. ठीक है, fine. Yeah, good guys. One of them is what? One of them is this atypical pneumonia. It is this Legionella pneumonia. Fine. They will be given associated with the history of food consumption and with a history of diarrhea. So then you will point to this Legionella. Fine. Next, about we know in the case of AIDS patients, there is this opportunistic infection which is known as what? Which is known as Pneumocystis jirovecii. Okay, and this also can lead to pneumatocysts, but mainly it will form this small cysts in lungs. That's why it is known as Pneumocystis jirovecii. Yeah, it can occur in a case of if the CD4 count is less than 200. Fine, remember. Next, as I told you, this Klebsiella pneumonia, it will be causing this nectarizing pneumonia. That's why it will cause this red currant jelly sputum. So there is this bleeding, it causes this red currant jelly sputum. Yeah, in a case of this Pneumocystis jirovecii, if you do this examination which is known as bronchoalveolar lavage में आपको मिलेगा crushed ping pong ball. Okay, we studied in microsphere, right? Ping pong ball, and it is seen in a case of Gomery methamphetamine silver stain. ठीक है, ये एक silver stain है तो इस पे black color का देखेगा. Fine. And then in a case of COPD patients, they will give, if they give a history of COPD patients and they describe about some pneumonia which is gram negative organism, then तुम्हें याद रखना है, it is what? It is this Haemophilus influenza which is causing this pneumonia. Okay, it is the Haemophilus influenza which is causing the pneumonia. So we studied 3 gram negative organisms: Neisseria meningitis, Neisseria gonorrhoeae, and Haemophilus influenza. These are the must know organisms, and after which this Neisseria meningitis and Haemophilus influenza, both of them they causes meningitis. Whereas this Haemophilus influenza, it is also associated with this pneumonia, especially in a case of COPD patients. ठीक है, इतना याद रखना. Yeah, good guys. फिर इसके बाद this hotel stay or cruise stay where there is this Legionella pneumonia, like they will be always telling about this AC vents or contaminated AC vents. Okay, they will be mentioning. Yeah, good. That is the bisacar. Yeah, we'll use. Yeah, good guys. Yeah, Diana, well played. Okay, it is this AC ventilations are and for culturing you will use this bisacar. Fine, and it is due to this inhalation of this water droplets from this infected AC vents. Fine, and then in pneumonia part they will ask about this code. They will tell you mostly what they will do means in FMGE it is being less tested. What they will tell you is that if they want to test, they will test like they will give you this classical history. There is this 65 years old patients with a respiratory rate of 32. Okay, and his urea is normal, his blood urea level is normal, and BP is well maintained, 110/70. He is presenting with cough and expectoration. Okay, then what he will consider? What is the next step where he will do his management? Okay, where he will do his management. Fine. Like for example, he will give him drugs, or he will send him home, or he will treat them in inpatients, or you treat them in ICU. So they will ask this typical questions. So to answer these questions, you should know this 𝗏𝗃65 score. Okay, 𝗏𝗃65 score. Yeah, it can be spread by bird droppings as well, especially the pigeon droppings, Dr. Divya. Then 𝗏𝗃65 score, it will be having this first point. It is one point. It is for this confusion. Okay, this mental status, confusion, mental status, and then is about this uremia, this blood urea nitrogen level, which is approximately more than 7 millimole or else more than 19 milligram per deciliter. Okay, if it is more, we'll consider them 1 point. And if there is tachypnea, if the respiratory rate is more than 30, we'll consider them 1 point. Or else then BP, if it is less than 90, remember it is less than 90. Okay, they will give these parameters and they will ask you which of the following is not a part of Krupp score, and mostly they will play around this BP. They will tell the BP is more, should be more than 90. It is not more than, it is less than 90. Okay, then about this part, which is this age should be more than or equal to 65 years. So if in such a cases, okay, if the score is 0, but this patient is having the symptoms, okay, the mortality is very low, then what we'll do, we'll just consider them home remedies or home treatment or outpatient treatment. Fine. Whereas in a case of group 1 to 2, means one of them is present, like either mostly the respiratory rate will be more, okay, or else the age factor will be there. Then you need to consider two things. For example, in a case of group 2, means like 1 to 2 will be there, like 1 or 2 will be present, then you should think of this IPD management. Okay, IPD management. Here you need to consider this IPD management for a short stay. Okay, short stay, or if the patient is not having any comorbidities, or if he is a young patient, then you can advise to go home like a OPD treatment. But if he is having older patients or having comorbidity patients, then you should think of keeping him in IPD. Fine. Then about this group 3, if you see here, there is a more than 3 points is there, then there is a high chances of getting mortality. Okay, fine. And here you need to manage in hospital a severe pneumonia, and you can even consider for ICU admission. ICU admission. Yeah, consider for ICU admission. More than 2, it is what it is 3. Okay, 3 and more than 2. Yeah, this is what. Then what is the strategy we will use, or what are the drugs we will use? For example, in a case of outpatient management, we know the patient is outpatient, so we won't give injectables much. So we'll give, most of them, they are the oral drugs. This oral drugs, previously we used to give only amoxicillin. Now we give 𝗏𝗏𝗀𝗏. We'll give this 𝗏𝗏𝗀𝗏. 𝗏𝗏𝗀𝗏 along with this macrolides like azithromycin, and along with this doxy. Okay, macrolides and along with this 𝗏𝗏𝗀𝗏 and doxy. Fine. And if the patient is having some comorbidities, for example, he's an old age patient or having some comorbidities, then we should consider giving some of this fluoroquinolones, like levofloxacin, moxie, and gemi. So all of them, they are this what? They are this respiratory fluoroquinolones like levo, moxie, and gemi. So it is what it is, the levo, moxie, and gemi. These are this respiratory fluoroquinolones, and we should give them, or we should add them if he's having comorbidities. Fine. Yeah. If there is detection of MRSA, like if there is none of this response, then we can think of MRSA. Right? Okay. So usually, like in a case of hospitalized patients, we can think of MRSA, and then we can start prophylaxis with vancomycin. Whereas in a case of OPD management, initially it should be the drugs, okay, which are used in a case of common populations. Right? And next, the inpatient management. In a case of inpatient management, we can give any of these beta-lactam antibiotics along with this macrolides or respiratory fluoroquinolones, and we can try the injectables as well. Okay. In this injectable forms as well, and if we need, we can give oxygen supplement. So these are the things you can use in a case of IPD management. So IPD management, it is especially for administering the drugs in IV line and along with this management of complications, because in some cases, if this pneumotocele, if rupture, then it can lead to pneumothorax. Then we need to be ready for the next step. So in such cases, to avoid complications, we'll make them in inpatients. And we know if the patient is old age and if is having like comorbidities, then they tend to regress very soon. So okay, they will desaturate very soon. That's why we need to have this inpatient management. So the aim of this 𝗏𝗃 score, it is to decide this inpatient or management, outpatient management or ICU management. So that is the goal. So they will give you this score, then you need to tell this is the management part. Fine. And next about this respiratory distress syndrome. In a case of respiratory distress syndrome, mostly they will ask you to diagnosis. Here you will be able to see this type of white out lung. Okay, white out lung. Okay, white out lung. Okay, there will be this around this ground glass opacities with this white out lungs. It is classically seen in a case of ARDS, acute respiratory distress syndrome. See, this acute respiratory distress syndrome, will call them when if there is any worsening of respiratory symptoms within 1 week of this clinical inset, we'll call them as ARDS. Okay, and here you will be able to see there is this bilateral opacities which is consisting with this, which is usually not consisting with this cardiogenic pulmonary edema, which is not consisting with this cardiogenic pulmonary edema, and it will be having this white out kind of appearance. Okay, here since there is no cardiac involvement, here the PC, pulmonary capillary wedge pressure, it will be always normal. So they will give this point. How about this pulmonary capillary wedge pressure? It will be normal in a case of ARDS. Okay, whereas in a case of cardiogenic pulmonary edema, it may be elevated. Fine. Then about this ARDS, if you see, there are few ARDS you need to think. The classification, it is based on the PaO2 or FiO2. It is based on this PaO2 or FiO2. If you see this PaO2 or FiO2 classifications, there might be mild ARDS, moderate ARDS or severe ARDS. The mild, here you need to see the ratio. If it is between 200 to 300, we'll call them as mild ARDS. If it is 100 to 200, we'll tell it is a moderate ARDS, or if it is less than 100 millimeter of Hg, then we'll call them as severe ARDS. They will give you these questions, like if there is a patient who is deteriorating within a week and the patient is having this PaO2 to FiO2 with a range of 200 to 300. So which of the following classification does this DRDS belongs to? Yeah, so it is what it is, this mild ARDS. It is the mild ARDS. Fine. So this is how they will ask in questions, and this is how you need to be answering it. Fine. That is how. Fine. We'll move on to the next part. And about this pleural effusion, we'll use this criteria to tell whether it is transitive effusion or exudative effusion. See, now you got a patient, or in question they classically describe, there is an X-ray given, and in X-ray you will be able to see this type of curve which is known as Ellis curve. If there is presence of this Ellis curve or along with this obliteration of this cardiophrenic angle, okay, see this is the lung, okay, just means when there is this lung, if there is any fluid collection, we know the dependent part, like whenever you pour some water, the water will go on this dependent part. If you see, the dependent part is here, so which is what, which is this cardiophrenic angle or costophrenic angle, okay, CP angle. So around this place, if you see, around this place only this fluid will go and collect. So if there is any fluid collection here, it will go on first affect this angle. That's why there will be this obliteration of CP angle, or there will be a blunting of this CP angle, remember. So this angle blunting will be shown because of this pleural effusion. So if there is any angle blunting, if it is small, it will show like that. But if it is a large collection, or if it is a large pleural effusion, it will be formation of this curve. This will be the X-ray and this will be the lungs. Here you will be able to see this type of curve formation. Okay, we'll see in a case of surgery, I will show you. It will be like kind of, it will be kind of curve which is known as Ellis curve. And this Ellis curve, if we see, then we need to know what is the reason for this pneumothorax, or what is the reason for this pleural effusion. For example, you got a case and you should tell, right, this is the cause for this pleural effusion. So in such scenario, we'll use this light criteria and we'll tell, this is because of this condition, or this may be because of this conditions. Means like, for example, like you saw this pleural effusion, now you took up a needle and you did this thoracocentesis and you withdrew some fluids, okay, and now you need to know whether these things will recur or what is the etiology for this. Once you treat this etiology, then only this will regress, okay. So decide this which type of pleural effusion will use this criteria, which is Light's criteria. So transitive means it is just water, whereas exudative means it is the water with proteins. It is water with proteins. Like for example, transitive means, remember, it is like a green tea, whereas this exudative means green tea with doodh, okay, green tea with the milk, or this normality with the milk. So remember, it is how the differentiating. So in a case of exudative, remember it is exudative, you will be having presence of proteins. In the case of exudative, you will be having the presence of proteins. Fine, and that is how you will differentiate. So see, as I told you, then in exudative there will be proteins. Okay, yeah, yeah. That is how, like, the example should be related to us. Fine, then only you will able to remember. Yeah, in there you will see, like, there is more protein. Matlab iska andar दूध है. Matlab there is a fat. So if there is a fat, then you will think of, yeah, it is exudative. It must be exudative. So if you see in the case of here, there is this protein. So if there is more protein, if the protein is more than 0.5, see, remember P for protein, P for punch. So it is the protein which is punch. So it is 5. So if you see, if this exudative pleural effusion, it is more than 0.5. Whereas in a case of transudative pleural effusion, it will be less than 0.5. Okay, then we need to consider this LDH enzyme. Okay, LDH enzyme, we need to do two things. First, we'll anonymously will measure, like, what is the level of LDH. If the LDH it is more than, then we'll tell it is an exudative. Then we'll compare this LDH along with our serum LDH. So if it is more than 2/3, then we'll tell it as exudative. Remember, exudative में सब कुछ excess होता है. ठीक है, exudative, the everything will be excess or everything will be more. Okay, so it is what? It is this exudative one. Yeah, that's true. Because of this protein parts, this exudative may form the formation of clot, whereas in a case of transudative, there will be no clot formations. Good, Dr. Puneet. Fine. Yeah, so remember, it is exudative, it is more than P for protein, P for punch, it is more than 0.5, whereas in a case of LDH, it is more than 0.6 and more than 2/3 of the serum protein. Okay, upper limit of the normal serum LDH. So itna yaad rakhna. Fine. So the examples include in a case of hypoalbuminemia, matlab when there is low proteins, the proteins will tend to hold the water. So agar proteins come hai, or if there is any liver damage, because of this there will be no protein protection. So in such cases there will be this transudative pleural effusion. So followed by which, for example, in a case of nephrotic syndrome, हम पढ़ेंगे उसमें there will be a loss of proteins. If loss of proteins, खून के अंदर प्रोटीन नहीं रहेगा. अगर खून के अंदर प्रोटीन नहीं रहेगा, means if there is no proteins inside the blood, then nobody will catch and hold the water. ठीक है, इतना याद रखो. Then in a case of congestive heart failure, the heart is unable to pump and there will be increase in this pressure which is known as osmotic pressure. Okay, osmotic pressure. And around the same for this case of constrictive pericarditis. Okay, whereas exudative means when there is inflammation. हमें पता है, when there is inflammation, the cells will go. Along with this, there will be inflammatory mediators and there will be protein secretions. So whatever inflammatory disease, then it will be there. Then like infections, the same inflammation will happen, like TB will be there. Okay, then about malignancies also, there will be increase in proteins, and rest all other conditions there will be increase in proteins. So itna yaad rakho. Fine. Yeah, TB, tumor infections. Yeah, good, Dr. Gautam. Yeah. In rheumatic arthritis, we'll see these things. Along with this, we'll measure this glucose level, doctor. We'll measure this glucose level in the case of rheumatic arthritis. Fine. Okay. Then about this, these are all things you should remember about this pleural effusion. Okay. If you're able to differentiate between this transudative and exudative, that is more than enough. Sometimes they will give you these points about this light criteria. Means protein more than 0.5, protein less than 0.5, LDH more than 0.6, and LDH more than 2/3 of this. All of this following are seen in exudative pleural effusion, except then you should choose protein less than 0.5. So it will be as dry like this, guys. Okay. Then we'll move on to the cystic fibrosis. Recently they started testing about the cystic fibrosis. Okay, mostly it will be asked from either pediatric part or medicine part, and what they will focus on this, you know, these things. What are this? How it will be diagnosed? Like there will be a history of chronic cough. And there will be a history of what? There will be a history of sinusitis, and there will be a history of bronchiectasis. So all of these things, they are the classical features for this cystic fibrosis. But now what they will test? Yeah, it is this due to the mutation of CFTR gene, which is located in the chromosome number 7. And we know this is an autosomal recessive condition. Yeah, good, guys. And yeah, when you kiss them, it will be very salty. Okay, when you kiss them, it will be very salty because the salt won't get into the secretions. Like for example, here very interesting part. Okay, we try to include this salt in secretions. लेकिन ये secretion में नहीं जाएगा, तो इसीलिए if there is no salt, there will be no water. So the secretions will be thick. Include sodium not included in salt. Okay, not included in salt. Okay, rectify. Else I will write clearly. If sodium is not entered or secreted in secretions. We know if there is no sodium, then there will be no water. So this mucus will be very thick. There will be this thick mucus. Whereas in a case of salt, it means in a case of sweat, if you see, it won't stop secreting, or if it won't accept the chlorine. So remember, it is salt, it is not secreting into the secretions. Whereas in a case of sweat, this salt will be more. So that's why we'll use a test which is known as sweat chloride test, and when you kiss them, it will be salty. They will be salty. Okay, so remember, okay, they won't be sweetie, they will be salty. Yeah, good guys. Yeah, salty baby. Okay, it is not rowdy baby, it is salty baby. Fine. And next, if you see the clinical features, like what are the diagnostic criteria I will use? Like it should be anyone, and along with this, any one of this. For example, there should be some of the clinical features. Like for example, there should be this bronchiectasis, there will be chronic infections, or there will be features of some infertility. And along with this, or either there will be history of cystic fibrosis in the sibling, or there will be a positive newborn screening. There will be a positive newborn screening for this cystic fibrosis. Okay, for newborn, we'll use this method which is known as immunoreactive trypsinogen. Remember, for infants, for screening, we'll use this test which is known as immunoreactive trypsinogen. Okay, it is the one criteria. Either there should be clinical features, or any of their siblings should be positive for it, or the newborn screening with this trypsinogen should be positive. So any of these three one. Okay, then any one of this following test, for example, either this sweat chloride test, which should be more than 60 millimole per liter, or on 2 or more occasions, or 2 mutations detected in the CFTR gene. Okay, and we know this is the CFTR gene, the mutation at the level of 𝗏F508. Okay, it is the most common mutation. So either there should be this sweat chloride test, it should be positive on 2 or more occasions, or there should be 2 mutation which is being associated with this CFTR gene, and we know the most common one, it is this 𝗏F508 mutation. And or else there should be one more potential which is known as nasal transepithelial. In nose, we'll keep between these 2 epithelium and we'll compare the potential. So it is known as abnormal nasal transepithelial potential difference. If they are positive, then any one of them will consider. So there should be one historical one, and along with this one test findings. Okay, this is the 2 things we'll use. Which one? Yeah, I couldn't get you, doctor. You were asking about nitroblue tetrazolium test. I guess that is NBT. We use in a case of chronic granulomatous disease, doctor. I guess if you are asking about NBT, fine. And next, for this treatment, we know we can give this enzyme replacement therapy, and also we can use this drug, which is the 𝗏𝗏𝗏𝗏. Like newborn screening test you were asking. I couldn't get it, doctor. Please brief your question. Right? And next, about this types of respiratory failure. Okay, there are 4 types of respiratory failure, out of which you will be always having this confusion between this type 1 and type 2. See, the type 1, it is this hypoxemic, means there will be a decreased level of oxygen. Okay, whereas in type 2, it is this hypercapnic, there will be increased level of carbon dioxide. Okay, so if you see here, there will be a decrease in carbon dioxide here, but there will be decrease in oxygen, which is the main pathophysiological mechanism in the case of type 1 respiratory failure. So remember, it is type 1. Why it is kept type 1? Because oxygen is more important than carbon dioxide. That's why if it is less oxygen, it is classified as type 1 respiratory failures. Fine. And if it is type 2, it is what? It is this hypercapnic or increased CO2. Which of the following trick, Dr. Sonali? Then if you see, in the case of type 1, as I told you, it is decrease in oxygen. In which of the following there will be decrease in oxygen? For example, if it is related to the lungs, if any disease which is being related to the lungs, then there will be what? There will be decrease in oxygen exchange or diffusion of these gases. So what are the diseases which is related to this lung parenchyma especially, which includes this pulmonary edema, where there is fluid collection, or there is ARDS, or there is recently studied pneumonia, or any pulmonary hemorrhage, or any collapse of the lung. So all of them, they are this pulmonary parenchymal problems which causes at the parenchymal level, so that if there is any issues, then this oxygen or this gas, they won't diffuse into this blood, so there will be decreased oxygen. So it is known as type 1 respiratory failure. Okay, whereas in the case of type 2 respiratory failure, there is what? There is increased carbon dioxide. We know carbon dioxide has been, it should be come out of the lungs. But in some cases, for example, if the patient is not respiring or using his muscles completely, then some of this carbon dioxide may reside in. For example, this neuromuscular disease, or if there is any disease where there is this increase in this dead spaces, for example, or increase in this lung volume. So especially the COPD and bronchial asthma. Okay, so it is type 1, that is decrease in oxygen and parenchymal pathology, whereas type 2 where there is increased carbon dioxide. Remember, fine? Yeah, due to decreased washout. Yes, yeah, simply to tell, yeah, decreased carbon dioxide washout. Yeah, for example, yeah, diaphragmatic palsy, we cannot respire and we cannot push out all the carbon dioxide to the outside. Fine. In a case of type 3, it is especially, it will be associated with this post-operative. It will be post-operative respiratory failure. Whereas type 4, it is due to the decreased perfusion. Okay. For example, in a case of coma or shock, okay, the muscles of these respirations, they are given with less blood supply. So it is what? It is this type 4 which is due to this decreased perfusion or in a case of shock. Okay, remember. Next, these are the few important topics you should know from this respiratory system perspective. Then we'll move on to the next part, which is this CVS part. Yeah, like GBS and transverse myelitis. Yeah, correct, doctors. Do you have any doubt in it? Yeah, guys, do you have any doubt? Yeah, type 4 will give this IPPV, means positive pressure ventilation, and we need to treat the shock or treat the reason for the shock. For example, if it is hypovolemic shock, तब हम क्या करेंगे? We'll give this fluid resuscitation along with this blood replacement. Fine. So इतना ही है. Fine. I guess the things are going well. Like there will be a bit confusion, or on medicine, most of the questions it will be simpler. Okay, it will be simpler. Like there will be 80% of the questions it will be simpler, and you should use your common sense. Okay, so while going to your examinations, don't keep your common sense outside the exam hall. Just try to bring them into the exam hall and don't overthink it. If your common sense tells, yeah, it is the answer, it will be the answer. ठीक है, ज़्यादा बिल्कुल नहीं सोचना है. ठीक है, don't overthink and postpone it. Think the necessity points and think at the very basic level. Think at the very basic level. ठीक है. Which type of oxygen therapy? For example, it is based on the stage, doctor. For example, if the patient is not maintained, if the patient first time is coming, then we'll see in anesthesia, we'll give this nasal prongs, like nasal cannula, we'll call them as. Then we'll give the oxygen mask. Then we'll check the saturation point. And if it is not improving, then we'll proceed with this next steps. For example, next we'll give with this NRBM mask. Then we'll give with ventri mask. So it is the stages. If the patient maintains, then we'll go. If not, we'll go for the further management, doctor. Okay. This oxygen management we'll see in tomorrow part. Anesthesia, I have the images, I will show you back. Okay, don't worry. Have some patience. Fine. Yeah, fine. We'll move on to this very important part because there will be one questions for sure, either from medicine or we can call it is from the physiology part. Okay. जैसे आपको मीन्स जिसको आपको क्रेडिट देना है आप दे दो, कोई दिक्कत नहीं है, लेकिन there will be one question, but make sure you are doing it correct. ठीक है. There are this JVP findings, means there is this jugular vein and this pulsations, it is due to this changes in the atrium, especially in the right atrium. Okay, what is the right atrium changes? Which whatever will be the changes, it will be shown to this JVP. Okay, it will be shown to this JVP. So what are the changes we can see? For example, there will be this atrium. Okay, there will be this heart and will be this atrium. So we know during this atrial systole, क्या होगा? Atrium will contract. So if the atria will contract, then what will happen? This contraction will cause some backflow of this blood. This contraction will cause some of this backflow of this blood. So it is known as what? It is known as A wave, which is due to this atrial contraction. Fine. Once atrial contractions, we know, then what will happen? Then this atrial blood will go to this ventricle. Okay, it is the final push. So the atrial blood will go to the ventricle. So then the pressure of the atria will decrease. That's why it is mentioned as X. Okay, X. Fine. Then followed by which it will go into the ventricle. So we know it will initially, ventricle will be in diastolic phase, and when ventricle gets filled by this blood, okay, there will be this passive and active. Then when ventricles will be filled, then it is the time for the ventricle to act. Okay, now today I'm telling you, today I'm teaching you, then it is your point for tomorrow to go and to revise and to solve questions and make them to be replicated into your main examination. अगर सिर्फ मैंने तुम्हें information दिया लेकिन तुमने उसको बिल्कुल इस्तेमाल नहीं किया, then you won't be able to get the questions right, and the main exam, it also, you also get the things correct in the examination as well. So इसीलिए whatever things you should have, you should go and replicate on the next day as well. So the same thing, when atria contracts and gives blood, next it is the ventricle turn to contract. So when the ventricle will contract, okay, when the ventricle will contract, okay, I will draw a big diagram. So when the, so if you see, it is the right atrium and this is this jugular vein. Okay, okay, this is this superior vena cava which is being in contact with this jugular vein. Just remember, see, so initially when it contracts, it will give some push, it will give some push, so that some back flow of blood will happen. Okay, so some, that is the A wave. Then when after this the blood will flow from here to there, so there will be decrease in pressure here, so it will pull like this, so there will be decrease in pressure. Then followed by which the next stop, it is this ventricular one. So when ventricular contracts, then there will be this cusp will be there, okay, which is the tricuspid valve, and this cusp will start bulge. Okay, when it bulges, it will increases the pressure here. Okay, pressure will be increasing, so that's why it will be manifesting as this next wave, which is known as C wave. So it is a small wave, but it will be showing its potential. So it is the tricuspid valve bulge. Okay, okay, fine, it is the tricuspid valve bulge. Next, what will happen is that then once ventricle contracts, you know, this, after this ventricle contraction, the ventricle will relax. Okay, so during this ventricle contractions, okay, this right atrium will start filling with this blood, okay, because of its negative pressure, and followed by which what will happen, then there will be more blood, will be coming into this right atrium. When there is negative pressure, this blood will start coming. When the blood will start coming, then there will be at certain space that right atrium will get filled, and it will be reflected. It will be reflected back as an increased pressure. It will be reflected back, means filling up this right atrium against the tricuspid valve will be showing this V wave, and followed by which the same will happen. Okay, then the right atrium will open. Right atrium will start filling this ventricle with a passive filling. Will this passive filling once the AV valve opens. Okay, so initially the atrial contraction, then the atrial contraction will lead to this flow of blood, so it will cause this X descent. Then there will be this ventricular contraction will causing this cusp to bulge, then which will be evaluated, or which will be shown as C wave, then followed by which then there will be this negative pressure generation, so the atria will come down, then atria will start filling, that is this V wave, then followed by which filled atria will cause filling of this blood into this ventricle. So it is this Y descent. Okay, this is the simple examination or simple explanations what I can give. Okay, so understand in this mind, so whatever the pathology wherever lies in, it will cause Dr. Atria contracted after ventricular, then ventricular relax. Yeah, first see, the ventricular will be in always in relaxed state. Okay, this when there is a relaxation, then only the blood will start fill, right? So there are two ventricular fillings. One is this passive filling, followed by this there will be active filling. Passive filling means ventricular का मतलब बहुत negative pressure हो जाता है, तो इसी वजह से it will just start coming by its own only. Okay, लेकिन there will be some कुछ blood रह जाता है, means there will be few blood which will be stopped there. So this few blood will be sent into the ventricle via this atrial contraction. So via this atrial contraction, लेकिन ये दोनों time, like during this passive filling and active filling, both the times the ventricle will be in diastolic phase. ठीक है, इतना आपको याद रखना. ठीक है, repeat sir. Fine. Just or else I'll just tell you simply. Okay, one more time. Okay, for the last. If you see, there will be this heart. Okay, okay, there will be this heart. Remember, it is in ventricle is in relaxation. Okay, ventricle is in relaxation. Okay, when the ventricle is in relaxation, remember it is in relaxation phase, then the atria will be filled by this blood. Okay, atria will be filled by this blood, and ventricle relaxation, it has two phases. One is this passive filling, next one it is this active filling. Okay, during this passive filling, there will be more pressure, there will be more negative pressure in ventricle. So अगर negative pressure है, तो it will start pulling the blood by its own. So this is known as passively. Okay, but there will be few blood which will be left over. There will be few blood which will be left over into the ventricle, and this leftover blood will be sent to this ventricle by atrial contraction. So this is known as leftover blood will be sent by this atrial contraction, and this atrial contraction will be showing this rise in pressure which is known as A wave. ठीक है, A wave. फिर उसके बाद क्या होगा, जैसे A wave हो गया, फिर उसके बाद then this there is no blood in here, right? So and final blood also will come down. तो उसी वजह से there will be X descent and followed by which there is a filling. ठीक है, मान लो इधर fill हो गया, तो same thing I am just repeating here. The one it is filled, then the ventricle will contract. So diastole तो हो गया, then the ventricle go into the contraction. Now it is relaxing, now it go into contraction. So once it contracts, this cusp will be there. This AV valve will start bulging to this AV or to this atria, and it will be manifesting as increasing pressure. That is this C wave. Okay, and followed by this ventricular contraction. जिससे ventricle contract किया तो blood it will go into this aorta. Okay, blood it will go into this aorta. This side it will go into this pulmonary artery. So once this blood goes, then the ventricular will become negative pressure. Then it will एक नीचे खींचेगा. Then when it will pull down, then this blood from this JVP it will come into this atrium. It will come into this atrium. So once the blood come into the atrium, it is this X dash, and it will be start filling. And after some level, this will start showing the resistance. That is this V wave. And all followed by this, when there is atria will be more pressure, and तो automatically नीचे का दरवाजा open हो जाएगा, ऊपर से नीचे blood गिरेगा. Okay, then the blood will start coming downside. Then it will repeat again. So this is one. This is the simple one. So ventricular contraction and ventricular relaxation आपको थोड़ा बहुत समझ में आना चाहिए. अगर मोस्टली अगर आपको ये थोड़ा फिर भी confusion हो रहा है, just rewatch this time step for after the class. Okay, fine. So if there is any disease or if there is any condition, okay, related to this waves, it will result into this abnormalities. For example, if the atria is not contracting, then there will be this absence of this A wave, which is what, for example, it is fibrillating. It is not just shaking, and it is not contracting. So as it is not contracting, it won't produce the A wave. So absent of A wave will be produced in a case of atrial fibrillation. I guess you got it, guys. Yeah. Right. Next, about this large A waves, means the A wave is constricting with lot of force. For example, in a case of pulmonary hypertension or any pulmonary stenosis, it is constricting against a strong force. That is this large A wave. Then canine A waves, when both of them, means I told when atria is contracting, the ventricle should be in relaxed phase. Okay, when contracting, ventricle should be in relaxed phase. लेकिन दोनों साथ में कर रहे हैं, then if it is contracting together, then like it need more force, then it will be showing this canine A wave. It will be showing this canine A wave. Then about this large V waves, it will be happening when there is no proper closing. It leads to this opening of this valve during this ventricular systole, that is known as tricuspid regurgitation. Okay, large wave will be seen in a case of tricuspid regurgitation. Then if there is any rise in JVP, in a case of constrictive pericarditis, the rise in JVP during inspiration only, it is known as 𝗏𝗏 sign. It is known as 𝗏𝗏 sign. Then that is what? Okay, 𝗏𝗏 sign. So this is the normal A wave, normal C, normal V wave. Whereas here, if you see, because of this non-synchronous contraction, this produces this type of wave which is known as canine A wave, which is seen in a case of complete heart block. Okay. Next, C for C, remember, C for C, canine wave will be seen in a case of complete heart block. Okay, इतना याद रखो. Then G and CV wave. Okay, this CV I told it is because of the cusp bulge, and V it is after this filling one. Okay, so but in a case of tricuspid regurgitation, the tricuspid valve it's closing. So this if it is not closing properly itself, then the blood will start coming here. So there will be no delineation between these two waves. That is known as G and CV waves will be seen in a case of tricuspid regurgitation. इतना याद रखो. Then about these two conditions, mostly they will ask, and here only you need to diagnose. Okay, this is this cardiac tamponade and the constrictive pericarditis. For sure, there will be one question based on these findings, either medicine part, either surgery part, or about the physiology part. If you see constrictive pericarditis, it is this calcification of this pericardium, which is due to this chronic TB. Okay, or this previous past history of TB, this calcification of pericardium. Okay, pericardium. Okay, remember. And here only, so here they will ask you, how will you differentiate between the JVP finding of this constrictive pericarditis and this cardiac tamponade? Okay, तुम्हें बस you will have a strong mindset, but when you see a question, you will try to mark them wrong. So उसके लिए तुम्हें याद रखना है, कार्डियक टेम्पोनेट के लिए देयर विल बी ए एब्सेंट y, तो इतना याद रखो, बस एक ही वर्ड याद रखो ताकि you won't get confused. The absent y will be seen in a case of cardiac tamponade. Absent y will be seen in a case of cardiac tamponade. Then if you see, then opposite will be happening in a case of constrictive pericarditis. So in a case of constrictive pericarditis, there will be deep X and deep Y. Okay, deep X and deep Y. Okay, or both of them X and Y will be present in a case of constrictive pericarditis. इसका मतलब है अगर कार्डियक टेम्पोनेट में y एब्सेंट है, इसका मतलब है कंस्ट्रिक्टिव पेरिकार्डिटिस में दोनों प्रेजेंट है. ओके, deep X and deep Y will be present in the case of constrictive pericarditis, whereas in the case of cardiac tamponade this y wave will be absent of y wave, or we'll call them as absent y descent. Okay, absent y descent. तो इतना याद रखो ताकि कंफ्यूजन आपको ना हो. ठीक है, या yeah, that is what. So but you tend to, it means if I tell you like there is a x descent present or in-depth x descent or prominent x descent, y descent, means you will get confused. तो इसीलिए मैं बोल रहा हूँ just remember one word so that you can mark the answer correct. At the end of the day, it is not your concept. Okay, it is not your concept, you know, like you cannot tell the computer I know this concept, make this thing right. No, at the end of the day, if you mark these questions correct, you will get this 1 mark. You can come out from this 149 to 150. Okay, that is why we are learning now. Fine. Then about this cardiac tamponade, it is mostly happen in a case of traumatic situations. If you see, this will be this shaped. It is known as water bottle stomach, water bottle heart. Okay, water bottle heart. Okay, here you will able to see there is a presence of this 3 triad, which is known as hypotension, and because of this fluid collection there will be this muffled heart sounds, and along with this JVP, which causing this congested neck veins. Fine. And as I told you, here you need to know just one thing, which is absent y descent, whereas X will be present, which will be steep or in depth in nature. Fine, just remember one thing. And X-ray will showing this water bottle appearance or this money bag appearance. तो इतना याद रखो ताकि आपका क्वेश्चन सही हो. ठीक है, then we'll move on to this few ECG findings. If you're able to see here, usually after P wave there is this PR interval, then followed by this QRS complex. लेकिन if you see, instead of this atrial contractions going properly to this ventricle via this AV node, it means you know that SA node, it will pass through this AV node, then the conductions will move on. Whereas instead of moving like this, if we are having this accessory pathway and going and giving directly to this ventricle, it is known as Wolff-Parkinson-White syndrome. And we know this PR interval, it is because of this AV nodal delay. But if we have any accessory pathway like bundle of Kent in a case of Wolff-Parkinson-White syndrome, then there will be a decreased PR interval that is known as delta wave. याद रखो, this is the delta wave. Okay, this is the delta wave. Remember, like dancing jugular vein, like mostly we'll see that is a different one, that is a dancing carotid we'll see. Okay, that is a regurgitation. In a case of regurgitation, like tricuspid regurgitation, we'll see, guys. Okay, just check it out. Okay, it is not jugular vein. Next, here the ECD findings will be short PR interval. Okay, as I told you, because of this fast conduction. Okay, but here if you see, this PJ interval will becomes normal. Here the PJ interval becomes normal. Why? How? Because there will be decrease in PR interval, but QRS complex, because of this delta wave, it will be increasing. So it will neutralize this thing. So that's why there will be PJ interval will be normal in this case of Wolff-Parkinson-White syndrome. So, and for these conditions, you can do a definitive management. Means what you can do is that you can ablate this extra pathway. You can remove this pathway by this alcoholic ablation, or also known as radio frequency ablation you can use, or else you can give some drugs, but like procainamide to treat or flecainide to prevent it. Yeah, there is this wide QRS complex and short PR interval. That is the two things, wide QRS complex along with this short PR interval. That is the final route. Then we'll move on to this heart blocks. Okay, if you see this, usually as I told you, there is this P wave, PR interval, QRS complex and T wave. If you see about this heart block, in the case of heart block, mostly it happens at the level of AV block. So as I told you, AV, it will cause this delay. Okay, so if there is any AV block, then it leads to this increase in PR interval. Just this PR interval will be increased. Okay, increased. Whereas based on this increase in the PR interval, it will be decreased. It will be differentiated into different types. For example, if we just increase in PR interval, then there is no any problem with this beat. All of these atrial contractions are being transferred into this ventricular contractions, then there is no issues, right? Whereas in the next degree of blocks, there will be this contractions, means this impulses will be shared, but one of them will be missed, okay, or few of them will be missed. So based on it, we'll classify it in few different types. In the case of second degree AV block, there are two types, which is known as Mobitz type 1 or also known as 𝗏𝗏𝐵𝑎𝑐S phenomena or Mobitz type 2. In the case of Mobitz type 1, remember, it is the longer, longest. It is the first there will be a small, then there will be increase. So it is the longer and longest. Okay, so there will be a progressive increase in this PR interval. There will be this progressive increase in the PR interval, and along with this there is a drop bit. Okay, there is a drop bit. See here, there is this PR wave, this is the T wave and this is the P wave, and again the P wave starts. There is missing of QRS complex is missed. QRS complex is missed. Okay, this is how this Mobitz type 1 block is. Next, if you see in a case of second degree AV block, okay, like a Mobitz type 2, if you see, there is this increase in PR interval. Okay, or sometimes it looks normal as well, but there is a drop bit. There is a drop bit. Means it is not progressively increasing. It is there is already constant. So if there is a constant increase around the normal, and along with this a drop bit, we'll call them as Mobitz type 2 type of block. It is Mobitz type 2. Then about this 2:1 block, means the atria is contracting twice, whereas this ventricle is contracting only once. So see here, this P wave, then again P wave, but only one P wave is being transferred into a QRS complex, whereas one it is getting waste. So it is known as 2:1 block. So 2 P waves to the ratio of 1 QRS complex. Okay, then we'll see about this third degree AV blocks. Third degree AV blocks means U and UIX. Means previously you have in relations, but now you don't have no relations. Means कोई बिल्कुल कोई लेना देना नहीं है. Means if there is no relations, means P wave can come by its own and QRS complex will come by its own. Okay, or anyone and their X. Okay, so there is no relations between this P wave and QRS complex. No relation with P and QRS complex. A good doctor 9 and QRS complex. Okay, fine. That is what that you need to remember. Fine. We'll move on to the next part about this cardiomyopathies. Usually this cardiomyopathy, especially they will ask about this HOCM. In HOCM, they usually have this history of this young athlete who is going for this sprint run of 200 meters. While running, means he want to show this attitude, so he is running very fastly, but suddenly he collapses into the ground. So he suddenly collapses and on spot he dies. Collapses and he dies. And it can be associated with this family history as well because of this chromosome 14 involvement. So in the case of HOCM, it is what? It is hypertrophic obstructive cardiomyopathy. So it is obstructing the flow of blood. Okay, it is obstructing the flow of blood, remember. And here if you are able to see, there will be two things. There will be this septal hypertrophy along with this left ventricular hypertrophy. Okay, leading to this left ventricular outflow tract obstruction. It will be causing this left ventricular outflow tract obstruction. Okay, when there is no outflow of blood, obviously the patient will go into hypotension, then followed by this arrhythmia, and the patient will die on the spot. Okay, on the spot they will die. Yeah, the murmur will be increasing and will survive. Correct, guys. Okay, remember. Then if you see, this is the increase in this septal wall and this ventricular wall will be increased. Next, there will be this banana shaped cavity. Okay, there will be this banana shaped cavity, and the defect, it is what? It is not because of mainly the systolic one. The defect is this, mainly it cannot hold much blood, and on long run it won't even pump that small amount of blood as well. Fine. Yeah. Next, it will produce this is ejection systolic murmur. Okay, ejection systolic murmur. Along with this, it will show on echocardiography. If you see, this is this left ventricle and aorta atrium. Okay, whereas if you see here, there will be this abnormal anterior wall motion. So this is abnormal anterior wall motion will be seen in a case of systolic anterior wall motion will be seen in a case of HOCM. Will be seen in a case of HOCM. Yeah, good doctor Naresh. Then what is the treatment we'll give? We can treat by either starting with beta blockers, or else we need to do this implantable defibrillator. Okay, implantable cardioverter or defibrillator, so that we can, when there is a development of this arrhythmia followed by this event, then we can defibrillate and we can bring them into normal. Fine. And here we can remove this septum by this alcohol-based myomectomy. And on biopsy, if you do, you will see this type of haphazard proliferation. Haphazard proliferation of myocytes, which is known as helter-skelter appearance. Helter-skelter appearance of myocytes. Yeah, good guys. Fine. We'll move on to this next part, which is this dilated cardiomyopathy. Mostly it is seen in a case of due to titin mutations, and it produces this double beating pulse, which is known as dicrotic pulse. Okay, double beating pulse which beats in both systole and diastole. It is known as dicrotic pulse. Then this restrictive cardiomyopathy, it is due to this 𝗵𝗶 gene mutation and seen in a case of amyloidosis and sarcoidosis. And here we will also see this Kussmaul sign, which we saw in a case of constrictive pericarditis as well. Fine. And next, if you see, there is a syndrome which is known as Naxos syndrome. There will be presence of this right means arrhythmogenic right ventricular tachycardia, and along with this there is a presence of woolly hair and hyperperitosis of this palms and sole. So this is known as Naxos syndrome. Then about this important point, which is this MI. Okay, in MI mostly they will ask you about this diagnosis, management, and sometimes they can ask you about this complications part as well. Fine. So to diagnose a MI, there will be this few features, like there will be this STEMI and non-STEMI. Means there will be ST elevated MI and non-ST elevated MI will be having this T wave inversions. Fine. Along with this ST elevated MI, you will be able to see there is this hyperacute T waves or hyperacute T waves. Then about this management part, now the management lies primarily on this PCI. Okay, PCI intervention means this PCI intervention only. But previously, arrhythmogenic right ventricular tachycardia, I guess. Yeah. Then about this PCI means we decide means about this MI part, we started mainly with this PCI. Okay, previously we used to have like thrombolysis karenge, फिर उसके बाद ही PCI करेंगे. Now the primary management is PCI. Okay, percutaneous coronary intervention. ठीक है, अगर if there is no availability of this, फिर उसके बाद ही हम जाएंगे कि thrombolysis करो. Okay, so that is the thing. So primary management, it is the PCI part. Fine. Where there is cath lab facilities available, and it should be done, it should be done within the 90 minutes. This is the 19 minutes of patient in contact with this medical services. So door to balloon means it is the balloon, matlab उड़ने वाला balloon नहीं है, it is what it is, this angiography balloon. Okay, so the door to balloon time, it is क्या, it is this less than, it should be less than 90 minutes, means less than 1.5 hours. ठीक है, अगर आपके पास PC available नहीं है, you are in the very periphery, then you should be having this, you should be doing this thrombolysis. तो पहले हम क्या करते थे, thrombolysis के लिए हम streptokinase use करते थे, लेकिन yesterday we studied, we use this tissue plasminogen activators. Okay, file altiplase retiplase will use for this thrombolysis क्योंकि उसका side effects कम है. Then to treat this features of acute MI, will use this MONA or MON. Okay, MONA. Yeah, good Dr. Anar, good Dr. Gautam, good Dr. Rahul. Yeah, so this includes our metoprolol, which decreases this oxygen consumption. Okay, which decreases this oxygen consumption of this heart, so that it will produce some relief. Then we'll need to give oxygen because there will be ischemia, so we need to give oxygen, or if there is a SpO2 is less than 93, then we need to supplement with this oxygen as well. Then we need to give this first management. First thing we want to do is this, giving this dual antiplatelet therapy. One is this aspirin along with this ticagrelor. Okay, ticagrelor. Okay, then about this, giving this sublingual nitroglycerin. So it is metoprolol, oxygen, sublingual nitroglycerin, and the first one, it is the antiplatelet, which is dual antiplatelet therapy, including aspirin and ticagrelor. Aspirin and ticagrelor. Fine. And next, based on the place of this infraction, or based on this elevation of this ST segment, we'll call them as different types of MI. Agar if it is involving this inferior leads, where we'll say it is inferior. Remember, we'll start from this anterior one. Agar if it is anterior wall, you should be always, you should means I will call them as anterior septal if it is involving from V1 to V4. Then lateral wall, remember the lateral wall, it is what it is, V5, V6. Yeah, V5, V6 and the first lead. V5, V6 and the first lead, it is the lateral one. Whereas inferior what? Inferior is the 2, 3 and AVF. 2, 3 and AVF. And these three are the what? Are these leads you should remember of. Like if mostly they will tell it is anterior and septal MI. Yeah. We used to use clopidogrel, and we have been using means for PCI we need to use some of this cannula and do, that's why we are using ticagrelor. Okay, and we can also use clopidogrel, and then we know in loading dose itself we can use clopidogrel, fine. And next, so that's why they will give you which type of MI is this. And just remember one point, in a case of inferior wall MI, this inferior wall MI will present with hypotension. Okay. Rest MI also can present, but one of the peculiar features of this inferior wall MI, it is the presence of this hypotension. Okay, hypotension, yeah. Mostly they won't ask you about the dose, doctor. Don't worry about the doses, fine. And if you see this one, can anyone tell me where is the location of this MI? Or which leads are being elevated here? It is which MI? Anterior wall, lateral wall, and or inferior wall MI? Yeah, good. It is what it is. This involvement of this V1, V2, V3, 4. It is what? It is this anterior wall MI, especially V2, V3, 4, which is this anterior wall MI. Okay, good guys, good. Okay, that is how you will diagnose this one. Okay, yeah, you can see this. Yeah, that is good. Yeah, good. You are having this eagle eye, Dr. Gautam. You will be able to see this reciprocal changes in this inferior leads. But as of now, you don't confuse with this reciprocal changes. Okay, reciprocal changes, if you know, it is well and good. If not, just try to identify which type of MI is this. As I told you, they will ask you very simple things. तुम्हें simple चीज बिल्कुल याद होना है. Okay, don't use huge brain and make small things mistakes, but try to use your good brain when it is necessary, but try to be keeping things as simple as this. Good. Okay, good, doctor. Fine. Then we need to diagnose this arrhythmia. If you see this image, you will be able to see. Yeah, good, Dr. Ambika. Yeah. If you see this, next, this is how a normal sinus rhythm looks like. And if it is just ventricular arrhythmia like this, which is in this patient, it is this ventricular tachycardia. And in this case also, we need to do defibrillation. Okay. Yeah, good, Dr. Puneet. Yeah, good, Dr. Gautam. You have this nice common like that. Time of sense you have, fine. Then about ventricular fibrillation, there is no any proper beats, but it will be having this fibrillation. So it is this ventricular fibrillation. Next, about this PVC, premature ventricular contraction. For example, there will be means in the case of PVC, they won't ask. If they ask, they will tell there is a patient of MI and who is presented with this ST elevation. Now after thrombolysis, you will be able to see this type of ventricular complexes. So it is known as what? It is known as premature ventricular complexes. It is known as premature ventricular complexes. So, itna yaad rakho. Next, this sawtooth pattern, which is seen in a case of atrial flutter. Then about this atrial fibrillation, you will see this fibrillatory waves with absent of P waves. Means the P waves are being absent. If we saw the atria is fibrillating. So since atria is not contracting, there will be no P wave, and since atria is not contracting, there will be no A wave in JVP as well. So no P wave, no A wave. दोनों चीज याद रखना. Okay. So in a case of atrial fibrillation, जैसे आप देख रहे हो, there will be this irregular. It won't. Their RR interval will be regular. It will be irregular in nature. ठीक है? मतलब same बिल्कुल नहीं है ना. So there is irregularities. So irregular RR interval along with this absence of P wave. It is a typical for this atrial fibrillation. तो इसके लिए हमें क्या क्या देना होगा? Means atrial fibrillation मतलब the heart rate also will be here, will be more, like more than 120 will be there, like around 150, 160 can be. Okay, based on the ECG will tell. And here for rate control will use esmolol. And here there is a high chances that atria is not contracting, so there will be a high chance of stasis. So if there's blood stasis, then we know this, it can lead to the formation of clot. So to prevent formation of clot, we'll give warfarin, anticoagulants like warfarin. Then we'll do this chemical cardioversion. We'll convert this fibrillatory waves into normal contraction by this chemical cardioversion. We know whatever this atria is there, then we can use this calcium channel and potassium channel as well. So this amiodarone, which is a potassium channel blocker, which is most commonly used, can be used in a case of atrial fibrillation. फिर उसके बाद if nothing settles down, then we can give a shock, then will prevent or will cause this atria to contract into the normal phase. So it is known as electrical cardioversion. So initially the chemical cardioversion by this amiodarone followed by this electrical cardioversion. ठीक है, इतना याद रखो. Yeah. So how will you diagnose? There will be no proper P wave. See, there is no proper P wave. Okay, it is not P waves. They are this fibrillatory waves. ठीक है, कोई so fibrillatory waves along with this absence of P waves, and there will be irregular RR interval. So irregular RR interval. Fine. Next, if you see this type of waves where there is hidden P waves, or like it looks like there is absence of P waves, then there is this presence of regular. There is this regular or constant RR interval with, we'll call them as narrow complex tachycardia. Narrow QRS complex tachycardia. So all of these things, the constant RR interval along with this narrow complex tachycardia and P wave which is being masked, which is looking like there is no P wave. So all of these things, they are classically for this paroxysmal supraventricular tachycardia. And we know in a case of paroxysmal supraventricular tachycardia, we'll see how the patient is presenting in. If the patient is conscious or unconscious, पहले तुम्हें देखना, ठीक है? ऐसे नहीं कि the patient came, you started defib. No, if the patient is conscious, then we'll start with the first one, which is this carotid sinus massage. If the patient is conscious or with his vitals are stable, fine. Then we'll start with carotid sinus massage. If with carotid sinus massage, if the patient is not cooperative or if it is not improving, फिर उसके बाद हम चलेंगे adenosine पे. We'll give adenosine 6 followed by this 12. Then if it is not managed with adenosine, फिर उसके बाद हम छोटा सा shock देके उसको revert करेंगे. We'll give small shock and we'll revert this arrhythmia into a normal rhythm. ठीक है? This is in a case of if the patient is vitally stable. ठीक है? Whereas if the patient is crashing, the patient is brought to just now and he's in structure. Okay, it is in he's in structure and you don't know what to do and the patient's vitals are non-recordable. So in such cases, you will start with this synchronized DC shock because you won't know when to give, right? So you will tell the machine, yeah, when you find this rhythm, just give this beat, give this shock. Okay, that is known as synchronized DC shock. Yeah. So adenosine initially will start with 12, then 12, 6, then will followed by this 12. Remember. Fine. And this adenosine can cause bronchoconstriction. So one of the complications or one of the side effects which we can be seen here, it is the bronchoconstriction. Itna yaad rakho. Next, about this MAT, which is known as multifocal atrial tachycardia. So why this is called MAT? Because this is more than ek jaise nahi. For example, you see some movies, right, where the actors will act with different, like one they will be having this mole and without mole one action. Okay, when one there will be a gray hair, one there will be a normal hair. Likewise, here the P waves will be having different morphologies. Like an onion, this will be keep on changing its face. Okay, so this is what this is. This multifocal atrial tachycardia. अगर आप देखोगे, ठीक है, we'll call them as Aprachit. Like you know this Aprachit movie, right, where he keep on changing. Likewise, this P waves keep on changing. Okay, so here there will be history of usually the CVOPD will be given. So एक देखो, there is no proper morphology of this P wave. Okay. एक ऐसा है, फिर एक ऐसा है, तो एक ऐसा है, तो see there is no proper formation or there is no proper P wave formation. So if 3 of this P waves in a strip rhythm or a rhythm strip, which is the second lead, if they are not equal, if they are not same, then we'll call them as multifocal atrial tachycardia, and it is most commonly seen in a case of COPD patients. Okay, itna yaad rakho. More than 3 different varieties of P waves. Fine, yeah, good. Then इसके लिए drug of choice भी 𝗲𝗵। Okay. Then we saw this atrial flutter, where the same sawtooth pattern we saw, and for this also we'll use this rhythm control esmolol, anticoagulants, and ibutylite and low intensity DC shock. So these are the important topics from this CVS part you should remembering. Okay. And about renal part, you make sure you are reading at least this one because they will ask mostly from this. Sometimes they will go and test very few new topics. And make sure you are reading this ABG analysis from the physiology part. Okay, that is from this renal part. If you see about this staging of the CKD, they will ask about, like, if the GFR is 90, what is the stage? If it is what, it is the stage 1. So it is what, it is 30. Next, minus it to 30, it is stage 2. Then minus it to 15, 15. So stage 3, stage 3B. Then minus it to again into 15. Okay, it is 30 to 15, it is stage 4. And if it is less than 15, we'll call them as stage 5. Okay, see these are the stages of this chronic kidney disease, how they are being staged. Okay, so just have a orientation. Next, about acute kidney injuries. Like acute kidney injury means the kidney is getting injured. They will ask you what is the etiology of this injury. For example, kidney is getting injured because of some factors causing injury to the kidney or किसी और की वजह से. Means, for example, you will be living in a room, okay, where you will be disturbing your friends. Okay, you will be disturbing your friends, and because of you, your friend will not be studying. Okay, because of you, your friend will not be studying. So here you also not studying, and your friends also not studying, and your friend is not studying. It is because of you. So whatever changes happening in the kidney because of others, it is known as pre-renal or before the renal, or there will be some post-renal change also, but we'll usually converse between this pre-renal and renal. For example, if there is a decreased blood supply, is it the problem of kidney? Is it problem of kidney? No, right? It is the problem of this shock, or this if there is any cardiac problems, or if there is any hypovolemic shock, then there will be decreased blood supply, obviously. So it will come under this pre-renal cause. Okay. Surgery break ke baad. Okay, we'll start like almost it will end around 12. We'll have a break around 12:15. ठीक है, 12:15 12:20 से हम सर्जरी शुरू करेंगे. Okay, right. So this is the plan. Okay, अभी के लिए यही तो plan है. ठीक है. Then so remember this is the pre-renal and renal part. So renal part, so pre-renal, see if there is less blood coming, so your kidney is perfectly okay. You are perfectly okay. You give me 4 chapters or you give me 4 topics, I will read and tell you. Okay, so you are perfectly fine, right? Your friend is disturbing you here in a case of pre-renal. Friend is disturbing. So whatever you give, you will take output from it. So you won't make this urinary sodium. So you won't even give less sodium to this urine, and so your urine excretion of sodium will be less, and your osmolality. That's why if you get 10 water, out of which you absorb most of them, that's why the concentration of your urine will be more. So here the urine osmolality will be more, and urine sodium will be absorbed. So urine sodium will be less here. Okay, it will be less. Remember, it is less. Fine. Whereas this urine to plasma creatinine ratio, it will be more. Okay, itna yaad rakho. Bas itna yaad rakho. Okay, about this one. Okay. Then if you see about this renal pathology, then here kidney is not functioning, so it cannot reabsorb perfectly. So if there is a renal pathological or renal pathology, then the whatever water you give, it will leave them in the urine, so it won't concentrate. So the urine osmolality will be decreased. And if you see about this urine sodium, it will send more sodium into the urines because it is not absorbing. It will just say let's go, like that. It is telling. So it is this increased urine sodium, okay, excretion. And about this urine to plasma creatinine, here if you see the kidney is functioning, so it is sending more creatinine to the urine part because we don't need creatinine in our plasma, right? Whereas here the urine creatinine is less because the kidney is not filtering, so the creatinine is not going into the urine. So these are the few differentiating factors that how you can differentiate this pre-renal from the renal kidney injury. Fine. And how will you define this kidney injury? There are different stages. Acute, in case of acute kidney injury stage 1, there will be 1.5 to 1.9% or 9 times the increase in the baseline of this creatinine, okay, or 0.3% of this per deciliter of this increase in this creatinine, okay. Whereas in stage 2 it is 2 to 2.9 from the baseline, whereas in stage 3 it is more than 3% increase in the 3 times increase in the baseline, or increase in the creatinine up to 4 mg per deciliter. And along with this, there is a decrease in the EGFR. So just try to remember it is 1.5 to 1.9, then 2 to 2.9, then more than 3. So it is what? It is the 3 stages you need to remember about this acute kidney injury. Okay. Then we'll come into this nephritic and nephrotic part, and this is one of the important part because they will ask from pediatric part, medicine part, and the pathology part. Okay, pediatric, medicine, and this part. So if you see about this nephritic syndrome, so nephritic syndrome, it is what you can remember by mnemonic of 𝗏𝗏. Okay, it is what it is this hematuria, oliguria, hypertension, and azotemia, means increase in level of BUN. Okay, blood urea nitrogen. Next, if you see about this nephrotic syndrome, remember it is the fro. So there will be increased proteinuria in the urine. So urine will be having the more proteins, and there will be, because more proteins are going into the urine, obviously there will be a less protein into the blood. So that's why there is this hypoalbuminemia. And हमें पता है this albumin is responsible for a pressure which is known as oncotic pressure. So there is less oncotic pressure. So then the blood will start, the water will start accumulating into the tissues, causing this edema. Okay, and along with these proteins, the lipids also go out. It is known as lipiduria. So itna yaad rakho. Then if in pediatrics they will ask you what is the most common cause of nephrotic syndrome, it is what it is this disease which is known as minimal change disease, and it can be seen in a case of after immunization, any leukemia and lymphoma. So why it is minimal change? On light microscopy you will not see any changes, where in the case of electron microscopy you will see this podocyte effacement. Yeah, good Dr. Anna. Then about in adults, the most common cause of nephrotic syndrome in adults kya hai? It is this focal segmental glomerulosclerosis. Then it can be seen in a case of HIV patients, hypertension patients, and heroin use patients. And this also seen in a case of reflex nephropathy and any renal tissue loss injuries or any trauma. Fine. And next one is this membranous glomerulonephritis. So they will give you this question, like what is the most common cause of nephrotic syndrome in a case of elderly and cancer patients? Elderly and cancer patients, the most common cause of nephrotic syndrome क्या है? It is the membranous glomerulonephritis. It is the membranous glomerulonephritis. याद रखो. Then this membranous glomerulonephritis, it is because of this antibody against the phospholipid C2. Yeah, good Dr. Anar, good Dr. Gautam. Then it is can be due to this infection of hepatitis B virus, malaria, leprosy, and syphilis. And this membranous glomerulonephritis, it will show this pattern which is known as spike and dome pattern. It is known as spike and dome pattern. Yeah. Thank you, Dr. Soulmate. Yeah, thank you. Then about this MPGN, remember this is MGN, this is membranous glomerulonephritis. If someone is coming in between this MGN, then it will separate them. So remember it is as MPGN. So P is coming in between this MGN, so it is causing the separation. So it is known as tram track appearance. So it will cause tram track appearance of this basement membrane on the biopsy part. So MGN, it is the most common cause of this nephrotic syndrome in elderly and also cancer patients, whereas it will show spike and dome pattern, whereas MPGN, remember MPGN show tram track pattern. Okay, so treatment of this mostly it will be this steroid responsive, will give the steroids, especially then if there is the steroid dependency, means once you remove the steroids, then if the patient is still means once you remove them, if the patient is having the recurrence, it is known as steroid dependent. The patient is dependent on the steroids, so you need to give cyclophosphamide in such cases. But if the patient is experiencing resistant, you are giving keep on giving the steroids, but still the patient is not responsive. So then in such cases you can give cyclosporin. Okay, then we'll move on to this few nephritic syndrome. As I told, the clinical features include 𝗏𝗏. What are the 𝗏𝗏? It is hematuria, oliguria, hypertension, and azotemia. Hematuria, oliguria, hypertension, and azotemia. And the most common cause of nephritic syndrome in children, it is what? It is this PSGN. PSGN, it is the most common cause of nephritic syndrome in children. Okay, and we know there will be a history of sore throat, and yeah, good Dr. Gautam, there will be a history of sore throat, followed by 14th day there will be a presence of this cola colored urine. Okay, cola colored urine, which is this hematuria. Okay, and there will be a positive of, yeah, it is this group A beta hemolytic streptococcus infections. Fine, and there is this anti-DNase antibody positive, and here you will be able to see this subepithelial humps. Whereas in the case of adults, you will see this disease which is known as Burgess disease, which happens 4 days after, means they will tell 4 days before the patient had a sore throat. If they tells 4 days before, means you will think of this Burgess disease, and in Burgess disease there will be this IgA deposition, and it can be associated with this enoxaparin perfluorosphate. Next one, it is known as RPGN. There you will see this crescent formation in this glomerulus. So RPGN, you will see this crescent formations. There are different types of RPGN. One of them is type 1, it is this Goodpasture syndrome. Type 2, it is this HSP, SLE, and PSGN. And type 3, it is the pars-human like vaginous granulomatosis, or vaginous में तुम्हें याद रखना, it is due to the C and का positive. It is positive for C and का. Okay, this is about this nephrotic and nephritic syndrome. So followed by this, we'll move on to the next part. Okay, you need to remember about this RTA, renal tubular acidosis. So type 1, type 2, there is no type 3, that is the type 4 we need to know. Okay, type 1, remember 1 per stone. Okay, 1 per stone. Okay, 1 per stone. So here in the case of type 1, there will be formation of this stones. There will be formation of this urinary stones. And there will be features of this hypokalemia. There is a features of hypokalemia along with this urinary stones, which will be seen in a case of type 1 type of renal tubular acidosis. Whereas in the case of type 2, remember second alphabet, which is this type B, which causes this bicarbonaturia. The bicarbonate in the urine, the bicarbonate will flow in the urine. It is a type 2. So second alphabet is B. It is this type 2 which causing this bicarbonaturia. और इसमें भी आपको decrease in the level of potassium. So decrease in the level of potassium. Whereas in type 4 में बस आपको ये इतना याद रखना है. There will be increase in level of potassium. There will be increase in level of potassium, and okay, that's it. That just remember these things so that you can differentiate between whether this is type 1, type 2, or type 4. Okay. Yeah, Burgess for adults and PSGN for children. Yeah, that's correct. That's it, Dr. Sky. Yeah. Yeah, Churg-Strauss syndrome. Yeah, Churg-Strauss syndrome will show this P and K, and other like there will be microscopic polyangiitis. It may also show P and K positivity. Right? Then we'll move on to the next part About this rheumatology part, yesterday also we yesterday or day before yesterday we studied in pathology, right? About this SLE, what are the diagnostic one? So just go and check once the antibody which we use, like most specific and most sensitively we use anti-double stranded DNA antibody, whereas most specifically we'll use anti-Smith antibody, and in kidney it is known as lupus nephritis, okay, where you will be able to see this wire loop lesions, okay. Here there are few clinical manifestations I will tell you. Yeah, good Dr. Anar. It is this anti-DS DNA which is more sensitive, both sensitive and specific, whereas specific one it is anti-Smith, and if it is neonatal the child will grow like cry, so it is known as RONA. So in a case of neonatal it is anti-Ro, whereas psychosis it is ribosomal P antibody, okay. So इतना तो आपको याद रखना. Yeah, DS DNA it is most commonly diagnosed. Yeah, good Dr. Quine. Welcome back. In SLE, if you see the skin manifestations like this, malar rash which spares the nasolabial fold, okay. Yeah, good Dr. Anar, good Dr. Quine. Yeah, good. Then there will be the synovitis, means there will be involvement of these joints, and along with this serositis, means sera of like pleura and pericardium will be involving. So if there is pleuritis and pericarditis, these are the serositis. Next, about there will be formation of this mucosal ulcers, are also known as oral ulcers, and there will be neuropsychiatric manifestation. जैसे हमने बताए थे, there will be ribosomal P antibody will be positive here. Then anemia, there will be features of this autoimmune hemolytic anemia, and renal, you will be able to see there is a presence of this lupus nephritis which causes this proteinuria, and there you will be able to see this light microscopically. You will see this wire loop lesions, especially in class 4 आपको बहुत ज़्यादा देखेगा और most commonly भी देखेगा, fine. And in immunofluorescence it will be showing this effect which is known as full house effect. ये भी हमने pathology में दिखा है, just have a look into it also as well, fine. Then we'll move on to this dermatomyositis. Dermatomyositis में you will be able to see this type of heliotropic rash around this eye, okay. फिर उसके बाद this papules which on this back side of your knuckles, it is known as what? Gotron papules. And then here you will be able to see on this side of your neck, you will be able to see this around the shoulder region, this is known as shawl sign, okay. Shawl sign, yeah, good Dr. Anna, yeah, good. Then for this diagnosis of this dermatomyositis, it is muscle, so we'll use this creatine phosphate levels. Then we can use some other antibodies like anti-MDA5 and anti-TIF1 and anti-MI1. So just remember this as a sake, okay, because mostly they won't test in depth, fine. And the investigation of choice, it is what it is, this MRI guided muscle biopsy, because there will be in body everywhere it is a muscle, right? But we should know where exactly the muscle is having inflammation. So where there is this perifascicular atrophy, there the MRI, with the help of MRI, will point out and will make the biopsy and will do this antibody testing as well, fine. Just remember, a good Dr. Quine. And there is one more condition which is known as limited scleroderma. See, in a case of scleroderma, there will be this stretching of the skin which may lead to this formation of this type of ulcers, okay. This is because of the stretch ulcers, fine. And here you will be able to see, right, the skin is shining. Why it is shining? Because it is pulling, means it is having this sclerosis. That's why the skin will be shining. It will be shining. Yeah. Yeah, it is the mechanic hand which is having this papules, which is known as, means the dry hand which is known as mechanic hand, and this is what? This is this Gotron's papules. Okay, it is the Gotron's papules. Remember. Next, about this limited scleroderma. In a case of limited scleroderma, there will be positivity for this anti-centromere. So it is centered or it is limited to something. So that's why it is anti-centromere antibody positive. And there will be manifestation which is classified as crust, C-R-E-S-T, crust. So there will be this calcinosis, Raynaud's phenomenon. हमें पता है, there is three things. There will be a pallor followed by this cyanosis, then redness. There will be this PCR. Pallor, cyanosis and redness. And the diagnosis of this Raynaud's phenomena will use for treatment, will use this calcium channel blockers. फिर उसके बाद there will be esophageal dysmotility causing this dysphagia, and there will be this sclerodactyly. We saw, right, sclerosis of this duct, like the fingers, okay. Then there will be a telangiectasia, means dilatation of the superficial vessels, okay. Yeah, good guys. Yeah, good Dr. Quine, we use calcium channel blockers in this. And next, about this headache, there will be one question for sure, and we also studied the same about this management of this migraine in pharmacology as well. So make sure you are reading it once more so that it will be in your subconscious mind and it will be in your active memory, fine. And this headaches based on it, like for example, in a case of tension headache, it will be like a band formation. Okay, migraine, it will be mostly of unilateral and will with other characteristics. And sinus, it will be in the midline, or if it is frontal sinus headache, it is at this level, which is mostly known as office headache. During the office hour it will happens. And hypertension, it will be mostly occipital in nature. Fine. Whereas this cluster headache, it will be retroorbital in nature, and it will be having the features of tearing, blushing, and all other features. Okay, there will be this retroorbital pain, and it will even wake you from sleep. So they will have this classical history. The patient is presenting with this history of headache, and this headache has been persisting for few hours, and the patient even complains that this headache has wake him up from the sleep. This headache has wake him up from the sleep. So this is the typical description of this cluster headache. Next, if you see this description of this migraine, it will be pulsating, dhadkega, means it will be pulsating. Then it will be a one-day illness, it won't persisting for the longer duration. Then it will be unilateral in nature, बस एक side में होगा. Then it will be associated with this nausea, and it will be causing this disability in their character. Okay, disability in the character. Sometimes it may be associated with this aura, मतलब मुझे लग रहा है मुझे आएगा करके, ठीक है. Then for treatment, we told in a case of mild, we'll use NSAIDs. In a case of severe attack or acute attack, we'll use this triptans. Okay, triptans like zolmitriptan, rizatriptan, and sumatriptan. Fine. And for prophylaxis, we can use propranolol, flunarizine, and valproate. Okay, and also there is one more drug which is known as topiramate. Okay, topiramate. Okay, remember. Next, about this cluster headache, I told you it will be having this typical retroorbital pain along with this tears, nasal stuffiness. Fine. And for this cluster headache, we need to give this oxygen therapy, and along with this sumatriptan, mostly it will heal, mostly it will reduce it. Fine. Yeah, triptan will avoid in a case of heart, because we know, right, usually this migraine happens because of this vasodilatations into the blood vessels. Whereas if we give triptans, then it will cause this agonistic action and it will cause constriction. So already patient को तो heart disease है, अगर heart में तो बहुत कम blood जा रहा, तो if you cause constriction of those vessels as well, then it will cause again ischemia. So that's it. Then there is one more, lidocaine will be used in a case of SUNC, and paroxysmal hemicardia will use this NSAID, which is this indomethacin. And we know this indomethacin we also use in a case of patent ductus arteriosus, और हमें पता है ductus arteriosus, it is a 6th arch artery on the left side. ठीक है, इतना याद रखो बस. Yeah, means yeah. Good morning, Dr. Bharat. Yeah. Like starvation period, if it is exposed to loud sound, if it is exposed to some sort of smell, all of them, they are this predisposing factors to the migraine, right? Yeah. That I will write the explanation to. Don't worry. Then about this Guillain-Barré syndrome. If you see, it is due to the antibody, which is this anti-GM1 antibody. Okay, and it will be causing this symmetrical flaccid paralysis. It is not spastic paralysis. It will cause symmetrically ascending, means it will be from the lower limb, it will be ascending up from lower limb, then upper limb. So it will be ascending symmetrical, bilaterally symmetrical paralysis, which is due to the involvement of this GM1. Okay, and it is most commonly involving this 7th cranial lobe. Okay, it will from the below to the upside. Then one of the commonest form of this Guillain-Barré syndrome, it is known as AIDP, acute inflammatory demyelinating polyneuropathy. And one of the characteristic features from the other type of paralysis, it is what it will be sparing this bowel and bladder. It will spare the bowel and bladder. इतना याद रखो. And then lumbar puncture, when you do, means when you do this lumbar puncture, there will be this albuminocytological dissociation. Okay, there will be antibody against this, means GM1. So we know it is antibody. Antibody भी क्या है? It is a protein. So if there is more antibodies, तो क्या होगा? It will go and increase the level of proteins in the CSF. अगर CSF में protein को ज़्यादा करेगा, मतलब means it is more proteins when compared to the usual cells. So it is known as albuminocytological. Along with this proteins albumin, and there is this cytological, the cells are having dissociation. Usually cells थोड़ा ज़्यादा रहना चाहिए, लेकिन इसमें proteins ज़्यादा रहेगा. It is known as albuminocytological dissociation. ठीक है, इसको ट्रीट करने के लिए हम स्टीरॉइड्स यूजुअली प्रेफर नहीं करेंगे, हम देंगे IV इम्यूनोग्लोबुलिन. हम देंगे क्या देंगे? हम IV इम्यूनोग्लोबुलिन. ये भी एंटी, मतलब इट इज एन ऑटोइम्यून डिसीज, बट वी प्रेफर यूजिंग दिस इम्यूनोग्लोबुलिन. ठीक है, इम्यूनोग्लोबुलिन याद रखो. देन about this disease, which is this myasthenia gravis, हमने पढ़ी थी. myasthenia gravis, it is a type 2 hypersensitivity reaction, or also what, it is a type 5 hypersensitivity reaction as well. ठीक है, type 5. Yeah, Yeah, we can, instead of IV immunoglobulin we can try plasmapheresis, but we prefer less steroids. बस इतना आपको याद रखना चाहिए, हम प्लाज्माफेरेसिस भी कर सकते हैं और IVIG भी दे सकते हैं, लेकिन हम स्टीरॉइड्स नहीं देंगे. प्लाज्माफेरेसिस. Good guys. Good, Dr. Naresh. Good. Then, if you see this myasthenia gravis, there will be what? There will be this antibody against this acetylcholine receptor. हमने देखे थे, तो it will be the type 2, especially it can be classified as type 5 hypersensitivity reaction as well. ठीक है. Then there will be this asymmetrical ptosis. तो क्या होगा, सुबह सुबह में उनको अच्छा लगता है, फिर उसके बाद जैसे means like there will be starting of this symptoms with a progression of time. It is known as diurnal variation. There will be presence of this anti-acetylcholine receptor antibodies and anti-MuSK antibodies. ठीक है. Then now on this clinic itself, you can do a test which is known as ice pack test. When you keep the ice pack, it will cause this relieving of the symptoms, which is known as ice pack test. Yeah, you are welcome, Dr. Bharat. Then the investigation of choice which we use here, they will ask you, what is the investigation of choice? Is it anti-acetylcholinesterase antibody, or is it anti-MuSK antibody, or is it multi-fiber elastography? Your answer should be what? Your answer should be single fiber. Your answer should be single fiber electromyography. It is the, yeah, towards the end of the day, towards the evening, it will be worsening, guys. So the investigation of choice, it is what it is, this single fiber electromyography. ठीक है. And then repetitive nerve stimulation means मतलब जैसे आप बार बार उसको छेड़ते रहोगे, when you start stimulating them, then there will be a decreasing response. तो इसीलिए वो सुबह होकर मतलब how during your preparation part, right? जैसे when you drink a tea or something, your eyes will be like this. Then later on, when you start listening to the class, your eyes will start closing. Okay, so this is the same as the myasthenia gravis. So when we start giving more information to you, you also tend to close your eyes and try to sleep. The same here, when you give multiple responses, or when you give responses for this continuously, this leads to this progression of the symptoms. इतना याद रखो. Yeah. So the diagnosis is single fiber electron myography. इतना याद रखो. Then for this treatment, हमने pharmacology में पढ़ा था. It is what it is this. Pyridostigmine, it is the pyridostigmine. लेकिन atropine poisoning के लिए हम physostigmine यूज करते हैं. atropine के लिए physostigmine, here it is pyridostigmine. और एक ड्रग यूज करते हैं इसको डायग्नोस करने के लिए, उसको बोलते हैं penicillin test. We already written in pharma as well. It is this endothelium. ठीक है, endothelium. ठीक है. Then about this, there is some cases it is associated with this thymus involvement. तो इसलिए हम इसको इनका अगर थाइमस है उसमें हाइपरप्लेशिया हो सकता है, तो इसलिए हम इनका थाइमस को निकाल देंगे. ठीक है. एंड द ट्रीटमेंट ऑफ चॉइस ऑफ फॉर जस्ट इन्वॉल्वमेंट ऑफ दिस ocular myasthenia gravis causing this process, it is this steroids are azathioprine. Good, Dr. Parul. Good, Dr. Shanwas Khan. Yeah, welcome back. Fine. Then we'll move on to this condition which is known as multiple sclerosis. Yeah, good, Dr. Gautam. Good, Dr. Bharat. Fine. Then we'll move on to this condition which is known as multiple sclerosis. ये भी एक autoimmune disease है. It causes क्या? It causes demyelination of this nervous system. So because of this demyelination क्या होगा? Here when you do this imaging, it is what it is known as, it is a MR imaging, especially this MR imaging which is known as FLAIR. ठीक है. हमें पता है कि CSF के अंदर के मतलब ये ventricles के अंदर फ्लूइड है. ठीक है. And this is what this periventricular. This is this periventricular changes which is be seen. So we know that if we need any changes needed to the ventricle, ये fluid हमें disturb बिल्कुल नहीं करना है. So this is what this is known as fluid attenuation inversion recovery sequence. Okay, it is known as fluid attenuation inversion recovery sequence, which is used as a radiological method for this multiple sclerosis. इतना याद रखना. ठीक है. So this periventricular lesions will be characteristically called as. ठीक है. तो मैं जैसे घर से प्यार से चिकू, छोटा, बेटू ऐसे बुलाते हैं ना, तो there will call them as Dawson fingers. We'll call them as like a fingers. It is known as Dawson fingers. Fine. Then in female, in this multiple sclerosis, mostly it will present as optic neuritis, which causes this sudden loss of vision, and it can also present as in neuromyelitis optica kind of spectrum disorders. Okay, there will be this kind of tingling sensations will be there along with these features of optic neuritis. Okay. And it is usually unilateral in nature, and it will be gradual in nature. Yeah, it can produce this Utah phenomenon as well. A good doctor, like once you take a hot shower, this symptoms tend to progress. Okay, so if for this management of this multiple sclerosis, okay, agar acute episode hai, then we'll give this steroids, which is this methylprednisolone. For prevention we'll give this beta interferon, okay, or other monoclonal antibiotics like natalizumab. It is natalizumab, fine. And for PPMS, primary progressive multiple sclerosis, will give this ocrelizumab, fine. So in a case of prevention, we'll give this beta interferon and natalizumab, whereas for PPMS, we'll give this ocrelizumab, whereas for secondary progressive multiple sclerosis, we'll give this ipilimumab. Okay, so just remember this 2-1. Prevention will give natalizumab, whereas PPNS will give ocrelizumab. Okay, these 2 drugs remember for sure, fine. And this is about this multiple sclerosis. Okay, then we'll move on to the next part about this type of meningitis. This is the must know topics. There is 3 subjects integration, which are microbiology, pediatrics and medicine. Microbiology, pediatrics and medicine part. So here you will see there is the usual history of this meningitis. There will be fever, headache, neutral rigidity, and sometimes there will be this projectile vomiting, or there will be simple vomiting as well. Okay, and if there is rash which is being seen along with this will be typical for this Neisseria meningitis. So this is the organism level, whereas we need to differentiate whether it is which type of meningitis, whether it is TB one, fungal one, viral one, or bacterial one. So mostly your differential diagnosis should be lined within 3 things: TB, viral and bacterial. See about the bacteria, we know this bacterial infections, the neutrophils will increase. So here in the case of bacterial, there will be increase in levels of polymorphonuclear neutrophils. Okay, PMNs, polymorphonuclear neutrophils. Yeah, good Dr. Quinine, good Dr. Gautam, good Dr. Anna. Yeah. So there will be increase in level of polymorphonuclear neutrophils, and we know this neutrophils and this bacteria, especially this bacteria, they will consume lot of sugar. That's why the sugar will be low. So in a case of bacterial, you need to know there is this increase in neutrophils. Okay, neutrophils. If neutrophils written, just close your eyes and go for bacterial. Fine. Here we know there will be associatedly there will be decrease in serum levels will be there, and proteins will be more because there is inflammation going on because of this infection. So the proteins will be more here. So इतना याद रखो. Whereas in the case of virus, उनका कोई लेना देना नहीं है because they walk on inside the cell. So what they will do? They will increase this lymphocyte. Okay. Mono means mononuclear cells like lymphocytes. देन उनका ग्लूकोज भी नहीं चाहिए, तो इसी वजह से वो ज्यादा इन्फ्लेमेशन भी नहीं करेंगे. सो इन द केस ऑफ वायरल देयर विल बी नॉर्मल प्रोटीन एंड नॉर्मल ग्लूकोज, नॉर्मल प्रोटीन एंड नॉर्मल ग्लूकोज. whereas in the case of TB there will be same lymphocytes will be there, but TB it is a bacilli, so obviously it will consume the glucose, so there will be a decrease in glucose, and TB there will be a high level of proteins. अगर बहुत ज्यादा लेवल है उसको बोलेंगे 𝗶𝗵𝗀𝗀 will known as 𝗶𝗵𝗀𝗀. Yeah, good guys. So your differential diagnosis should be between TB and viral if the cells are lymphocytes. So lymphocytes से then TB हो सकता है या HIV हो सकती है, sorry, any viral infections हो सकता है. Okay, so in a case of viral there will be normal sugar and normal proteins, whereas in a case of TB there will be a decreased sugar and increased protein. इतना याद रखो. Okay, and the final part of this neurology one, it is this motor neuron disease. ठीक है. Motor neuron disease. Okay, just a few more moment, we'll complete the medicine one. Okay, have some patience. Then about this motor neuron disease, it is due to this hexanucleate repeat disorders. Okay, we studied this trinucleate repeat disorders. For example, our Friedreich's ataxia were GAA, and Huntington's chorea, Hunter always keeps a cage, so CH repeats. Whereas this motor neuron disease, it will be a hexanucleated repeat disorder. It is a hexanucleated repeat disorder, and there are different types. Yeah, good Dr. Gautam, good Dr. Anar. Yeah, there are different types. There might be involvement of this lower motor neuron. Okay, see, if there is involvement of this lower motor neuron, it will be a flaccid paralysis. It will be like this. Means if you tell the patient to lift, the patient cannot lift. But when you touch and see, the hand will be like this. Means whatever you do, it will be flaccid. It won't be it won't be stiff, it will be flaccid. This is known as flaccid paralysis. Okay, and because of this there will be absent reflex as well. Like for example, you do this wrist reflex or any other reflex like bicep reflex or tricep reflex, like none of them, they will come out to be positive. So because of this flaccid paralysis in the case of lower motor neuron. Okay, and usually it will be associated with this muscular atrophy, and this happens because of this involvement of this anterior horn cells of the spinal cord. हमें पता है this all of this lower motor neuron will go on go in connection with this anterior horn cell of the spinal cord. So if there is any lesion over there, it leads to this flaccid paralysis. It is this lower motor neuron type. Okay, and in bulbar palsy, remember bulbar palsy वो ना पी सकते हैं ना बात कर सकते हैं. So they cannot even have a drink because they'll be having this agitations because of this loss of gag reflex. They will cough, this will enter into this airway, and they cannot speak because they'll be having this tongue difficulties as well. Yeah, okay, that's you remember. Next, about this upper motor neuron type, there is also paralysis, but upper neuron type, it will be of spastic paralysis. When you try to give pressure and you need more pressure to relieve this paralysis. So it is known as spastic paralysis. Okay, it is known as spastic paralysis along with this brisk reflex. Okay, and it is related with this primary lateral sclerosis, which involves this corticospinal pathway. It involves mainly this corticospinal pathway, which is a sensory pathway. फिर उसके बाद आते हैं लोअर मोटर न्यूरॉन डिजीज एंड अपर मोटर न्यूरॉन डिजीज, दोनों साथ में होते हैं. वो बोलते हैं कि एमियोट्रोपिक लैटरल स्क्लेरोसिस, which is a type of motor neuron disease which is we see in a case of like Stephen Hawkins में उनको था. ठीक है, he had this thing. Okay, remember. Then there is this gradual, means usually this amyotropic lateral sclerosis, there will be combination of both. Okay, there will be combination of both upper motor and lower motor. Yeah, here you will be able to see that it will be gradual in onset, and for years they will be asymmetrically, it will be progressive, and followed by this here the knee, ankle and left, it will be lower, there will be upper motor neuron type. Okay, so it will be brisk in nature, whereas biceps may be absent. Okay, and the death is mainly due to this because it is progressive. The death is mainly because of this respiratory failure. Okay, respiratory failure, और इसको treat करने के लिए हम riluzole और edaravone देते हैं. Okay, riluzole will be used for this amyotropic lateral sclerosis. इतना याद रखो. Okay, so this is about this CNS part, and we have small GIT and hepatobiliary, and followed by this we'll have this endocrine part. Fine. Then GIT you need to know mainly from the surgical perspective. अगर तुम्हें gastro मतलब medicine gastro देखना तो तुम्हें देखना means there is usually there will be alcoholic patient who is presenting with history of, दो चीज का हिस्ट्री वो लेकर आ सकते हैं. ठीक है, ज्यादा पी लिया और ज्यादा खा लिया तो क्या करेंगे उसके बाद वो उल्टी करेंगे. दे विल बी हैविंग दिस वॉमिटिंग एपिसोड्स. So in a case of vomiting episodes, if vomit is coming and the vomit is coming with some part of blood, okay, the vomit is coming with blood, just blood, okay, simple blood, then without any complaints the patient is normal, but he is coming in the morning and telling you, doctor, I just vomited some blood and he is vitally stable, he is normal, then it is what? Then it is the Mallory-Weiss syndrome. So if it is just superficial mucosal bleed, the patient is telling you, then it is what? Then it is Mallory-Weiss syndrome. Whereas Boerhaave syndrome, if you see, this will be a huge reflex, this will be a big reflex, where this upper end of this esophagus also closed and lower end will tend to close, and this esophagus will be constricting between these two ends. So when there is a constriction in between two ends, this esophagus tend to rupture out. So this rupturing of the esophagus and spillage of this content into the mediastinal cavity, इसको बोलेंगे Boerhaave syndrome. इसको बोलेंगे Boerhaave syndrome. So इतना याद रखो, it is known as Boerhaave syndrome. So it is a complete rupture. So Boerhaave, it is the complete rupture, whereas Mallory-Weiss, it is a very superficial and mucosal rupture. ठीक है, mucosal rupture. तो इसलिए if it goes into this mediastinum, it will be having this Hammond crunch sign. It will be having this crunching sound. Okay, just याद रखो. Okay, and this Mallory-Weiss, this Boerhaave syndrome can be associated with this transferring of this esophageal content into the mediastinum. तो mediastinitis cause सकता है और lung infection भी cause करा सकता है, or it can come into this air can come into the superficial tissues, then can cause subcutaneous emphysema. So these are the differentiating factor, how we will differentiate from this Mallory-Weiss from this Boerhaave syndrome. Okay, yeah, you will see this Meckel's triad in a case of Boerhaave syndrome. Meckel's triad, बढ़िया Meckel's triad. Then about this ulcerative colitis and Crohn's disease, you need to know about this management part. Like mostly तुम्हें पता, means like they know this, you know Crohn's disease हम क्या देखेंगे, there will be this cobblestone mucosa देखेंगे, there will be presence of this strictures fistula along with the presence of transmural involvement. Yeah, बढ़िया Dr. Gautam, involvement. Yeah, good. Skip lesions, yeah, skip lesions which causing this cobblestone papillae and along all these features. And yeah, whereas in a case of ulcerative colitis हमें पता, it is more superficial, so there will be this continuous involvement and it is superficial in nature. ठीक है, इतना याद रखो. But mostly they will test you about this management of this ulcerative colitis and Crohn's disease. तो माइल्ड में क्या करोगे, मॉडरेट में क्या करोगे, सिवियर में क्या करोगे. तो अल्सरेटिव कोलाइटिस इट्स बेटर टू हैव बिकॉज व्हेन यू ट्रीट इट विल हील. सो फॉर अल्सरेटिव कोलाइटिस फॉर इनिशियल मैनेजमेंट यू विल गिव दिस 5-ASA अमीनो सैलिसिलिक एसिड और मिसलामिन. ठीक है, तो माइल्ड टू मॉडरेट के लिए हम 5-ASA देंगे. अगर थोड़ा और चाहिए तो देन वी गिव 6-mercaptopurine or azothioprine, then the antibodies like adalimumab and cyclosporine. So it is from this mild to the moderate we can test. Whereas in the case of just severe episodes of this ulcerative colitis, तब हम steroids देंगे, इतना याद रखो. और else अगर इसमें भी ठीक नहीं हो रहा, हमें पता है कि द मोस्ट कॉमन कॉज ऑफ दिस अल्सरेटिव कोलाइटिस इट इज द इन्वॉल्वमेंट ऑफ द रेक्टम. तो हम इसको निकाल सकते हैं. तो विल डू दिस मींस प्रोटेक्टमी एंड इलियोएनल पाउच एनास्थेमोसिस. तो ये करेंगे तो मींस द डिसीज फैक्टर विल बी रिमूव्ड ऑफ, सो देयर विल बी बिग रिलीफ टू द पेशेंट. ओके, दिस इज द मैनेजमेंट प्रोटोकॉल फॉर दिस अल्सरेटिव कोलाइटिस. लेकिन Crohn's डिसीज ना बहुत खतरनाक डिसीज है. या Crohn's disease is a खतरनाक disease because if you see here there is a formation of strictures, fistula, तो obstruction cause कर सकता है. Then this will produces this, this produces this type of string sign of contour because of this constriction. String sign of contour. Good. Yeah. You can use sulfasalazine as well. Yeah, good for ulcerative colitis. ASA, that is ASA. For initially if you see, for induction if you see just you give nutritional therapy, you won't give enteral nutrition, you give TPN. Okay, for mild to moderate disease you start with steroids, budesonide, enema, then prednisolone, then 6-mercaptopurine, azothioprine and followed by this infliximab and adalimumab. तो ये सारे हम सिर्फ mild to moderate में ही दे चुके हैं. Whereas in the case of severe disease you need to give all these things along with this natalizumab and 𝗧𝗵𝗶𝗀, along with this natalizumab and 𝗧𝗵𝗶𝗀 and with total parenteral nutrition. So if there is any induction then we give TPN, और if there is any severe disease तभी भी हमें TPN देने की जरूरत है. ठीक है, whereas in the case of Crohn's disease में हम steroids तब देंगे when there is an induction, whereas in the case of maintenance there is no role of steroids in the case of Crohn's disease, whereas steroid play a crucial role in a case of ulcerative colitis. ठीक है, बस इतना याद रखो. Then we'll move on to this types of hepatitis. But mostly means just if you can just understand with this graph, if not just see about this test and just memorize it. See, first we know the first antigen to come from this hepatitis B, it is what it is, this 𝗏𝐵S/AG antigen. ठीक है, जैसे 𝗏𝐵S/AG antigen खून के अंदर आया तो फिर उसके बाद we know 𝗏𝐵C, we won't see in blood, antigen we won't see in blood. So then the first antibody to be start producing, it is what it is, this 𝗏𝐵C antibody. So first antibody क्या होगा, it is this 𝗏𝐵C antibody will start producing. So this 𝗏𝐵C will be having two types. Initially in acute it will be the IgM, then followed by this IgG. Okay, followed by this IgG. तो उससे पहले हमें एक infectivity बढ़ाने के लिए 𝗏PE भी आ जाएगा. तो in later part this will be having this antibody against it which is known as anti-HB. So first पूछेंगे कौन सा एंटीजन आएगा, it is 𝗏𝐵S/AG, and first antibody कौन सा आएगा, it is IgM variety of anti-𝗏BC आएगा. ठीक है, and 𝗏BE for this infectivity, E for infectivity, इतना याद रखो. Fine. If you know this, then it is an easy PC for you. Fine. So to start an infection, you need this 𝗏BS/AG. Then if it is IgM type of, first if it is IgM type of, you know IgM it is seen in acute infection. So IgM type of anti-𝗏BC, and along with this, if 𝗏BE, if there is active factor is there, so it is this acute hepatitis B with infectivity. Okay. Whereas in a case of chronic there will be IgG will be present. अगर ज़्यादा infective है, if still it is infective, then it will be positive for this 𝗏BE with active viral replication which is more infective. अगर ये negative है, if it is negative, then it will be this chronic hepatitis along with this less infectivity, along with this less infective. It is what? It is less infective. Okay. Then if it is 𝗏BS/AG is there, then anti-𝗏BS is there, then along with this IgG is there. इसका मतलब है means anti-𝗏BS started developing, and if you have this anti-𝗏BS along with this IgG, मतलब it is a chronic hepatitis which is mostly healed. Okay, which is mostly healed. Okay, which is mostly healed and which is being resolved. ठीक है, इतना याद रखना. Then if it is just IgM है, then just it is acute hepatitis B, very remote one. Okay. And if you see this Anti-HBS, you're not seeing HBS antigen, anti-HBS and anti-HBE, it is recovered. The patient is completely recovered from the infection. ठीक है, completely recovered from the infection. अगर anti-HBS, HBS-AG भी है और anti-HBS भी है, then it is a chronic infection. Whereas in the case of anti-HBS is there and IgG is there, the patient is completely recovered. ठीक है, इतना याद रखो. Then if just anti-HBS is there, we know in vaccine we just give anti-HBS. So it is what it is, the vaccination. It is the vaccination. ठीक है, okay. Then then if just anti-HB is there, it is a false positive or very remote infection in the past. मतलब बस थोड़ा सा infection हुआ. So this is this. If only IgE is there, IgG of anti-HBC is there, it is a remote infection. अगर सिर्फ anti-HBS positive है, because we give only in vaccines we give HBS antigen. So if anti-HBS पॉजिटिव है देन इट इज वैक्सीनेशन. ठीक है, फिर बाकी IgM है तो अक्यूट है, फिर IgE के साथ आता है then it is what, then it is with infectivity, without infectivity. If IgG है then it is what, then it is a chronic infection. If IgE present it is with infectivity. If anti HBE present then it is with less infection. ठीक है, so I guess there will be a few confusion here, so make sure you are watching it once more time. Okay, that's it. Then we'll move on to this next disease, which is this Wilson's disease. We know Wilson's disease is due to the deficiency or due to the mutation in the ATP7B gene. Yeah, good. Then it will cause this hepatolenticular. There will be deposition of this copper into this liver and to the basal ganglia. So liver and the basal ganglia, that is this lentiform nucleus. Okay, lenticular nucleus. Okay, so this lenticular nucleus effect will show this, and MRI will show this phase of Panda sign. Yeah, diagnosis by serum ceruloplasmin. Yeah, serum ceruloplasmin we'll see serum ceruloplasmin, whereas here the serum ceruloplasmin level will be decreased, whereas investigation of choice क्या करेंगे, हम biopsy करेंगे. ठीक है, yeah, so low ceruloplasmin. Good Dr. Gautam, good Dr. Anar. Okay, fine. Next, here for management we can use this copper chelators like triantrin and D-penicillamine, whereas drug of choice in a case of maintenance phase में हम zinc देंगे, वो भी एक kind of chelatory act करेगा. Whereas for neurological manifestations, we can use 𝗧𝗵𝗶𝗀𝗏. Okay, 𝗧𝗵𝗶𝗀𝗏. ठीक है, याद रखो. Then remember about this conjugated and unconjugated bilirubinemia. Just remember this mnemonic DRC. Doctors need to be conjugated क्योंकि हमें लड़ना चाहिए. Yeah, because if someone is trying to attack, you should be a gang and you should attack them. So that is what, that is doctors should be conjugated. So remember this Dubin-Johnson syndrome and Rotor syndrome, both of them they are what, they are this conjugated hyperbilirubinemia. Okay, whereas in a case of unconjugated bilirubinemia there are two syndromes, Crigler-Najjar and Gilbert. Crigler-Najjar and Gilbert. See, Crigler-Najjar, it is the severe one. Okay, it is the severest one because there will be low activity or absence of this glucouronal transferase. Agar type 1 it is most severe one which is absent, whereas here it will be decreased in quantity. Okay, we know this. Yeah, we know this. Usually this unconjugated hemoglobin like bilirubin will be converted into this conjugated by this glucouronal transferase. So if this enzyme is completely absent, it is this Crigler-Najjar type 1. If it is less in quantity, it is known as Crigler-Najjar type 2. Okay, then we'll move on to the next part. Dubin-Johnson, याद रखो, it is the MRP2 gene defect. Okay, like window period is the period where usually like you won't able to detect this presence of antibodies. Okay, you won't able to detect the presence of antibodies. बस उतना याद रखो. And about this liver cirrhosis, mainly we know there is this compensated liver cirrhosis, means in steatosis followed by this compensated and decompensated liver cirrhosis. Mainly वो क्या पूछेंगे कि what are the complications of this liver cirrhosis? Complications क्या हो सकता है? Yeah, Gilbert syndrome, mostly it is a decrease in enzyme, but it won't manifest. It will manifest only in kind of stress like infections, or you are under stress, or because of any other comorbidities, तभी सिर्फ Gilbert syndrome it will manifest करेगा. ठीक है? Then about this liver cirrhosis, especially we'll see about the complications. One of them is esophageal varices. We know this esophageal varices, it can cause bleeding. So in a case of bleeding, it can be two things. There is a esophageal varices is present and bleeding naiva means there is no bleeding. Then we need to give nodenolol and propranolol to prevent the bleeding. Okay, and as yearly we need to go in and we need to intervene it. Okay, then if there is already bleeding happening and along with this low BP, first तुम्हें क्या करना है? First तुम्हें cannula डालना है. So this is what they will ask. A patient is presented to the emergency department. He has a history of chronic liver disease, and on evaluation, his means on asking history, he tells that he vomited around 500 ml of blood. Okay, and the patient is drowsy, and while taking BP, his BP is 60 to 70. What is the next line of management he will do? He will go for immediate endoscopic examination and band ligation, or he will do IV resuscitation with the best large size cannula. So the first, what he will do, you should save the patient by putting the cannula. So that is how the questions for FMG is asked. So you should know in simple mentality वो क्या पूछना चाह रहे हैं. तो पहले तो वो पेशेंट अनकॉन्शियसली आ रहा है और देयर बीपी इज वेरी लो, सो तुम्हें पहले कैनला डालना है, फिर रेससिटेट करना है, फिर बाकी का काम बाद में देखना है. ठीक है, इतना याद रखो. So first what you will do this volume resuscitation, followed by this either you can give saline if it is blood available till now, then you can give the blood as well. Fine. Then uske baad you need to go and give this IV actiotide to stop the bleeding. Okay, then you can give this IV actiotide to stop the bleeding. Then followed by which you can go for endoscopy and you can ligate the vessel and you can do even sclerotherapy. तो इतना सारे चीज आप कर सकते हैं. Next, if it is still, you did all these measures but still the bleeding is happening, okay, then you can reattempt this ligation part for one more time or two more times. Then you should go for some other definitive procedures like 𝗡𝗵𝗶𝘀 procedure, which is shunting this blood from the portal vein, or else you can go for this transplantation of the liver. ठीक है, इतना कर सकते हो. Next one, this spontaneous bacterial peritonitis. They will tell there is a patient who is presenting with features of enteritis, fever, and there is increased level of 𝗵𝗶𝗀𝗀 in the ascitic fluid. So if you see from this bowel there will be bacteria, there will be this fluids will be there. So this bacteria into the blood, it will come into from the bowel, it will come into the ascitic fluid. So this is known as स्पॉन्टेनियस बैक्टीरियल पेरिटोनिटिस. आपने कुछ नहीं किया, वो अपने आप आ गया. ठीक है, सो ट्रीट करने के लिए हम क्या करेंगे, IV सेफ्ट्रिएक्शन देंगे. राइट. देन नेक्स्ट कंडीशन इज द हेपेटोरेनल सिंड्रोम. हेपेटोरेनल सिंड्रोम, बिकॉज ऑफ दिस लिवर द किडनी इज सफरिंग. ओके, बिकॉज ऑफ दिस रिफ्रैक्टरी ascites, it is causing this AKI-to-8. Okay, so for this we will give albumin to prevent this ascites and will give actrotide as well. Yeah, that is correct, Anand. Next, about this hepatopulmonary syndrome, means because of this there will be collection of fluid into this lungs as well. Then while sitting, the patient will be experiencing this difficulty in breathing. It is known as platypnea. Next, about this hepatic encephalopathy, because of this increase, means because of this liver cirrhosis, this ammonia won't be metabolized and the gut bacteria will produce enormous amount of ammonia. So this ammonia will cause encephalopathy features. So what we'll do, the patient will be having this alteration in their sleep-wake cycle. Okay, the patient will be sleeping in the morning and in whole night he will make us not to sleep. Okay, the main work of the patient is to make us not to sleep during the night duty, and in morning duty he will be, means he won't give rounds to you, he will be always sleeping. So that is this alteration in this sleep-wake cycle, and you will see, like once you keep his hand, it will come like this. So it is known as 𝗓𝗔, also known as flapping tremor. And next it is the confusion part he will be having, and it is because of this blood ammonia levels which is elevated. So उसके लिए हम क्या करेंगे, हम lactulose binders देंगे, क्या नहीं तो the bacteria which is producing will make them to die and reduce it, or else we'll give this LOLA, which is this L-arginine and L-aspartate हम देंगे. Okay. Then in the case of ascites, like how we saw in the case of pleural effusion, right? How will you differentiate from this transidative pleural effusion from this exudative pleural effusion? Likewise, you need to tell like what is the reason for this ascites. तो उसके लिए हम क्या करेंगे, उसके लिए हम दो चीज करेंगे. पहले हम सीरम एल्बुमिन और ascites का एल्बुमिन का ग्रेडियंट देखेंगे. अगर if the ascitic albumin is more, we'll tell it is more than 1.1 category, तुम इस category में आ जाओ. If it is less than 1, it is mainly because of small conditions. For example, it might be because of bile leak, it might be because of nephrotic syndrome. हमें पता है nephrotic syndrome में proteins नहीं है, so the fluid will leak off. Then there will be, if there is any peritoneal carcinomatosis, because of this there will be small infections over there which can cause this. फिर उसके बाद any pancreatitis and tuberculosis, both of them they are the infections. तो ये सारे there will be, it will cause elevation in the protein, but it won't have a significant elevation. Okay, it won't have a significant elevation. Still the plasma albumin will be more when compared to this. Whereas if I see the SAG value in a case of in the case of these conditions where this albumin proteins will be more when compared to the usual one, so we'll segregate them into more than 1.1 gram category. Okay, here we will segregate them into two more parts. If the protein which is more than 1.1, then we'll segregate them into whether it is less than 2.5 or more than 2.5. If it is more than 2.5 means the liver is letting this protein to go, means the liver is normal here in such cases. Okay, so if you see here, for example, it is not liver problem, right? Congestive heart failure, it is the heart problem. This causes pushing the fluid to go. Then yearly Budd-Chiari syndrome, then IVC obstruction and sinusoidal obstruction. So in all of these cases, the protein will be more. Whereas means the SAG ratio will be more. Whereas in a case of late Budd-Chiari syndrome, which causes the scarring and cirrhosis and massive liver metastasis, all of this thing, it will affect this liver parenchyma and it will not let this protein to go. So that's why here the protein will be more. Okay, here the protein will be more. So itna yaad rakho. This is how simply you can try to remember about this SAG ratio. Okay, so mostly they will ask for in your grant test in most of the platforms, but they will tend to refrain in the main examination क्योंकि थोड़ा ये मुश्किल लगता है. ठीक है. Then we came to the final part of our medicine part, which is this endocrinology. Okay, we'll take another 10 minutes to finish this one. Okay. If you see about this diabetes mellitus, हमें DKA में management करना. You know, in a case of DKA, there will be acidosis. Okay, there will be acidosis, and it is because of this mostly type 1 diabetes mellitus. So हमें क्या करना है? Because of this acidosis, there will be dehydration will be there. There will be more vomiting will be there. Okay. Okay, there will be more vomiting will be there. So in such cases, what will happen is that we need to replace the fluid. Along with this, we need to bring down this glucose level. Yeah, we need to bring down this glucose level. So हमें fluid देना. So mostly we'll prefer this giving oral. Then along with this fluid, we'll bring down this glucose level with this IV regular insulin. Okay, and we know this ketoacidosis. This ketoacidosis will diagnose based on this ketone body, which is beta hydroxybutyrate level. Based on this beta hydroxybutyrate level, itna yaad rakho. So here we'll give oral means regular insulin, which is given as IV. Okay, then we'll need to keep in mind about this potassium levels as well. In the case of diabetic ketoacidosis, and once you give insulin, there will be a decrease in glucose level, and once it is a nominal level, you need to start supplement with the glucose as well. So you need to give here insulin along with this IV fluids. Then about few oral hypoglycemic drugs. So whatever the patient might be, we'll start with usually metformin 500 mg. So remember, and there will be no risk of hypoglycemia, and it causes maximum reduction in the HbA1c. And as a side effect, it can cause megaloblastic anemia and lactic acidosis. ये दो चीज कर सकता है. One is this megaloblastic anemia. Next one is the lactic acidosis. And next group of drugs, they are known as glitazones. Rosiglitazone, pioglitazone. They are this PPR gamma agonist. Okay. They are activating the stimulating of this PPR gamma, and they reverse this insulin resistance. Okay. And but the problem is that they will be having this hepatotoxicity, but the maximum hepatotoxicity will be seen with proglitazone. Fine. And these drugs, they also cause sodium and water retention, so it should be avoided in CHF and hypertension, and it can predispose to this osteoporotic fractures. Okay, just remember. And it can cause MI, and it can cause urinary bladder carcinoma as well. Okay, the MI is by this ROSI, and urinary bladder is mostly by this pioglitazone. Okay, you just see one more time because it is a bit difficult to cramp, but you try to remember, at least know about this metformin. It causes this megaloblastic anemia and lactic acidosis. Fine. And here this one hepatotoxicity will be caused by this most of these glitazones. Fine. And about this acarbose, we know it inhibits this intestinal absorption of this carbohydrates. Okay. So because if it inhibits this absorption of this carbohydrates, so क्या कर सकता है? So it will cause staying of this carbohydrates into this bowel. तो ये क्या होगा? It will cause increase in the formation of gas. तो flatulence ज़्यादा होगा. So it is contraindicated in the case of inflammatory bowel disease. And we have this GLP-1 analog and GLP-2 analogs. Remember this one analog, which is used in a case of type 2 diabetes mellitus, like exenatide and liraglutide. Whereas this type 2, it is used in a case of short bowel syndrome, where if because of some disease, for example, inflammatory bowel disease, you removed some part of colon, or because of obstruction, you removed some part of small intestine. In such cases, there will be a small amount, like less than 200 centimeter of this bowel will be left. So in such cases, you will use this GLP-2 analogs. Okay, and we have this next more class which is known as DP. Remember, Sita is a ladki. So if ladki hai, then she should keep a good DP. So remember, DP P4 inhibitors, which is the 𝗧𝗵𝗶𝗀. It is the 𝗧𝗵𝗶𝗀, and we know it causes pancreatitis side effects, and most of the gliptins, it causes renal failure, whereas linagliptin can be used in the case of renal failure because it undergoes metabolism in the liver. Okay, next one, this is the SGLT2 inhibitors. We know this SGLT2 inhibitors kya karega? It will block the absorption of this glucose from the kidney, so it will cause glucoseuria. So they will give you the history. There is a patient who is taking a oral anti-hypoglycemic drugs, and these drugs, because of this taking this drug, the patient is experiencing this increase or recurrent episodes of urinary tract infection. So he is experiencing this case of urinary tract infection. So this is typical for this case of SGLT2 inhibitors usage. Remember. Next, about this Graves' disease, we know this Graves' disease, it is the increased thyroid hormone. Yeah, thank you, Dr. Rahul, thank you, Dr. Naresh. Yeah, thank you. Yeah, good. Then about this autoimmune diseases, you just remember this Graves' disease, it will be having this glitazone can also cause glucoseuria. Gliflozins, that is what this is this SGLT2. These are this gliflozins. Remember, glucose flows in urine. That is gliflozins. Okay, glucose flows in urine. That is this gliflozins. That's why it causes glycosuria. Agar glucose aa raha hai urine mein, to maja hi maja hai. This bacteria will go into the urine and it causes growth. That's why it causes this UTI. Okay, I guess you got it, guys. Okay. Then about this Graves' disease, we see it will be associated with this HLA of HLA-B8 and DR3. HLA-B8 and DR3, and it will be antibody against this thyroglobulin and thyroid peroxidase and thyroid stimulating hormone. So ये क्या करेगा? It is an antibody. It won't go and decrease it. It would go and still stimulate. Means it will go and ungli करेगा. Means it will go and stimulate the thyroid gland. जैसे ungli करेगा वो छिड़ेगा. मतलब it will cause means it will cause irritated, and it will cause production of this more thyroid hormones. Right? So it will be presented with the features of ophthalmopathy, like thyroid ophthalmopathy, you know, right? Acropathy, thyrotoxicosis, and few dermopathy conditions. Remember, and we know this will be increased by this T3, T4 will be increased, and because of this feedback mechanism, TH will be decreased. Okay, तो इसके लिए हम क्या करेंगे? तो diagnose के लिए we can use this method, which is detecting this long-acting thyroid stimulating antibody. और ट्रीटमेंट के लिए हम कार्बामेजोल या मेथामेजोल दे सकते हैं, लेकिन प्रेगनेंसी का फर्स्ट मंथ में आप बाइक में भी चल सकते हो या बस में भी चल सकते हो और कार में चल सकते हो, लेकिन आफ्टर 2 months you should go only in car, because you will become posh and you will be given more care, right? So remember, in second and third trimester you will use carbamazole, लेकिन first trimester में you can use any public transport, that is this propyl thiouracil. So propyl thiouracil, it is used in first trimester, but second trimester में हम car से चलेंगे, that is this carbamazole. ठीक है? Yeah, that's it. Remember. Next, about this Hashimoto thyroiditis, it is the most common cause of hypothyroidism. It is the most common cause of hypothyroidism है, ठीक है? And it causes this antibodies against TPO and thyroglobulin and TSH receptor, and it's related to this, yeah, CD4 and CD8. And on evaluation, you will be able to see this Hürthle cells and lymphocytes, and clinically there will be enlarged thyroid gland. Sometimes that might be painful as well. And finally, it will be resulting in hypothyroidism. अगर hypothyroidism है, then we'll give thyroxine as a supplement. Okay, thyroxine देंगे as a supplement. Fine. And about this men syndromes, तुम्हें याद रखना this 𝗵𝗶𝗶. Okay, see, pituitary tumor, parathyroid tumor, and pancreatic tumor. This is seen in a case of 𝗵𝗵 syndrome, which is this MEN1 syndrome. Okay, which is this MEN1 syndrome. 2A, it is known as Stippel syndrome. Stippel syndrome है, remember it is TAP. Okay, thyroid malignancy, which is this medullary carcinoma thyroid. हमें पता है medullary carcinoma, it produces this calcitonin, so we'll use them as tumor marker, and it will produce a cal type of amyloidosis. ठीक है? Then it is thyroid malignancy, and A for adrenal pheochromocytoma, then P for parathyroid adenoma. P for parathyroid adenoma. ठीक है? Then about 2B, which is this MEN2B, which is also due to this red gene mutation. Here there will be this thyroid malignancies, and adrenal. There will be TA, and along with this other features, there will be this morphinoid habits and ganglioneuromas. Morphinoid habits and ganglioneuromas. If men 1, along with this gonadal tumors, it is what it is, this men 4 syndrome. It is the men 4 syndrome. Yeah, good doctor. Yeah, good doctor. Well said. Fine. And this hyperparathyroidism, mostly they will tell there is a patient who is presenting with features of hypercalcemia, like renal stones, abdominal moans, psychotic gones. So this will be mentioned in the questions, and there will be increased level of PTH, and there will be increased level of calcium. And on X-ray, you will be able to see there is small lucent areas where there is a filling of blood. So it is known as due to the hemorrhage. So it is known as brown tumor. Or mainly you need to know there is on medial side there will be this absorption. On radial aspect you will see subperiosteal bone absorption in the phalanges, and you will see this alternative bands. It is known as Rugger-Jessie bands, and this is the brown tumor. And on skull you will see the salt and pepper skull. And for diagnosis you will use this 𝗧𝗵𝗶𝗀 scan for this hyperparathyroidism. Okay. And Conn syndrome, remember Conn syndrome, it is the overproduction of this adrenal hormones. Okay. There is a tumor of this adrenal gland which is causing this Conn syndrome. Okay. And so there will be overproduction of this aldosterone which causes this hypertension and hypokalemic alkalosis. हमें पता है, means it will go and act on this ENaC channel. If it go and act on the ENaC channel, it will absorb more sodium and it will send more potassium to the outside and also more hydrogen to the outside. So क्या होगा? If more potassium and hydrogen goes out, then the body will go under this metabolic alkalosis and there will be hypokalemia. तो यही होगा. Okay. And इसको स्क्रीन करने के लिए हम टेस्ट यूज करेंगे. रिमेंबर, अगर कॉर्न मतलब तुम्हें पता ना कॉर्न, दिस कॉर्न देखिए, दिस सॉल्टी कॉर्न, दिस बॉइल्ड कॉर्न, ठीक है. अगर कॉर्न में हम क्या करेंगे, हम नमक डालेंगे. सो रिमेंबर, फॉर दिस कॉर्न सिंड्रोम हम नमक डालेंगे. सो विल पुट salt and will eat. Likewise, here we'll use a test which is known as salt loading test, also known as saline infusion test. Okay. For treatment, we'll use this blockers as spironolactone. Then Addison's disease or Addisonian's crisis, it is due to this hypofunction or this destruction of this adrenal gland, resulting into this there will be a decreased glucose will be there will be a hypotension will be there, and because of this pituitary tell to stimulate this adrenal gland, and so there will be a more ACTH. So इसी वजह से there will be a hypotension, there will be hyporesponsiveness, there will be the features of this hypoglycemia, but there will be a hyperpigmentation. So these are the few things you need to remember. So there will be high ACTH and low cholesterol. So there will be the salt wasting, postural hypotension, hypoglycemia and hyperpigmentation. तो इसके लिए हम क्या करेंगे? We'll do this test which is known as ACTH stimulation test. ठीक है, बस इतना याद रखो. And finally, the final slide for medicine, it is the Cushing syndrome. The Cushing syndrome, what is the earliest change you will see? It is known as what? It is known as dineural variation. It is the dineural variation change of this cortisol. Fine. And its clinical features, there will be this central obesity or centripetal obesity, along with this lean limbs. Okay, centripetal obesity. And this is what? This is this lemon on stick appearance. And this will be having this same goal. There will be this moon faces. Okay, moon faces will be there, and there is a presence of this hair. So large hair will be there, moon faces, and with more hairs on the bodies. And on screening, you will use 24-hour urinary cortisol level, and if it is increased, then we'll use this overnight dexamethasone suppression test. Overnight dexamethasone suppression test. Okay, usually we'll use low dose dexamethasone suppression test, but to differentiate between this other ectopic secretions like Cushing syndrome, like to differentiate it, we'll use this high dose dexamethasone suppression test. बस इतना याद रखो. Yeah, there will be this purple stains will be there. There will be features of this hypertension will be there. ये सारे आपको, and hump will be there. These are the features of Cushing syndrome. Okay, Cushing syndrome. And finally, if you see this type of patient, the history will be given. There is a patient who's underwent hip replacement surgery, and now presenting with features of breathlessness. Okay, he is on bed rest for 5 days. Okay, and this X-ray will is given. What is the diagnosis you will think of, guys? Yeah, good, Dr. Anar. It is the pulmonary thromboembolism. And in the case of pulmonary thromboembolism, the chest X-ray feature include this Hampton's Kump and there is this few more signs like there will be this pleasure sign and there will be Palla sign, where this right pulmonary artery will be enlarged. So these are the features of what? These are the features of pulmonary thromboembolism. And on ECG, you see the most common feature, it is the tachycardia. It is the tachycardia, and there is S1, Q3, T3 will be there. So, okay, just it is also one of the ECG findings in pulmonary thromboembolism. Okay, and to diagnose it, what he will do? He will do CT pulmonary angiography, and for whether the presence or absence, we do D-dimer. So for screening, we'll do D-dimer. For definitive diagnosis, we'll do S1, Q3, T3. For definitive diagnosis, we'll do what? We'll do the CT pulmonary angiography. D-dimer. Okay, remember. So that's it, guys. That's it. The most important must-know topics you need to remember for this medicine part. I know it took bit time, but it will be what for sure. Okay, so just have a revision and have a small tie break. We'll meet up at 12:40 or 12:45. Okay, 12:45 we'll meet up. Okay, just remember one thing, like whenever you dream big. Okay, dream big. So put your ladder to the moon so that you can reach the sky. So always dream big and believe big that you can do it, and you will do it. Okay, that is my assurance. Fine, we'll catch up after break. If any doubts, please let me know in the comment section. Big breaks. Now we'll take up a bit break after a while. Okay, like around 1:45 we'll take the next break. Okay, 1:45 too. Okay, good. If any, please put up in the chat section. We'll help you to answer it. Right? Okay, guys, see you.
Hello. Hello, doctor. Welcome back to the session. I guess we have a small break, and we start with the surgery part. Whether the audio and video is clear?
Hello doctors, welcome back to the surgery part. Are you able to hear me with perfect audio? Is there any issues? Can you please confirm from your end? Hello guys, yeah, can you confirm in the chat section? Yeah, okay, thank you Dr. Anar. Thank you Dr. Venki. Yeah, I guess the things are well settled. We'll start with the surgery. Yeah, good afternoon Dr. 𝗲𝗵𝗀𝗀𝗀. Yeah, good afternoon. Yeah, thank you for the confirmations. Yeah, we'll take around 1 hour 15 minutes of our discussion, the surgery part. Then we'll have a good lunch break. Then after that we'll continue with surgery. Then we'll finish up with OBG. Okay, as I told you, if you do these subjects very well, like there is a 90 marks from these subjects. Okay, there are only few concepts that you need to listen. Okay, if you know these few concepts, you will get at least 70 questions. Like even you can get even 70 questions from this PDF, and out of which you need to use your common sense for sure. Okay, that is the main role. Okay, you need to use your common sense along with the knowledge which I have been given. Okay, if you have any doubts, please make sure like you are putting up in the chat section, we'll comment it out. Okay, we'll start with the session. It's our surgery part. Fine. And in surgery, first they will ask you about this condition which is known as breast abscess. Usually they will describe this question with a history. There is a female who is lactating her child, and now she is presenting with features of tenderness and engorgement of his breast. Tenderness and engorgement of his breast. And on evaluation, if you're able to see, when you try to mobilize this swelling, like this is skin erythema, you will able to see, and there is a redness. So when you try to mobilize the skin, like it is the swelling which is there, which is actually fluctuating, which is moving. So it is known as fluctuation sign positive. If the mass or if the structure is fluctuating sign positive, and along with this tenderness, with the features of fever, chillness, and engorgement of breast, all of these things, they are typical for this breast abscess. And based on the recent findings, recently they have told that initially what you need to do, you cannot do mammography because mammography will cause compression of the breast. So instead you can do this ultrasonography, and what you can attempt is that you can attempt aspiration under ultrasonographic guidance. So what you need to do, it is aspiration under USG guidance. So you can attempt multiple attempts, or multiple times you can do this procedure, but it will be till a certain point. If you cannot feel like with these aspirations there are minimal fluids they are coming out, then you can go for INT. But the main role, it is what it is, this aspiration under USG guidance, and along with this we know there is this abscess formation, which is actually which is due to this infections of this nasopharyngeal or this mouth sacs of this child, which is transmitted from this nasopharynx to this child to this breast through this cracked nipple or something, causing this breast abscess. So just listen this, and for this you need to give the antibiotics. So you need to give antibiotics along with multiple repeated aspiration under USG guidance. If this fails, then you go for this INT. Okay, and till this swelling and things resolve, you need to do means you need to drain the milk by either by compressing, by there will be the like manual compressing and manual extraction of this milk there, that you can use, but you should not feed the baby. So this is this ultrasound is showing this masses, and here we are putting up the needle, okay, which where you will able to see here, like here we are putting up the needles, and this is this ultrasound guided needle which we put, and this is this needle, and this is this ultrasound probe, and with this help we are removing the abscess part. Fine. This is the breast abscess management. Next, about this benign breast diseases. These benign breast diseases, most of them they are classified based on their clinical feature. Mostly this benign breast diseases, they'll be having few typical features. For example, they may present to you with some of the mass. For example, in a case of fibroadenoma, it will be present to you with the feature that it will be known as breast mouse, because it will be extremely moving. You try to catch it, it will be moving. So it is what it is, this fibroadenoma, also known as breast mouse. It is nothing but there is this small fatty deposition in the calcification causing this popcorn appearance on mammography. Fine. And it is the most common benign lesion of the breast. Yeah, good Dr. Quine. Yeah, it is the popcorn calcification, and on mammography you will be able to see it. So usually if there is, until unless there is any pain, or until unless there is any cosmetic reasons, we won't do any surgery for it. So if there is any necessary which is causing this pain because of neuronal involvement, or if it is causing any cosmetic significance, then only we remove this fibroadenoma. So how we can remove? We can remove by enucleating it, or we can do by simple excision. Okay, simple excision, and usually we'll do this curvilinear incisions around the nipple. Okay, curvilinear. Thank you for the compliments. Okay, thank you. I hope you also will be beautiful. Thank you. Fine. Like at the means like at the end of the day, whatever I'm telling, you are making it out and you are making into your examinations. Once you pass, that is the happiest moment in my life, because this one mark which you have been means which you need, are the marks which you need to pass the examination. If it comes when it comes from my teachings or my things, then it will be more like I feel very much good, and you also will be happy, I also will be happy, because like that is the good feeling when a student passes, when a teacher gets. Okay, thank you Dr. FMGE Jantwal. Fine. Yeah, you have nice motivation as well. Fine. Next one, if you see about this, few more things, this duct papilloma, like there are few features like of the breast. See, if you see, as I told you, this is the mass. Next, what is this? This is the discharge. So there are different types of discharge, and based on the color of the discharge, so you can tell what is the thing. For example, you can see like there will be the, you can call them as races, because based on the color you are telling what is the disease. Fine. So in a case of duct papilloma, it will be having this bloody discharge. And remember, it is duct papilloma. We have multiple lactiferous duct. Whereas in a case of duct papilloma, mostly it will be only one duct which will be having this papillae. Means papillae are nothing but this finger-like projections. So this is this involvement of mostly only one duct. And for treatment of this duct papilloma, what we'll do, we'll remove this only one duct by this procedure which is known as microdocectomy. Yeah, good Dr. Quine, good Dr. Anand. Fine. And then there is a thing which is known as duct ectasia. In a case of duct ectasia, it will be mostly this smoking and middle-aged female with a feature of greenish discharge. So this duct ectasia can present even with this bloody discharge, but it is significant for this duct ectasia. It is what it is, this greenish discharge. Yeah, greenish blackish discharge. Exactly, Dr. Quine, it is this greenish and as well as blackish discharge, and sometimes it may even have this hemorrhagic and serous discharge as well. Fine. So in a case of duct ectasia, it means these are the lactiferous ducts which are joining into the area of nipple. Here what will happen is this, it will be ectasic, means it will be ectasic or dilated. So for this condition where there is duct ectasia, what we'll do, we'll do a surgery which is known as conical excision of all the ducts. Okay, conical excision, which is known as Hadfield's operation, which is known as Hadfield surgery. So remember, in the case of duct papilloma, we'll just remove the affected duct. So it is known as the small one, microdocectomy. Whereas in the case of duct ectasia, there will be involvement of this most structure. So we'll do this surgery where conical excision of this involved duct, it is known as Hadfield operation. It is known as Hadfield operation. Okay, and there is one more condition which is seen in the case of smokers. If there is recurrent mastitis, if there is smokers with recurrent mastitis, it will be known as 𝗧𝗵𝗶𝗀 disease. It will be known as 𝗧𝗵𝗶𝗀 disease. It is known as 𝗧𝗵𝗶𝗀 disease. Remember, it is known as 𝗧𝗵𝗶𝗀 disease. Next, we'll come into the features or this, what are the clinical presentations this carcinoma breast can have. For example, this carcinoma breast, we know it is a breast mass, right? Once there is a breast mass, it will start involving this subsequent structures. Either it can go on involvement this ligament, yeah, a good guess, ligaments, or it can go on involve the skin, or it can go on involve these other structures like our lymph nodes, and it can go enter into our blood, and it can cause metastasis. Likewise, if it's go and block this subdermal lymphatics, if it block this subdermal lymphatics, then what it will happen is that if it goes and block this subdermal lymphatics, then what will happen is that this lymphatic fluid will start collected into the breast, and this breast will be engorged. And if you see, there will be small skin pores will be there, right? So it will be like a small opening. So when it's enlarged, it looks like a peel of orange or the skin of the orange. It is known as 𝗃D orange. 𝗃D orange appearance. 𝗃D orange appearance. Fine. Next, if you see this one, this is what? This is this nipple retraction. Nipple retraction. If you see this nipple retraction, there you will be having confusion. This two things, nipple retraction, and this is what? This is this dimpling. Okay, dimpling. Okay, so this where this girls will be like, the boys also will be having this dimpling, right? This dimples will be having. Okay, this is what? This is dimpling. And this nipple retraction, there's two main different mechanisms which for these two things. Like both of them, it looks like there is retraction, right? But both have a different reason. Okay, both have a different reason. See, if you see this, compare this as a nipple. Okay, this is the anterior part of the nipple, and nipple is being connected to this lactiferous duct. Okay, nipple is being connected to this lactiferous duct. This is the nipple, and it is being connected to this lactiferous duct. Okay, and if there is any damage, or if there is an involvement of this lactiferous duct, see, this is the outside which is shown as a nipple, and it is the connectivity or the continuity which is causing this, which is this lactiferous duct. And if there is an involvement of this lactiferous duct, so kya hoga? It will go and pull up this nipple. It will pull up the nipple. See, there is no nipple. The nipple is being retracted. So this is known as nipple retraction. So nipple retractions happens because of this lactiferous duct involvement. It is due to the involvement of lactiferous duct involvement. Remember, yeah, good, Dr. Anar. So next one, it is this dimpling. If you see dimpling, why it happens is, as I told you, this there is a breast, and the breast will be having this radial arrangement of this circular arrangement of this ligament. They are known as Cooper's ligament. And if there is one mass is there, and this mass causes this involvement of this ligament, then just at certain point this will bow down, it will go inside. So this will cause this one which is known as dimpling. This one is known as dimpling. Fine. And next, even it can come out and it can cause ulceration even, and in some cases some kind of breast cancer which may show this type of, there is a nipple retraction is there, there is this swollen or enlarged breast along with this redness and the features of inflammation. So if there is all of these features of inflammation along with this breast changes, it is seen in a case of inflammatory breast cancer. And we know inflammatory breast cancer, it is staged as T4D, whereas this 𝗃D orange जो भी बाहर से देखता है, तो it is staged as T4B. It is staged as T4B, whereas this inflammatory breast cancer, it is staged as T4D. इतना आपको याद रखना है, ठीक है? So in a case of this type of breast cancer, then we'll go for this further surgeries. क्या क्या कर सकते हैं? For example, if it is a very small lesion, तो हम क्या करेंगे? बस उस lesions को हम निकालेंगे, उसको बोलेंगे, means there will be this simple mastectomy. ठीक है? There will be, we'll removing this part, and along with this, we'll remove this nipple, areola, and soft tissue, and along with this breast tissue which is being affected. So it is a simple mastectomy, right? And we'll do one more procedure which is known as radical mastectomy. If it is enough more size, if it is in a more size, then we'll do simple mastectomy along with this removal of this 1, 2, 3 nodes. Like for example, there are different types of lymph nodes, but we classify these lymph nodes of this breast based on this pectoralis minor. Okay, pectoralis minor, like below, in posterior to it and above it. So below, posterior, and above it, will stage them 1, 2, stage 1, stage 2, stage 3 type of lymph nodes. So if there is any more involvement, then we'll do radical mastoidectomy. So and there will be, we'll remove this pectoralis major, minor muscle as well. Okay, and followed by this, we'll do one more surgery. Means because as we are removing this much structures, we need to preserve this breast for the reconstruction. Okay, in such cases, what we'll do this simple mastectomy, which is the removing of nipple, areolar, and soft tissue, along with this removal of 3 lymph nodes and the pectoralis fascia. We'll spare this muscles, we'll remove the fascia. Whereas we'll do one more surgery which is known as breast conservation surgery, in which there is a small mass, if it is involving just one quadrant. Okay, we'll remove that. But remember, in the case of breast conservation surgery, we'll give radiotherapy. We'll give radiotherapy to the area which we have undergone, which we have taken up. So remember, in the case of pregnancy, can you do breast conservation surgery? I guess what will be your answer? Guys, what will be answer? Yeah, good, Dr. Gautam. Like, yeah, we won't do breast conservation surgery in a case of pregnancy because we need to expose them to the radiation. Fine. Next, we told, like in the case of modified radical mastectomy, we need to preserve few structures. That's why we are doing this MRM. Okay, good, Dr. Gautam. Good, Dr. Rahul. Good. Well said. Then, if you see, what are the structures which is spare? For example, like we leave them to live. Okay, we leave them to live. Okay, chalo, tum jiyo. Karke you told, and like jao simran jao, jiyo apni zindagi. Like this dialogue is there, right? Yeah. So just you let them to live. Okay. So I forgot the dialogue. Okay. So if you see, this is this A, B, C, D. These structures will be preserved in the case of MRM. So this include axillary vein and Bell's nerve and cephalic vein and nerve to latissimus dorsi. Okay, so this is this axillary vein, Bell's nerve, cephalic vein and nerve to latissimus dorsi. So all of these structures will be spared or this is preserved in a case of modified red. Yeah, it is correct. Yeah, thank you, Dr. Rish. Yeah, ja simran ja, jile apni zindagi. Wow, like go simran go, live your own life. Okay, that is the same like. So yeah, all of these structures, ABCD structures, chalo jao, jiyo apni zindagi, live your own life because I am leaving you alone or leaving you to live. Okay, just remember. Yeah. Yeah, so yeah, after FMG exam, yeah, we'll live. Okay, we'll live. We won't just live, just we'll live like bindas, without any worries, without any worrying about this FMG exam. We'll live. Okay, don't worry. Yeah, that's the spirit. Just go ahead and do it. Fine. Next, the structures will be spared. It is the ABCD: axillary vein, Bell's nerve, and cephalic vein. Yeah. Okay, then the complications associated with this MRM. So what are the complications can happen? So you did a surgery. Okay, the surgery there might be having some complications. For example, if there is while doing surgery, there will be collection of the blood, right? So while there is collection of the blood, usually it will be drained by the lymphatics. And here, while doing surgery, we may impair the lymphatic flow. So this lymphatic flow impairment lead to the formation of this collection of lymphatic fluid, which is known as seroma, serous collection. So it is not a tumor, it is the serous collection of the fluid, which is known as seroma. Okay, badhiya. Then if there is damage to this nerve, what is the name of this nerve which is supplies the serratus anterior? If it is damage to this nerve, which causes this winging of scapula, which is also known as nerve to bell. Yeah, serratus anterior. What is the name of this nerve? Tell me. Yeah, what is the long thoracic nerve? Yeah, badhiya, Dr. Anand, badhiya, Dr. Conan. So it is this long thoracic nerve. Okay, badhiya, Dr. Ragul. Good. No, it is not nerve to latissimus dorsi. It is this nerve to this nerve to serratus anterior, which is known as long thoracic nerve, also known as nerve of Bell. Yeah, good, Dr. Prototype, Gautam, Rahul, and Anna. Yeah, best. Fine. Next, it can result into this. As I told you, there is an impairment in this lymphatic structure. It can lead to this lymphedema as well. Okay, it will cause swelling over the hand, which is known as lymphedema, and this can lead to this necrosis. Like once we remove the part, and we'll remove around this blood supply as well, right? So superficial part, like superficial skin, they won't even get blood supply. Or if we keep some flap from somewhere else, this flap may devoid of blood supply and it can go under the necrosis. Fine. And this may lead to a peculiar complication. They will tell you there is a female after mastectomy, okay, after mastectomy, which is 10.5 years back. Okay, now presenting with reddish blue discolorization of hands and swelling of the upper limb. This is the typical case history of a lymphangiosarcoma. Yeah, 10 to 10.5 years. Yeah, it is the typical history of what? Lymphangiosarcoma. sarcoma. And this lymphangiosarcoma is specifically known as ภิve-Treves syndrome. It is known as ภิve-Treves syndromes. Yeah, good, Dr. Gautam. Yeah, it is a late complication. Good, Dr. Quinine, prototype quinine. Yeah, good. Fine. So these are the few complications that you should remember about this MRM. Okay, MRM. Fine. Next, we'll move on to this thyroid malignancies. Yeah, Bhagam. Next, about this thyroid malignancies. If you see about this thyroid malignancies, there are different types of thyroid malignancies, and you need to know just few differences, how they are different. See, this papillary cancer, it is due to the gene mutation of BRAF. Follicular, it is due to this RAS-P10. Okay, iska to hame. Then medullary, we know it is due to this RET, and we only studied now. It is this MEN2A association is there. Okay, which is this RET oncogene present. Then anaplastic cancer. Okay, anaplastic cancer, it is P53. So तुम्हें इसमें क्या तुम्हें याद रखना? See, this papillary cancer and follicular cancer, they are well-defined cancer because they actually originate from this proper thyroid follicles. Okay, they originate from the proper thyroid follicles. Okay, and there are few risk factors you need to know. Like papillary cancer, it occurs because of any irradiation. For example, you did a breast surgery, and for this you irradiated him. Okay, or her. Okay, so after this irradiation, then there is few radiations got stuck or attacked this thyroid gland and are got exposed to this thyroid gland, then this can lead to this papillary carcinoma thyroid. Or in a case of hypothyroidism, we studied, right, Hashimoto thyroiditis, it can cause even this papillary cancer. Or this initially in child, there will be this midline swelling which is known as thyroglossal cyst. This thyroglossal cyst, if we didn't remove, this can lead to this condition which is known as papillary carcinoma thyroid. It can transform. Okay, yeah, good. Whereas follicular, it is due to this main of multinodular goiter. Okay, in this, if you see papillary carcinoma thyroid, you want to know it is spread by the lymphatic node. See, it has the three it has this three predisposing factors. One is this irradiation, Hashimoto thyroiditis, and thyroglossal cyst. Whereas this papillary carcinoma, it spread through the lymph nodes. So the most commonly it will be having this aberrant thyroid glands. Means here is the thyroid gland, but this nodes where if you do any thyroid scintigraphy, you see here on the side of the neck as well, there is a presence of thyroid gland because it's spread by the lymphatic node. So तुम्हें पता है, it is spreading by lymphatic node. So while doing surgery, you will remove thyroid and you will also do for this modified radical neck dissection. तुम neck को भी dissect करोगे और देखोगे is there any involvement of the lymph node. So you will do thyroidectomy along with modified radical neck dissection in a case of papillary carcinoma thyroid. Okay. Whereas in a case of follicular carcinoma thyroid, follicular carcinoma में तुम क्या करोगे? Yeah, staging of cancer, if you able to read once, it's if you ask me, it is better. But if you couldn't remember it, just remember about its management only. Okay, management and simple things. For example, T4B, it is for what any of these outer changes, like for example skin erythema is there, PUD orange is there. Okay, or if there is any inside involvement, for example intercostal muscle involvement, it is what it is T4E. And if there is any involvement of this inflammatory breast cancer, it is T4D. So मोटा याद रखना, ठीक है? Don't try to indulge everything. Okay, just see superficially. Fine. And next, yeah, I was discussing about this follicular carcinoma. This follicular carcinoma, it's spread by this hematological route. So if it is spreading by this hematological route, obviously it will be spreading through the blood vessel. Okay, इतना याद रखना. So you don't need to do modified radical dissection in a case of follicular carcinoma thyroid. तो पूछेंगे, in a case of papillary carcinoma thyroid, you will do thyroidectomy along with modified neck dissection. Whereas in a case of follicular, तुम्हें modified radical neck dissection करने की जरूरत बिल्कुल नहीं है. तुम्हें बस थायराइड ग्लैंड को निकालना है, ठीक है, और डिस्टेंट मेटास्टेसिस को देखना है, ठीक है, फाइन. वैरस इन केस ऑफ मेडुलरी तुम कर सकते हो, उसमें कोई दिक्कत नहीं, क्योंकि ये दो लिम्फेटिक भी हेमाटाइटिस प्लस भी करेगा. ओके, एंड व्हाट आर द फाइंडिंग्स यू विल सी हियर इन केस ऑफ पैपिलरी कार्सिनोमा? यू विल सी दिस टाइप ऑफ फाइंडिंग, दिस encircling findings, this calcium deposition, which is known as 𝗲𝗵𝗶𝗀 bodies, which are actually what? These are this like concentric calcification, which is actually what? Which is this dystrophic calcification. Yeah, good Dr. Quinine, good Dr. Gautam. Yeah, well. Well play. Fine. Next, you will be able to see this type of bare nucleus or empty nucleus. It is known as what? It is known as orphan anenuclei. Orphan anenuclei. Fine. Yeah, good Dr. Quinine. Yeah. Good, Dr. Anar. Yeah, good, good, good. It is like, see, this 𝗓𝗵𝗶𝗀 is seen in a case of papillary carcinoma thyroid. It is papillary carcinoma thyroid. Fine, remember. Then if you see, we'll do one more investigation, which is known as FNAC. FNAC means what you will do, you will prick the needle, and with this pressure, you will take up the sample, and you will just push into the slide, and you will see what are the cells in it. Whereas in a case of follicular carcinoma thyroid, I told there is an involvement of this blood vessel. So if there is involvement of the blood vessel, it should cross this thyroid capsule. It should cross this thyroid capsule. So thyroid cross capsule को cross करने के लिए, it should invade this thyroid capsule. So you need to tell that this is follicular adenoma or follicular carcinoma only by biopsy, because there you can see this capsular invasion. Okay, like you cannot decide something based on just one phase, right? You should see both the phases. So in the case of follicular carcinoma, you cannot decide or you cannot diagnose using this FNAC. You need biopsy to differentiate between follicular carcinoma to follicular adenoma. Okay, इतना याद रखो. So as I told you, here you will see orphanine nucleus and some bodies. Okay, and here in the case of follicular, there is no use of FNAC here. Okay, so we need to do biopsy. Mostly the biopsy, it is what it is, lobectomy. After removal of this only, then we'll do the surgery. Fine. Okay, whereas medullary carcinoma, we already discussed, it will be involving it's because of this parafollicular C cells. So it is because of the C cells involved. So there will be involvement of this calcitonin, and there will be involvement of this calcitonin leading to this amyloid deposition, which is this ACAL type of amyloid. Fine. And this anaplastic cancer, it mostly causes compressive symptoms, like how it will cause fibrosis around it, and it will cause compressive symptoms like dysphagia and dyspnea. Okay, dysphagia and dyspnea. Is there any audio lag, guys? Hello? Is there any audio lag? Just a second. Yeah. Check. Is there any lag? Hello? Hi. Yeah. See, there is a lag. Check it. Yeah, there is a lag. Yeah, we are working on it. Just give us. Yeah, hello doctors. Can you check it once? Is there any still lag here? There's a lag. Still lag. Yeah, hello doctors. Can you check it once? Is there any still lag here? Can you check it again, guys? Still lag. Hello, doctors. Can you check it once? Is it fine now? Yeah, it's working fine. Yeah, thank you for the tech team. Okay, thank you for your patience, guys. Like, yeah, we'll go ahead. As I told you, in a case of anaplastic cancer, if you see this anaplastic cancer, it will cause this compressive symptoms. What? Okay, now it will be one with there. I reduced it. Yeah. In the case of anaplastic cancer, if you see, it will be having this kind of compressive symptoms. It will be having this compressive symptoms. It's still coming? But hello? Yeah, yes, I completed. Yeah. Hello? Yeah. I guess it's fine now, right? There's no problem. Yeah. If you see it, this anaplastic cancer, is it all fine, guys? Is there any issues? All perfect, right? Yeah. We'll go ahead. Yeah. If you see this next one, anaplastic, it causes this mainly this compressive symptoms. It will cause this compressive symptoms. So compressive symptoms includes this esophageal symptoms, which causes the dysphagia, and if it compresses the trachea, it causes what? It causes the dyspnea. So these are the symptoms which is caused by this anaplastic cancer mainly. And as I told you, papillary, it will involve the lymph node, so it will cause, we need to do thyroidectomy. Along with that, we need to do lymph node dissection, which is this modified radical neck dissections. Whereas in the case of follicular carcinoma thyroid, it won't involve the lymph node, so we don't need to do this modified radical neck dissections. Fine, that's it. Whereas in the case of medullary carcinoma thyroid, it will spread by both lymphatic route and also hematogenous route. So in such cases, then we need to go for modified radical neck dissection. Right? And if we are going for surgery in the case of medullary carcinoma thyroid, we should be ruling out to this other malignancy, because it can be associated with this MEN syndrome. अगर MEN syndrome के साथ होता है, for example, if it is a MEN 2A syndrome, it will be associated with this adrenal pheochromocytoma. it can be associated with this adrenal pheochromocytoma. तो इसीलिए हमें सर्जरी जाने के पहले we should be ruling out this all men syndromes. ठीक है, बस इतना याद रखो. So in the case of anaplastic, I told you it is a compressive symptoms. So to remove it, we'll remove from here. It is the isthmus part will remove so that it will start or it will stop compressing the trachea and esophagus. Okay, right. We'll move on to few more thyroidectomy procedures. If you see, this is the total thyroidectomy where we are removing this entire part of this thyroid. For example, in the case of follicular carcinoma thyroid and medullary carcinoma thyroid. Fine. Whereas if in any minor pathologies, for example, in the case of multinodular goiter, if there is no tumor pathologies or carcinogenic pathologies, then we'll only leave or only cut this half part of this thyroid. But remember, with this half part, we always remove the isthmus. Okay, with this hemithyroidectomy, we'll remove always the isthmus one. Okay, remember. So it is what? It is this hemithyroidectomy. Next one, if you see, you are leaving some part of this thyroid gland which is left behind. So it is what it is known as Hartley-Dunhill procedure. Okay, so most of this gland and the isthmus will be removed, but whereas this some part of this isthmus which is near to this nerves, if we leave it, it is known as what? Hartley-Dunhill procedure. It is known as Hartley-Dunhill procedure. And the same way, if we'll do near total thyroidectomy, there are these two laryngeal nerves, which are mostly this recurrent laryngeal nerves, which will be passing nearby. So to prevent this injury to them, we'll leave on both sides. So it is known as near total. If we leave on both sides, it is known as near total. And if it is leaving more, like when compared to here, it is just around 1 gram. So if you are leaving more around 4 to 8 grams, then it is known as subtotal. If it is more than 4 to 8 grams, then it is subtotal. If it is around 1 gram on both sides, it is known as near total. Bas itna yaad rakho. This is the type of thyroidectomy you need to remember of, and these are the few thyroid malignancies you need to remember. Okay? This will move on to this thyroidectomy. So when you do this thyroidectomy, you can encounter multiple complications. So most common complication it is this hemorrhage. If you see this hemorrhage, it is mainly from this superior thyroid artery. It is mainly from this superior thyroid artery. So once you need to remove the thyroid gland, you will clamp near the gland mostly, because to prevent injury to the nerves, and also you prevent ischemia to this parathyroid gland. So you will close this. If there is a thyroid gland, you will try to ligate as early as possible, means as close as possible. Okay, remember. Okay, in such scenarios, you need to put ligature to this artery which is coming, which is this superior thyroid artery. So in some cases, in some unfortunate situations, the ligature and the sty you put, it will remove and it can cause hemorrhage. And this hemorrhage is what it will do, it will go and collect in behind this suture. Okay, in the subcutaneous layer, it will go and collect, and what will happen once bleeding is happening, and it will cause compressing this trachea, and it will cause neck compression and respiratory distress. Okay, so in such cases, हमें क्या करना होगा? We need to remove the suture and we need to drain the hematoma. Okay, we need to remove the suture and drain the hematoma. So to prevent this type of complications, हम क्या करेंगे usually? Once we done with this surgeries, we'll keep a negative suction drain, ताकि वो जो भी blood आएगा, we need to remove it off. We'll try to keep on removing it. So it is the one of the complications, which is the hemorrhage, and how we can prevent it. Okay. Next, if you see about this. Next one, this will be presented with this difficulty in respiration. So first one, as I told you, there is a formation of hematoma. This can be due to the slippage of ligature. तो तभी हम क्या करेंगे? We'll shift them to the OT. उनको OT ले जाएंगे. फिर उसके बाद we'll remove the suture and we'll remove the hematoma. Fine. Next, in some cases, as I told you, there is this recurrent laryngeal nerve. We should be very cautious. So if we injure this nerve, we know most of the muscles of this larynx will be supplied by this recurrent laryngeal nerve. So if there is any unilateral, then other side can manage. But if there is bilateral recurrent laryngeal nerve palsy, then what will happen? The only abductor of the vocal cord, which is posterior cricoid, it also go to the palsy, leading to this respiratory distress. So leading to this respiratory distress, yaad rakhna, or difficulty in respiration. Then there will be this thing which is known as laryngomalacia. Okay, what will happen is that because of this can lead to this collapsing of this trachea and larynx. And because of this, like if you ligate it, and unfortunately what you do, you injure to this parathyroid gland, and because of this calcium hemostasis has been disbalanced, and because of this what will happen is that the calcium levels in the blood will start decreasing, and it leads to this type of condition. Previously In last FMG, they given this word for the first time. It is known as laryngismus and stridulus. It happens due to this complication of this thyroid surgery, which is decrease in the calcium level. So this is one of the complication which is due to this decrease in calcium. Okay. फिर उसके बाद आगे आते हैं edema to the vocal cord. You can injure that, those you can cause edema. Then, as I told you, there are few more nerves which is passing nearby. One is recurrent laryngeal nerve. Next one is the internal laryngeal nerve. If you injure this recurrent laryngeal nerve, the patient will be having difficulty in respiration, because the only abductor which is working, it also will be paralyzed now. Fine. Then sometimes if you injure this internal laryngeal nerve, then you will cause this paroxysmal cough. Fine. And obviously, if you remove this thyroid gland, it will be having what? It will be having this hypothyroidism. तो हमें क्या करना होगा? We should supplement them with lifelong thyroxine. ठीक है, याद रखना. Yeah, good, Dr. Anna. Fine. Then, if we accidentally remove this parathyroid glands, then this may lead to this hypocalcemia, which is mostly seen after 2nd to 5th day after post-op surgery. Okay, after the surgery. Fine. And then we'll move on to the next topic, which is this differentiating between this indirect and direct hernia. See, remember just one word, direct hernia. See, this direct hernia, it won't pass through this deep inguinal ring. Direct hernia, it won't pass the deep ring. So, iska matlab kya hai? The meaning of this is this: the direct hernia, it won't go through this deep inguinal ring. It will go through this superficial ring if possible, or else. और इसका दूसरा मतलब है, then indirect inguinal hernia, for definitely it will pass through this deep inguinal ring. ठीक है, इतना याद रखना. See, so this is the direct inguinal hernia, which is just protruding out directly. Whereas in the case of indirect inguinal hernia, तो क्या होगा? It will pass through this deep inguinal ring, and it will pass through this superficial inguinal ring as well, and it will cause this manifestation. लेकिन if you see this direct one, it will directly pass into this skin, and it can pass to the superficial one, but it won't never pass to this deep inguinal ring. और इधर ही एक triangle बनाते हैं. It is known as what? It is known as Hasselbalch's triangle. And this triangle, it is between this inferior epigastric arteries and to this rectus sheath. Okay, and this rectus sheath, and this direct inguinal hernia, it passes through this Hasselbalch's triangle, and it lies medial to it. ठीक है, Hasselbalch's triangle के through ये direct hernia जाता है, and it won't involve this deep inguinal ring. It won't pass through this deep inguinal ring. Whereas this indirect hernia, it will pass through the deep inguinal ring, and it won't pass inside this. It will pass mostly lateral to it. You see here the formation of triangle, so will be always lateral to it. Okay, remember. Then they will ask you, this superficial inguinal ring, it is due to the defect in which of the following component? Okay, yeah, remember. Yeah, correct. Then if you see this superficial inguinal ring, it will be what? They will be asking which of the following component will form the superficial and deep inguinal rings. This deep inguinal ring, it will be formed because of this fascia transversalis, whereas the superficial inguinal ring, it is due to the defect in this external oblique. This superficial inguinal ring, it is due to the defect in the external oblique, whereas this deep inguinal ring, okay, it is due to the defect in the fascia transversalis. So these two questions they will ask you. Okay, so as I told you, the entry is of indirect inguinal hernia, it is the deep ring, and the exit, it is the superficial inguinal ring, and direct, it will be entry into the Hasselbalch's plexus. इतना याद रखना. Next, what are the procedures which we do for this? We use News classifications for hernia as well. Okay, remember it. And what are the surgeries which we can do for this hernia surgeries? Okay, if you see in the case of direct hernia and indirect hernia, we do different type of surgeries. Like we can keep mesh. If you keep mesh, it is known as what? It is known as hernioplasty. And if you doesn't keep mesh, okay, if you're just you can do multiple things. For example, you're just opening the sac and just reducing the content, and you are coming back and suturing it. So it is known as herniotomy. And once you open the means once you open and reduce it, but and also you are repairing this posterior wall, and you are repairing the posterior wall, it is known as herniorrhaphy, or you try to suture it out, it is known as herniorrhaphy. Whereas in a case of hernioplasty, you reduce it and then you keep a mesh so that it won't protrude back again. So it is known as hernioplasty. So in a case of hernioplasty, what you will do, you will keep a mesh. And remember, mostly this mesh will be made up of proline, and it will be in lightweight in nature, and the pores will be large in nature, and proline or polypropylene mesh, and it will be hydrophobic. It won't absorb the water, because if there is absorption of water is there, the size of this mesh may increase, decrease, may increase and decrease, so it can decrease the tensile strength. So that's why we'll use this hydrophobic mesh. So this is the mesh. And in recent FMGE they asked, where you will place, like in a case of hernia, there are multiple places you can place the mesh so that it will prevent the recurrence. See, this is the peritoneal layer, okay, this is the peritoneal layer. If you are keeping them below it, okay, that is just keeping them below, there are three things. One is onlay, inlay and sublay. Onlay, inlay and sublay means, onlay means above, means like just you are keeping above. Inlay means just see, you are keeping above, it is this only. And if you are keeping in between, it is known as inlay. If you are keeping in between, it is inlay. And if you are keeping below, if you are keeping the mesh below, it is sublay. So see, if any hernia need to come, if any of this hernia need to come, it need to pass this below one, then it need to pass this above one, come in between, then it will pass this above one. So wherever if you can keep, you just keep, and you will prevent the coming out of the hernia. Okay, that is the main funda. That is our main funda should be there. Okay, so if you see the first one, if you keep it below, okay, below peritoneum, it is known as sublay, which is inside the peritoneum. So it is what sublay intraperitoneal. But if you keep it still below this rectus sheath, but if you keep it in front of the peritoneum, it is known as sublay preperitoneal. It is known as sublay preperitoneal. Okay, then if you just keep behind this rectus abdominis, it is known as sublay retromuscular. You're just keeping behind the muscle, so it is known as sublay retromuscular. And if you are keeping in between this rectus abdominis, it is known as inlay procedure. It is known as inlay. And if you are keeping outside this, then it is known as what? Then it is known as onlay. If it is you are keeping above it, it is known as onlay. So okay, onlay, inlay and sublay. Okay, onlay, inlay and sublay. Just remember, fine. And they will ask you, what is the most common nerve which is being injured in a case of hernia repair? The answer is what? It is this ilioinguinal nerve, which is the most common nerve which is injured during this hernia surgeries. Fine. Next, we'll move on to this trauma scoring. Yeah, good, Dr. Anar. It is this ilioinguinal nerve. Then we'll move on to this trauma part. In a trauma part, first you need to know it is this GCS scoring. You know, it looks very simple, but on certain point you will take confusion. So remember, don't get confused with simple things and make things simple as simple, and don't get confused in it, and make sure you are getting these questions correct in your main examination. So GCS score, remember it is, yeah, in a case of laparoscopy if you are doing, then it is this lateral cutaneous nerve of thigh. The patient will be complaining that he is having this radiating pain on the lateral side of this thigh. Okay, lateral side of the thigh, that is known as lateral cutaneous nerve injury, which is seen in a case of laparoscopic herniotomy. Correct, guys, correct. Then this about this GCS scoring, you know, if you know this mnemonic, it is well and good. If not, just remember it is EVM. So remember it is EVM. It is 4, 5, 6. So the best one here, it is the motor. So assessing the motor response, it is the best one. So that's why given the maximum point. Fine. See, you need to know the first one. So the first one, it is always spontaneous. So if this eye opening will give 4 points. Like first, if it is spontaneous, first if the patient is opening and closing by his own, then it is E4. If he is opening to a stimuli like voice, if he is opening, you are calling him, "Aapka naam kya?" means like what's your name? Then the patient is opening, then it is E3. Then you are giving this painful stimulus, then only he is opening, then it is E2. Then, but if he is not responsive, then it is E1. Okay, the minimum point, it is the 1. Okay, if it is no response, it is E1. Whereas if it is too pain while you are pinching, he is opening, then it is E2. Whereas if you are shouting, then he is answering, then it is E3. Whereas he is opening by its own self, it is E4. Next, about this verbal response. Usually when a trauma patient comes, you try to take history. When you try to take history, like based on his voice, based on his orientation itself, you can get an idea like how he is. Then he will ask you, "Aap kahan ho?" ठीक है, आप कहाँ पर हो करके means you will ask, you will start asking to him. So if he is oriented, he is telling, yeah, I'm in hospital and I'm talking with a doctor. Yeah, I guess so, Dr. Moman Moharam. Okay, yeah. The next one, it is initially it is what it is oriented, and you ask him where he's confused, whether he's in hospital or whether he's in the theater. So if he's confused, we'll give 4 points. Next, it is inappropriate responses. See, first is inappropriate words. See, inappropriate words followed by the sounds. Okay, he will tell inappropriate words whatever you ask, he will tell irrelevantly, but he will tell some words inappropriately. Okay, but if he sees like just sound he's producing, like if it is words, then it is V3. If it is just sounds, it is V2. Okay, if it is just sound, it is V2. If it is no response, it is V1. And finally, the best, it is what it is, the motor response, as I told you. So first, what you need to do is that you ask the patient to lift his hand. If he is obeying the command, it is what it is, the M6. It is the M6. And next, what you need to do, you need to pinch the hand. You need to make a painful stimuli. Okay, you make a painful stimuli. Here, see, here what he will do, means he will take a hand. Okay, he will take a hand and he will take the opposite hand and he will try to remove your hand. So he will localize the pain and he will try to remove your hand. Okay, he will try to localize it. It is the 5th point. If it will be the M5. Whereas in a case of next, for just pinching, he is unable to lift the opposite hand or other hand, he will try to withdraw. So he will try to withdraw. It is what it is, this M4. It is this M4. It is the M4. Next, remember, it is go for alphabetically. It is what? It is this flexion, then extension. It is the flexion and extension, like abnormal flexion, which is this decorticate, and then abnormal extension, it is this decerebrate. So first it will be flex, then extend. First it is what? It is flex and then extend. Fine. And next it is what? It is no motor response. So eye opening spontaneously, 2 verbal command, and 2 pain, no response. Eye opening spontaneously, 2 verbal response, then 2 pain, then no response. Okay, fine. Then about verbal response, oriented, confused, oriented 5 points, confused 4 points, then inappropriate words 3 points, inappropriate sounds 2 points, and no response 1 point. Fine. Motor movements, he can do whatever tasks you tell. Okay, he obeys the command, it is M6. If he is localizing the pain and he is able to remove the painful stimuli, it is M5. And he is withdrawing, just he is withdrawing for the painful stimulus, it is M4. And if it is initially, if it is flexion, it is M3. If it is extension, it will be M2. If it is no response, it will be what? It will be M1. So remember this and try to answer them in the examination. Don't get confused. Okay. So based on this, we'll assess like how much is the level of brain injury. Is it a minor brain injury? Is it a moderate one? Or is it a severe brain injury? So mild, moderate and severe. Okay, mild, moderate and severe. Okay, yaad rakho. Then about this condition, okay, you saw a patient who is presenting with this tire marks on the abdomen. तो आपको लगा ठीक है, इसमें तो कुछ ना कुछ तो गड़बड़ है. So there is a history of RTA which you were suspecting as a blunt trauma abdomen. So in a case of blunt trauma abdomen, yeah, they will tell, right? Yeah, you can remember it moderate. ठीक है, चलता है क्या 9 से 12. So it is what? It is 9 to 12. It is the moderate one. Yeah, good, Dr. Naresh. Yeah. Yeah, first investigation, it is always what? It is this ultrasound, which is this point of care ultrasound, which is the first what you will do. Okay, fine. First, in a case of abdominal trauma, see, first, if any case of trauma comes, you know the like what you will do, you will put cannula, you will check for vitals. This is the usual thing. Next, what you will do, you will check for, this is an abdominal trauma case. Then you think, yeah, we need to do what? We need to do this E-fast. Okay, you need to do the E-fast. If E-fast comes out to be negative, okay, if E-fast comes out to be negative, see, for example, first why I am telling why you need to check the vitals. See, if the patient is dead, okay, and you know it is an abdominal trauma patient, and what is the role of doing is E-fast in him? Is there any role? Yes, he is dead, right? So first what he will do, he will check vitals. When the patient comes, he will check vitals. That is the literally what he will do wherever you go. Okay, then you bring them. Yeah, this is abdominal trauma case. Chalo E-fast karne chalte. Okay, then you will go for this E-fast, and if there is in the case of E-fast, if we see, you will see for this 𝗵𝗵𝗀𝗀𝗀. Whether is there any presence of bleeding. Okay, like there are few other things also we'll see. I will discuss it later on. Okay, so if it is no bleeding. Okay, if it is no bleeding, what you will do? You will just observe for him and you will repeat. Okay, you will observe for him and you will repeat it. Fine. And next, if you are able to see, if there is presence of hemoperitoneum, agar hemoperitoneum mila aapko, if there is a presence of hemoperitoneum, then you need to check once again for the vitals. Are you see the reviewed vitals, like if the patient is stable or not. If the patient is stable, then you need to know, like, what is the source of bleeding? What is the source of bleeding which is causing this hemoperitoneum? So you need to know the source of bleeding by doing CECT, which is the investigation of choice. Whereas in a case of unstable patients, you cannot go and do for the CECT because he's thriving for his life. So in such cases, you need to go for emergency laparotomy. You need to go for this emergency laparotomy. Yeah, that's correct. If the vitals are stable, then you go for CECT. If the vital is unstable, then you go for emergency laparotomy. Okay, itna aapko yaad rahna chahiye. Okay. Then about this fast and fast. Previously, like we also discussed in radiology part also as well. If you see about this fast, what we will check? Like we'll check for this heart. Okay, heart, for especially cardiac tamponade. Okay, cardiac tamponade for this blood collection. Then we'll see for this abdominal corrections. We see around this liver, like Morrison pouch. Then we'll check around the spleen to check around this splenic hemorrhages. Okay, splenic hemorrhages. Yeah, good. Splenic hemorrhages, and we check around this pouch of Douglas in females, or we'll check around this pelvic region to rule out this pelvic hematoma. Okay, pelvic hematoma. Okay, hematoma. So these are the changes we used to see in fast. Whereas in fast, we found that there is one more condition which is causing more mortality. It is what it is, this pneumothorax. You know, pneumothorax, it is a clinical diagnosis, but in emergency situations it is difficult to deal yet. So we do this fast for this as well. So if you do this fast, you will add right and left thorax. Left thorax. Where you will see what? Where you will see for this pneumothorax. Where you will see for this pneumothorax. Yeah, good guys. Good Dr. Gautam. Good Dr. Puneet. So we'll do to see this pneumothorax. Fine. Once you found out, we'll see in subsequently hum kya karenge karke. So this is the initial and sequential role how we do. Right? So now you did this fast patient. Now you found out the patient is having this tension pneumothorax. Like there are two pneumothorax. One is this one is this normal pneumothorax and another one is the tension pneumothorax. Pneumothorax normally matlab we studied in medicine that pneumococcal formation seen in a case of Staphylococcus aureus pneumonia. Staphylococcus aureus pneumonia क्या करेगा? Pneumococcal बनेगा, or when sometimes this pneumococcal will rupture and cause pneumothorax. It will be very minimal. Okay, whereas in a case of during trauma, this air accumulation can, due to some of the fracture or one-way wall, this air accumulation will be on one side, and this air accumulation will be causing pushing to the opposite side. So when it causes tension to the opposite side, okay, and causing even tracheal deviation, it is known as tension pneumothorax. It is known as tension pneumothorax. और हमें पता है when there is pneumothorax, if you are able to see, there is this sign which is known as deep sulcus sign. Where you will be able to see this deep sulcus sign, and when you are able to keep your stethoscope on here, there will be no lung sounds. There will be no lung sounds. There will be no lung sounds because there is just filled with air. And you will try to percuss. When you try to percuss, then you will be able to see it is because of more air. You will be able to see hyperresonance. Hyperresonance during percussion. Okay, इतना याद रखो. Right? In auscultation, there will be absence of breath sounds, and on percussion, you will get what? You will get this hyperresonance. So there will be a presence of this deep sulcus sign. Okay, deep sulcus sign. इतना याद रखो. So, well, mostly tension pneumothorax, it is a clinical diagnosis, but sometimes it go for till radiological investigation, okay, or we can go for the CFAST, okay. So management hum based on this, hyperresonance, and based on this child or an adult, we have the management might be differ. For example, in the case of child in emergency setting, we'll put this wide bore needle at this second intercostal space in the mid clavicular line. Second intercostal space in the mid clavicular line. Whereas in a case of adults, good Dr. Anna, adults, in a case of adults, it is what? It is this fifth intercostal space at this mid axillary line. Mid axillary line, just slightly anterior to the mid axillary line. So, which is this around this triangle of safety will do. Okay. Whereas you remove the air, but still you want to check, or you want to confirm it, or you are doing as a definitive management, then you will do what? You will do this ICD insertion at this triangle of safety, which is at the level of fifth intercostal space which is at this anterior axillary line, which is at the level of anterior axillary line. ठीक है, याद रखो anterior axillary line. Fine. And next, as I told you, like this is how this forms. Like around this, if there is a history of trauma and this kind of Ellis curve or kind of Ellis curve is there, this is because of hemothorax, because blood collection acutely. Whereas if it is just a chronic condition, just asymptomatic patients come, then it should be what? Then it should be the pleural effusion. Then it should be the pleural effusion. Okay. So in the case of trauma with this features, it is the hemothorax. Okay, it is the hemothorax. Okay, which occurs due to this chest wall lacerations. And because of this hemothorax, many of the blood, it will come and enter into the lungs, so the blood volume will be less. And the treatment, it is what it is, this inserting a ICD and doing a tube thoracostomy so that we can drain the blood. Okay, we can drain the hematoma. Fine. And next one, it is what it is, this pericardial tamponade. हम already देख चुके. In the case of pericardial tamponade, there is accumulation of blood in this pericardial space. In the pericardial space, and this will show this money bag or this water bottle appearance. Okay, and it will be having this feature of Beck's triad. There will be this muffled heart sounds, hypotension, along with this increased JVP. So three classical features will be there. There will be distended neck veins, then increased JVP, and hypotension will be there, and there will be a muffled heart sounds. And treatment हम क्या करेंगे? We'll do this pericardiocentesis. We'll put a needle into this pericardium and we'll do this pericardiocentesis. Okay, and the treatment of choice, it is the surgical pericardiotomy. Okay, if it doesn't heal, we'll go surgically. Fine. Yeah, that's correct. Kusumal sign we won't see. We'll see Kusumal sign in the case of constrictive pericarditis and restrictive cardiomyopathy. Fine. And next, if you see this kind of fracture where 1, 2, 3 or more than 2 rib fracture, which is continuous. Okay, which is continuous. Ye kya? It is what? It is the flyal chest. Okay, 2 or more than 2 consecutive ribs at 2 or more places where they are being fractured, and because of this fracture, means when you inspire, usually the chest will come out, right? But here it will go in an opposite direction. We will call them as paradoxical movement. Yeah, good Dr. Rahul. It is this flail chest. Good Dr. Rahul Gautam, Ambika Quinin. Yeah, good. Yeah. So anterior, the posterior asking. So if you see the posterior ribs, mostly it will be straight in nature, whereas this anterior rib, it will be like this. Okay, it will be coming with this having the curvatures. So okay, so it is around this junction. Okay, if you're able to see, these are this posterior rib which is actually straight, and here in anteriorly as well, here you will be able to see, right, there is a mark which is coming and joining. So this is here, there is a fracture at the level of anterior rib. Okay, here at the level of posterior rib also there is a fracture. Okay, so in a case of this type of flail chest, what we'll do, we'll supplement with oxygen. Okay, supplement with oxygen and we'll give analgesia. We'll less likely you do strapping of this. Okay, fine, we'll do supplementation with oxygen and we'll give anesthesia. And in a case of flail chest which is going into this respiratory failure, तब हम क्या देंगे? Positive pressure ventilation. Like positive pressure ventilation हम देंगे, ठीक है, like BiPAP CPAP देंगे, ठीक है, yeah, good, fine. Then we'll move on to this next part, which is this hypovolemic shock. Yeah, okay, Mohammed, I'll inform to the team. Fine. Next, about this hypovolemic shock differentiation. If you see, hypovolemic shock means there is this hypovolemia, means decrease in blood volume, and decrease in blood volume, it will be because of either RTA, which is causing this hemorrhages, or fluid loss. And if there is decrease in blood volume, then whatever is there, this blood whichever going to this left atrium will be less. So if there is less blood going to this left atrium, then there will be this this will be reflected by this, there will be decrease in PCWP, and same it will go to this circulation and same will be received here. So there will be a decrease in JVP as well. So both of them will be decreased in the case of hypovolemic shock. Okay, but so if there is decreased volume going, obviously it will pump decreased level of blood only, so the cardiac output will be decreased. But if you see this afterload, the systemic vascular resistance, means because it need to supply the vital organs, so it will produce this systemic vascular resistance. So there will be a increased systemic vascular resistance and there will be a decreased oxygen saturation and decreased perfusion to the other organs, or most of the organs will be having decreased perfusion, क्योंकि कम blood है तो कम blood जाएगा. So if there is less blood only going, and it will cause only less saturation or decrease in oxygen saturation. Okay, and next if you see about this cardiogenic shock. This cardiogenic shock में क्या होता है? In the case of cardiogenic shock, there is problem at the level of heart. The heart is not pumping properly. So इसमें क्या होगा? For example, in the case of arrhythmia, fibrillations, acute MI या valve failure या cardiomyopathy in pericarditis, what will happen is that there will be enough number of bloods. The खून तो ज़्यादा रहेगा, means there will be blood, but the heart is unable to pump. This preload will be there, but this heart won't be unable to pump. So if you see the pressures of this right atria and left atria, it will be more. But heart to pump nahi kar raha hai, so it will, to the body in ratio, it will be receiving less. So if you see, this preload will be more, it has the reserve, but it will pumping very less. So this cardiac output will be more. Okay, at the same time, it will be this blood, whatever pumping less blood, it will be preserved for this vital organ. So the peripheral vascular resistance or to the skin, the blood will be very low. Fine, and because of this, it will be having decreased perfusion. So हम क्या करेंगे? हम will give this 𝗏𝗵𝗀𝗏, which is an inotrope which causes more contraction of the heart. So this is the 𝗏𝗵𝗀𝗏. Next, distributed shock, also known as vasodilator shock. मतलब when in a case of neurogenic shock, there will be a decrease in systemic vascular resistance. अगर vascular resistance decrease हो गया, तो then it will cause what? It will cause decreased blood supply to the vital organs. ठीक है? तो skin को ज़्यादा supply होगा और vital organs को कम supply मिलेगा. ठीक है? So whatever the blood, it lies in the periphery only. ठीक है? Periphery में ही है, तो इसको कम blood आ रहा, decreased blood coming. अगर कम blood आ रहा है, then what it will do? The heart is here functioning well, so heart will try to pump very fast or very more. So it means that it will pump very fastly with more blood. It will increases the cardiac output. लेकिन हमें पता है there is no systemic resistance, so whatever blood goes, it will go to this skin, and skin as a waste. So remember, it is go to the skins because the skin is having very decreased vascular resistance. तो इसी वजह से there will be perfusion mismatch होगा. ठीक है? थोड़ा बहुत जो भी मेन ऑर्गन है उनको तो perfusion बिल्कुल दिक्कत होगा. तो उसी वक्त हम क्या करेंगे? नॉरएपिनेफ्रिन या एपिनेफ्रिन देंगे. एपिनेफ्रिन देंगे because of neurogenic or septic shock. Okay, or epinephrine in the case of, if there is because of anaphylaxis, the same thing will happen. Okay, and obstructive shock in the case of tension pneumothorax tamponade, like because of this outside obstruction, the heart is unable to do its work properly. So the preload तो ठीक रहेगा, लेकिन heart ठीक से pump नहीं कर पाएगा. क्यों? If you see, this heart is being filled with blood. Okay, if it is filled with blood, okay, then the heart cannot expand. It cannot go out. So as it cannot go out, it cannot accommodate more blood. So it will pump very less blood. So it is what? It will decrease this cardiac output. So systemic vascular resistance में इसमें कोई लेना देना नहीं है. So but it will try to help this body by increasing the systemic vascular resistance, and with this the perfusion to this main organs only will be viable, whereas rest organs will be having less perfusion. ठीक है? तो इसके लिए हम क्या करेंगे? Active management. For example, if this tension pneumothorax causing this compression to the heart, तो उसको relieve करेंगे. या नहीं तो if it is this cardiac tamponade causing this collection, then pericardioccentesis करके वो खून को निकालेंगे. ठीक है? So this is the simple funda what we use for this different types of shock. How will we diagnose and how will we manage? And finally, this shock for this is this hypovolemic shock. There are different types of classifications for these shocks. This you need to remember about this hypovolemic shock. In the case of hypovolemic shock, if you see, we'll classify them based on the degree, and based on the degree classification we'll tell. If it is just small trauma and there is a less blood loss, then the blood loss will be around amounting to 15%, less than 15%. Then what will happen? Everything will go normal. Just 15%, 750 ml. Chalo chalne do. Then the BP will be normal, the pulse rate also will be normal. Whereas BP and pulse rate, everything will be normal. So you just leave them or you give them IV saline. Okay, IV saline. Okay, so IV saline, and everything will be mostly normal here. Whereas in the case of stage 2, where 15 to 30% of the blood will be lost, around 1500 ml का blood lost हो गया, तो तब क्या होगा? तब there will be increase in heart rate. There will be increase in heart rate. There will be increase in heart rate, but it will be minimal. Whereas the main differentiating factor is the heart decreasing in the BP. So in stage 2 there will be a decrease in BP. Stage 2 there will be a decrease in BP. तब हमें fluids भी देना है. If हो सकता है तो we can start with blood transfusion. In stage 3 we see there is amounting to 40% of the blood loss. So around 2000 ml, 2 लीटर का blood गायब हो गया. ठीक है? और loss हो गया. In such cases, the heart will pump more and it will cause proper tachycardia, which is more than 120. At the same time आप देखोगे, then here the BP will be decreased and also this urine output. The urine output also will be decreased because it will supply to the vital organs, it will try to skip the kidney part, so it will be decreased. Okay, so main like brain को blood कम जा रहा, तो इसीलिए there might be confusion, so we need to replace with bloods. And in more than 2000, it is more than 40%, so there will be more tachycardia along with this decrease in BP, and there will be oliguria. There will be starting of oliguria, very low amount of urine. Okay, तब हम क्या करना चाहिए हमें? We need to do massive blood transfusion. We need to start this massive blood transfusion protocol in the case of type 4. ठीक है, इतना याद रखना. Yeah, good doctor Anna Rajwade. Good. Yeah, BP start decreasing from the stage 2, whereas start decreasing from the stage 2, whereas pulse rate start increasing from the stage 3. Exactly, from stage 3 it causes this more significant increase. Whereas stage 4 it will be causing negligible or anuria type of features. Okay, anuria type of features, whereas stage 3 it will cause oliguria. Some oliguria extent, whereas stage 4 it will be oliguria to anuria symptoms. Okay, that's you need to remember. Fine. Next we'll discuss about this damage control surgery. For example, you saw this RTA patient with multiple injuries. The BP start decreasing from the stage 2. BP start decreasing from the stage 2. Whereas heart rate it will be start increasing mainly from the stage 3. Just remember. Okay. This in the case of damage control surgery means the patient is having multiple injuries, but we need to act based on the need. For example, if he is having abdominal trauma, which is having this bleeding, at the same time he is having the fracture. Okay, first we need to see the abdominal trauma because it is more vital, and if there is any if it is not being resolved, he will die soon. Okay, he will die very soon. Okay, remember. तो इसीलिए तो initial phase 1 में क्या करेंगे? तो we will control this rapid control of hemorrhage and will prevent this contamination with further contamination. Phase 2 में क्या करेंगे? Secondary, start in stage 2. Phase 2 में आप देखोगे, then we need to do secondary resuscitation. We need to look onto this other complications. For example, if there is decreased perfusion, then the thermoregulation will be damaged. So decreased temperature, which is this hypothermia. और हमें पता है when there is this hypothermia, it may lead to this coagulopathy, and it may form this clots, and it can even lead to this metabolic acidosis. So second में we need to take care of this 3 things: hypothermia, coagulopathy, and metabolic acidosis. In third, we need to do definitive surgeries. We need to do definitive surgeries like planned re-exploration and stroma formation. Like for example, if this abdominal trauma, we need to do re-exploration, we need to correct the defect, and we need to put stroma as temporarily. फिर उसके बाद जो भी है बाद में देखेंगे. तो it is the phases, phase 1, phase 2, phase 3. So initially explore करेंगे, फिर secondary resuscitation करेंगे, फिर उसके बाद main, फिर उसके बाद क्या करेंगे, फिर definitive surgery करेंगे, फिर definitive surgery करेंगे. ठीक है, इतना याद रखो. Next about the stages. First, you need to know to whom it is select. You cannot just go and select. It is a head trauma patient. There is no way related to this. So, who is having just single injury, you cannot go for damage control surgery. So, you should select the optimal patient. Then you should bring them to this OT, and you need to control the hemorrhage. That is the phase 1, which is seen in a case of which is done in a case of stage 2. Whereas in stage 3, we did ICU restriction, which is the phase 2. And finally, we'll do this definitive surgery for this, and followed by this, we'll close the abdomen in the 4th stage of this damage control surgeries. There are 3 phases and 4 stages. Don't confuse it. 5 stages. 3 phases and 5 stages. Don't confuse it. Fine. Then we have this protocol, which is known as massive blood transfusion protocol. This massive blood transfusion protocol, if you see, when we'll call, if there is any replacement of entire blood volume in 24 hours, or replacement of more than 50% of this total blood volume within 3 hours, or transfusion of more than 4 units of PRBC within 1 hour, or if there is any ongoing bleeding, or if we are transfusing more than 10 units of PRBC within 24 hours, or 4 units within 1 hour, or 10 units within 24 hours, we'll call them as massive blood transfusion. Our massive blood transfusion will take up in the ratio of 1:1:1 PRBC, FFP, and platelets. PRBC, FFP, and platelets. Fine. And you need to know this few scores. This SARS score. Okay, fine. This SARS for this systemic inflammatory response syndrome score. This score, which is used to differentiate from this means usual sepsis and the inflammation part. Fine. So in this, you need to know 3 things. Okay, like 4 things especially. Temperature, it will be either it can be less than 36 degrees or it can be more than 38 degrees. Okay, and the respiratory rate will be more than 22. The components which you know, it is the temperature, respiratory rate, heart rate which is more than 90 beats per minute, and WBC either less than 4000 or more than 12,000. Okay, so itna yaad rakho. Then 𝗚𝗃 you know, it is the GB road. It is the GB road. You can remember as GB road. So GB means it is the gas close coma scale, and then followed by this systolic BP, which is the systolic BP, and systolic BP less than 100, and respiratory rate more than 20 per minute. Respiratory rate more than 20 minutes. So these are the components for this 𝗚𝗃. Fine. Next, we'll see some more scores. For example, our MELD score. Just you need to remember about these components, like where we'll use and what are the components. If you see about this MELD score, it is used for this model for this end stage liver disease. So in a case of liver transplantation, we'll use this MELD score. Thank you, Dr. Rajneesh. And if you see what are the components we'll use this bilirubin, we'll use this INR and serum creatinine. So we use the CBI one here also. So it is the creatinine, bilirubin and INR. Along with this, we can use the sodium as well. So remember, it is used for this assessing the mortality. Okay, so who are having this higher MELD score, there will be higher mortality chances. Fine. Next, about this PERLD score, will be having this, will be remembered as BIA. Okay, BIAs. Okay, so there will be this bilirubin, INR will be there, serum albumin will be there, then age will be there. Okay, age will be there, and there are some other parameters. So remember it mainly as BIAs. So remember it is bilirubin, INR and albumin. Bilirubin, INR like PTINR and albumin. Whereas in Neser's index, we'll use this bilirubin, INR and SGOT. Okay, bilirubin, INR and SGOT. Here also the same BIA, bilirubin, INR, albumin, ascites and asterisk. In a case of child-buck score, and in discrimination score, we'll mostly use this two parameter, which is this bilirubin and PTINR. Okay, just write in your table. Okay, because in just I guess 2 years back they asked this 𝗚𝗃. What are the components of this 𝗚𝗃? GCS changes less than 14, respiratory rate more than 20, and systolic blood pressure less than 100 or less than 90. Like this they will ask. Or which of the following is not a component? Like respiratory rate, systolic BP, diastolic BP are mental changes as gas close coma scale. Remember, yeah. Okay, so these are the things you need to remember about this important scores. And finally, if you can, then remember about this 𝗚𝗵𝗶𝘀 score, about this wound healing. So if you see, once you suture a wound, you need to know whether this is healing properly or not. This is healing up properly or not. So, or you need any additional interventions to maintain this normal aseptic precautions or to promote this normal healing. So this include initially for additional treatments like antibiotics or drainage of the pus if any presence, or debridement of the wound. And then if there is any serous discharge, erythema is there, purulent exudate are there, or is there any separation of this deep tissues inside this suture you closed it, or is there any isolation of the bacteria? Isolation of the bacteria which is present near the wound site means if there is any bacterial infections, then it will prevent this wound healing, right? Then how much is the hospital stay? So based on it, we'll collect this score which is known as 𝗚𝗵𝗶𝘀 score. Okay, it will be bit hard to remember this, but make sure you are just having idea. Means if you having idea, these scores can be asked. Fine. Then we'll what's the time now? Yeah, we'll do this. One more part about this urinary system and we'll conclude it. Okay, then GIT will do after the break. Fine. Okay, I guess you're not bored. Okay, so if you see about this urinary stones, we already studied about these crystals. We saw this dumbbell shaped crystals will be seen in a case of calcium oxalate monohydrate, whereas this envelope shaped crystals, it will be seen in a case of calcium oxalate dihydrate. Then this coffin lid crystals will be seen in a case of triphosphate stone, also known as struvite stones, and rhomboid shaped crystals will be seen in the case of uric acid crystals. So we know these crystals, and in these crystals it can cause hyper or supersaturation, which is leading to this formation of urinary stones. And for this urinary stones, we know up to 5 centimeter, up to 5 millimeter, we won't do any intervention. We'll do conservative management. What we'll tell, if it is still 4 centimeter, per 4 millimeter, per 1 mm, we'll add 1 liter of water extra. So if it is 4 millimeter, we'll tell them to drink 4 liter of water a day. So if you drink more water, it will come, there will be diuresis will be happening and it will come by this urinary pathway. Right? So if it is more than 5, then we'll go for the intervention. What we can do is that we can do one thing which is known as extracorporeal sharp wave lithotripsy. What will give? Will give shock wave from the outside. When you give this shock wave, it will go and break these stones into small pieces. Will go and break stones into small pieces, and it will come out through urine. So remember, this ESW will be contraindicated in the case of pregnancy and any bleeding disorder. Okay, remember, and any bleeding disorder. Next one, it is the PCNL. So if some stone is very big and it is very hard, then we'll do this percutaneously. We'll go mostly around this posterior, the lateral aspect. Then we'll go and remove the stone and we'll put up a tube. Next one, if this stone lies on this inferior part of this ureter, then we'll go ureteroscopically. We'll go by this scope and we can go on, take up the stone and we can come back. Okay, we can take up the stone and we can come back. So it is what it is, this URS. Then okay, so mostly as I told you, we need to give them additional fluids like 4 to 6 liters per day, and it will easily wash out the stones. Okay, so this is it. Yeah, if it is more than 2 centimeter, we'll try to use PCNL. Remember, yeah, good. Then some other methods, like for example, acidification and alkalinization, and we'll try to avoid this loop diuretics because loop loses calcium, whereas in a case of renal stones who is having hypertension or who need this diuretic support, will try to use thiazides. Will avoid loop diuretics because loop causes losing of this calcium into the urine. Okay, itna yaad rakho. Yeah. Next, if you see about this TB of the urinary system, it will be spread secondarily from hematogenous route. Like hematogenous, by blood it will come here. Okay, usually it will be from the lungs, which is having this primary foci, which is being spread into the kidney. So this will be having this multiple features. One, it can cause this type of calluses, which is known as moth-eaten calluses. Okay, then it can cause this type of formation of pus inside the kidney, which is known as 𝗵𝗔 kidney. It causes this type of kidney, which is known as 𝗵𝗔 kidney, which causes this pus formation. Then this 𝗵𝗔 kidney can undergo what? Yeah, good, Dr. Parul. This 𝗵𝗔 kidney can undergo calcification, which is known as what? Which is known as cement kidney. Cement kidney, fine. And this tuberculosis, it causes this scarring of this bladder, and it causes this very small. This bladder will become very small, which is known as what? Which is known as thimble bladder. Thimble bladder. Okay. And one of the earliest finding, if you see, means you do this ureteroscopy, while earliest finding you will see it is the pallor around this ureteric orifice. Where the ureter comes and joins, you will able to see this pallor, and on later part you will able to see this type of ureteric orifice, which is known as Golf hole ureteric orifice. So it is asked in NEET PG examination where you will see this Golf hole ureteric orifice. It is seen in a case of TB. It is seen in a case of TB. Okay. Then about this, it can go ahead and it can involve this prostate, and means like it can come via the prostate. Mostly it will spaz it, and it will cause this infections over this vas deferens, and in vas deferens it will cause this beaded appearance. And it will cause this beaded appearance. Okay, and the investigation of choice for this TB, it is what it is, this IVP. We'll do this intravenous pyelography, and earliest sign it is this sign, which is known as moth-eaten calyx. Fine. For treatment, what we'll do, we'll give ATT and we'll manage the complications. For example, if there is simple bladder, then we'll augment this bladder. Fine. If there is any ureter changes, then we'll do it. And if there is any 𝗵𝗔 kidney, cement kidney, we'll analyze the level, or we'll analyze its function, and based on it we'll remove or we'll keep it. Fine. And next, about this urinary bladder carcinoma management. So they started asking about this urinary bladder carcinoma management. So you just see, remember, this is the urinary bladder. So initial stage of this urinary bladder cancer, we can use few chemotherapy agents. One of them is BCG. So we discussed yesterday in PSM that all of the vaccines, they are what? They are this primary level of prevention, except using BCG vaccine in a case of CA bladder. So in a case of CA bladder, if you use BCG vaccine, it is considered as a treatment modality, and it will come under this secondary prevention. It will come under this secondary prevention, not this primary prevention. Yeah, good, Dr. Gautam. Good. Yeah. Like 𝗵𝗔 kidney can also be bilateral, but medullary sponge kidney, it will be in a different manner. Like there will be arrangement of this radial arrangement of cysts will be there in the case of medullary kidneys. They will tell at like a kind of brush appearance. Okay, that is a different entity, Dr. Koinen. Okay. See, so in a case of initial, you will go inside the bladder and you will give intravesical chemotherapy, and followed by this, what you will do? If there is a small and single lesion, you will go by this transurethral route and you will remove it. Mostly it will be if it is small and single one, it is the papillary tumor, and if it is multiple, you will go for this TUR resection, and also you will go for this chemotherapy. You will resect and will give chemotherapy. And if it is for T1, we also do the same, TUR plus intravesical chemotherapy. For after T2 to T4 stages, what we will do, we will remove the bladder. We'll do radical cystectomy followed by adjuvant chemotherapy and radiotherapy. Okay, followed by adjuvant chemotherapy and radiotherapy. So the same thing will be repeated from stage T2 to T4. So they will be asking, this is having a large mass which is being spread to the nearby locations, means it will be stages more than T2. So if it is stages T2, T3, T4, then it is what? Then it is an advanced stages. In such cases, we need to remove the bladder, and along with this, we need to give radiotherapy and neoadjuvant chemotherapy. Remember, okay? Neoadjuvant chemotherapy. Fine. Then, so what are the agents we'll use? I told you one of them, it is the BCG and mitomycin C will use. BCG will use, mitomycin C will use. It can be remembered as MET-BCG. So mitomycin C, epirubicin, 𝗧𝗵𝗶𝘀 and BCG. Fine. And next, systemic chemotherapy by IV route, means two routes we can give. Like we can give just transurethral will go and will deposit, will flush here. So it is what? It is intravesicular. But some things we can give by intravenous route. What are they? They are this MVAC regime known as methotrexate, vincristine, adriamycin and cisplatin. So read this thing, because see, the smoking causes lung cancer. It is acceptable. But this tobacco usage causes bladder cancer. And smoking and tobacco usage causes bladder cancer. That's why there's an increase in prevalence of this bladder cancer. That's why they are asking this bladder cancer question. So just remember. Fine. So just remember about this bladder part. Fine. And about this testicular torsion, mostly it will be seen in this children or young individual, where you will able to see this deformity. Mostly if you see, this is the testis, and this is this tunica vaginalis. Usually it will be attached to this like this. Whereas if there is high infestation of this tunica vaginalis, the testis will be supportless. So because of this supportless testis, what will happen? It will go and roam around. It will go on torse itself. So it is known as testicular torsion. It is known as testicular torsion. So one of the risk factors for this, it is what it is, this high infestation of this tunica vaginalis, which this known as bell clapper's deformity. You know, right? In mandir, in temples, there will be a bell. Okay, this is bell. Yeah, there will be a bell, right? So bell will be there. So here like that, here there will be tunica vaginalis. Here will be testis. So it will be swinging like this. It will be swinging like this. So it can undergo torsion. So this is what? This is this testicular torsion. Fine. And this will be featuring with the presence of agonizing pain along with the features of nausea, vomiting. There will be a pain, nausea and vomiting. Pain, nausea and vomiting. And remember, this can involve both the testes. This can involve both the testes. And how will you differentiate it? What you will do? First, you will do a sign which is known as French sign. What you will do? You will lift the testes of the patient. Once you lift the testes of the patient, if the pain relieves, then it is not testicular torsion. It is acute epididymo-arthritis. If this lifting the testis, if his pain relieves, it is what it is, this acute epididymo-arthritis. Whereas if you still lift the testis, but he is still feeling the pain, so it is what it is, the testicular torsion. If he is still feeling the pain, it is the testicular torsion. And in a case of testicular torsion, you need to check for the vascularity. Once the vascularity is there, just compromised, then you will do surgery. And in surgery, if you are able to see this testis which is being affected, it will be high reading. So this sign which is known as angel and demon sign. This is known as angel and demon sign. Okay. An examination, the affected testis will be high reading. It is known as angel sign, like high reading, which is called demon sign, and there is thing which is known as, means demon is there and angel is there. So two signs will be there. So contralateral normal testis will be angel. So contralateral which is normal, this an angel. So remember. Yeah, good. In the case of French sign is will be negative in a case of testicular torsion, and French sign will be positive in a case of acute epididymo-arthritis. Okay, and here if you elicit the chemistry reflex, it will be absent. Okay, and investigation of choice, we need to see this vascular supply, we'll do Doppler. Fine. And here management will do emergency 𝗓𝗏𝗄𝗃. Fine. And next it is the gangrene. This type of gangrene which is occur at the level of total regia, which is known as what? Which is known as corneous gangrene. And this is what? This is the necrotizing of this fascia. It is this necrotizing fasciitis. So it is this necrosis of this fascia, superficial fascia especially, superficial and deep fascia, both of them, and it will be caused by both aerobes and anaerobic organisms. And for this, what we'll do debridement and antibiotic covering. Debridement and antibiotic covering. Fine. And this nephrectomy, where I will do this nephrectomy surgeries, like especially this partial nephrectomy. Like if there is a RCC, but still you just want to remove the tumor part, you will leave the kidney part. Like if there is any size of tumor, if it is just up to 4 centimeter, then what we'll do partial nephrectomy. And if it is just a RCC in only one kidney was there, and in one kidney only there is RCC is there, then we'll do partial nephrectomy. And if there is involvement of both kidney in RCC, then we'll do partial nephrectomy, or RCC with already diseased kidney. Okay, one kidney is already deceased, but it is having RCC. So here we'll do partial nephrectomy. So here we'll do partial nephrectomy. Fine. And finally, the paraneoplastic syndromes of RCC. The most common one, it is the increase in ESR, and it can also cause increase in calcium levels. And this RCC can cause liver damage. Yesterday in pathology also we studied this RCC induced liver damage because of this interleukin 6. Because of this interleukin 6, it is known as Staphylococcus syndrome. It is known as Staphylococcus syndrome. And this RCC can go into the lungs. Okay, metastasis into the lungs, and can cause a metastasis like a cannonballs. It is known as what? It is known as cannonball metastasis. It will be caused by both RCC and choriocarcinoma. Okay, choriocarcinoma. So guys, so that's it about this urinary tract part. Okay, we'll meet up with this GI part. We'll start after this break. Fine. It is 2:22. We'll take our break till 3:05. Okay, till 3:05 p.m. will resume. Okay. Do you have any other doubts? You can post up in the chat section. I'll be happy to answer it. Fine. I guess things are going well. Okay, just there will be few lacks in it. Like there will be everyone, like in a part of life, in a part of preparations, there will be few dips and things will become, and something you feel like, yeah, why this thing is very much prolonging. For example, this medicine class, this surgery class, why this is this much prolonging. So just remember one thing, how much itself it prolongs, at some point of time, at some point of the day, it will end for sure. Okay, and whatever happens, it happens for your goodness. Keep this positive in your mindset and keep working for it, and you will come out with flying colors. Okay guys, we'll meet up at 3:05 p.m. Fine. If any doubts, please reach out in the chat section. Fine. Bye guys. Hello doctors, good afternoon and welcome back after the lunch. Like, am I audible? Can you please confirm it? Hi 𝗏𝗏𝗀𝗃𝗀. Yeah. Hi Medruchi, it started. Okay, thank you Dr. Venkatesh. Thank you. Yeah, thank you Dr. Rahul. Yeah. Okay, fine. Yeah. Thank you Dr. Gautam. Yeah, good, fine. Had your lunch? Did you had your lunch? I guess yes, fine. With this, we'll start with this surgery part, and mostly it will be taking around next 30 minutes to complete the surgery. Then we'll start up with this gynecology part, which is also a high yielding one. And gynecology part will maximum take around 1 hour 30 minutes to 1 hour 40 minutes. And this is our ideal timing, and we'll usually finish with our usual timing ones. Fine. If any things are doubts, please let me know. I'll help you out with it. Fine. Then we'll start with our thing. We'll start with this GAT part, the first one. Sorry. The first one, it is what? It is this 𝗏𝗏𝗀𝗃𝗀. If you see the first one, it is this 𝗏𝗏𝗀𝗃𝗀. This 𝗏𝗏𝗀𝗃𝗀, it is actually what? It is due to this absence of this relaxation. We studied in physiology, there is no VIP which causes relaxation. Means nitrous oxide and vasoactive intestinal peptide, both of them, what they do, they causes relaxation of the sphincters. So whereas in the case of 𝗏𝗏𝗀𝗃𝗀, this lower sphincter is not being relaxed. So because of this, what will happen is that there will be constriction. There will be constriction at the level of lower esophageal sphincter, and this leading to this dysphagia. And this dysphagia is frequently, it is most commonly for liquids than solids, because if there is solid component goes, it will stimulate and irritate this nearby nerve plexus, and it will cause this opening of this lower esophageal sphincter. Whereas liquid, how much ever you fill, it won't create this pressure to this threshold level, so that this LEH won't open it. Yeah, good Dr. Annar. It is what? It will produce this type of thing which is known as what? Bird beak appearance and barium swallow. It produces this bird beak appearance and barium swallow, and also which it is known as, because of this tapering, it will call them as pencil tip appearance. Okay, pencil tip appearance, and sometimes will be used as a rat tail appearance as well. Okay, but this rat tail we often confuse with this carcinoma esophagus, so we less often prefer to use it. Fine. And the investigation of choice, it is the manometry. In manometry, if you are able to see here, this relaxation pressure, it will be more than 55 millimeter of Hg, along with this presence of failed peristalsis. Means there will be no peristalsis, and along with this pressure is more. So because of this increased pressure, this lower esophageal sphincter, it won't open. Okay, so as this won't open, this leads to this 𝗏𝗏𝗀𝗃𝗀. Right? This leads to the 𝗏𝗏𝗀𝗃𝗀. So what we need to do is that we need to open it by breaking the contraction. We know calcium causes this muscular contraction. So we'll give this calcium channel blockers, and we know this, we told no VIP, like nitrous oxide and vasoactive internal peptide will cause this relaxation of muscles and sphincters. So we'll produce this nitric oxide by the help of nitrates. Or as a surgical modality, what we can do is that we can go and cut this muscles over the lower esophageal sphincter. It is known as 𝗏𝗏𝗃𝗀𝗃𝗀𝗃𝗃𝗃𝗃𝗃𝗃𝗃 as known as 𝗏𝗏𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 as endoscopically or laparoscopically, or else we can go even by the help of peroral. Means in the oral route only we'll go and we'll create a small opening in this layer of esophagus, and we'll go to the muscular layer. Okay, there will be this layers, mucosa, submucosa and muscular layer, and we'll go to this muscular layer and we'll cause incision and will cut this layer. Fine. So it is known as what? It is known as poem. So perorally, by oral route we are going with endoscopic help, and we are cutting this muscular layer. So remember, so it is the treatment of choice is what? It is the hairless myotomy, and now recently we are using the poem part. Fine. And this is the manometry I told, and this is the barium swallow, so showing this bird beak appearance. And next we see few more motility disorders. One is this nutcracker's esophagus. Next one, it is this diffuse esophageal spasm. There is small lineage differentiate between these two. If we see about this diffuse esophageal spasm, what is alacrimia means? Where it is actually alacrimia means absence of tears. 𝗏𝗏𝗃𝗃𝗃𝗃 plus try to correlate with this topic which we are teaching. Fine. And if you have any doubts related to it, we will post in the middle. If not, just keep it with you. We'll answer it in the end of the session. Fine. And then if you see this diffuse esophageal spasm, it will be there will be having this diffuse esophageal spasm, and it will cause this corkscrew shaped esophagus. Shaped esophagus. It will show this corkscrew shaped esophagus, right? And it is due to this impairment and this, because of the spasms, it causes this impairment in this vascular supply. And it is actually due to this tertiary contractions. Means usually there will be this peristalsis, whereas here there will be these tertiary contractions which are actually spasmodic, and because of this spasm the vessels will undergo spasm, and it will cause what? It will cause compromise in the vascular supply, and if there is any compromise in the vascular supply, it leads to the ischemia. Especially it will mimic, because of this ischemia, it will mimic the myocardial infarction, especially on the left side, fine, and it will be always associated with this dysphagia. Yeah, good, Dr. Anna. Then here also we'll use this manometry to measure the pressure. Here the DCI will be, it will be more than 400. It will be more than 400. Okay. Then the management here the same. The muscle is contracting, so we'll remove the muscle contraction by blocking the calcium channels. So we'll use calcium channels, and it will make the open this esophagus by giving the nitrates. Fine. And okay, and in later part surgically what we can do is that instead here, means in the case of achalasia cardia, we did this small myotomy, whereas here we'll do long myotomy, fine. And nutcracker esophagus, it is the most common motility disorders. Okay, it is most common painful hypermotility disorder, and this nutcracker esophagus, it's almost similar to diffuse esophageal spasm, whereas this nutcracker esophagus, the pain or this DCI will be more, which is very much more, like around more than 800 when compared to this compared to this diffuse esophageal spasm, which is more than 400. So the DCI here, it will be more than 800. So this is, just remember. Okay, and both of them will be having this dysphagia. Next, about the CA esophagus. Usually the CA esophagus patients, he or she also complains with the features of dysphagia. Once they complains about the features of dysphagia, okay, then what will happen? Because of this dysphagia, yeah, good, Dr. Anil Rajpati. Because if you see, Anar, if you see, there will be this mass, and this will pass, allowed to pass this liquids, whereas solid, if it comes, it will come and get stagnant over here. Okay, it will come and get stagnant over here. So that's why it causes dysphagia to, especially to the solids, but actually it will cause dysphagia to both, but more common to the solids. Okay, and there will be, because of this dysphagia, there will be a features of weight loss, and in later part, this esophagus may get in connection with this trachea and can cause tracheoesophageal fistula. Remember this. And for this, we can do few procedures. For example, we can remove this esophagus where there is a presence of cancer. You know, the most common cause of esophageal cancer, it is a squamous cell cancer, and it is mostly at the midline. Whereas if it occurs at the inferior part, it will be the adenocarcinoma. So wherever there is a esophageal cancer, we need to take 10 centimeter margin. Means if there is cancer here, we need to go around and cut around 10 centimeters. Okay, we need to take this 10 centimeter margin. Just remember this. So for this esophageal cancer, we can do few surgeries like Ever-Lewis operation, Orient transhiatal esophagectomy, which is more commonly done, and Mekion en bloc esophectomy. So all of this procedure are done to remove this esophagus, and after this we'll catch up the stomach as a conduit, or we'll take from the small intestine as a conduit, and we form a alignment with this oral cavity, or with this cricopharynx will have this alignment, fine. And in few cases where this tracheoesophageal fistula is there, and in advanced stages, we'll provide some stents, like we'll keep some stents, and we'll just give them relief by providing the stents, and it will provide relief from the dysphagia component, fine. And next, for this we can use some of this chemotherapy regimens, which includes epirubicin, cisplatin, and 5-fluorouracil. So epirubicin, cisplatin, and 5-fluorouracil. Epirubicin, cisplatin, and 5-fluorouracil. Fine. Then we'll move on to the next part. You saw this child. You saw this child or this infant who is just 3 weeks old. Okay, this child is 3 weeks old, and he is presenting with, the mother is bringing her with this features of projectile vomiting and multiple episodes of vomiting. On evaluation, you will be able to see there is this presence of this olive-shaped mass. Olive-shaped mass. And the child is very much dehydrated, and now if you are able to do this analysis, you will be able to see on X-ray, you will be able to see this single bubble appearance. You will be able to see this single bubble appearance, and all of this following. Yeah, they are 21 days old, or this child with the age of 3 to 4 weeks, along with these features of projectile vomiting and with multiple episodes and a olive-shaped mass, we will be suggestive of hypertrophic infantile pyloric stenosis. It will be suggestive of, yeah, it will be non-bilous vomiting. Correct, guys. So it is what? It is this infantile hypertrophic pyloric stenosis. And we know there are different shapes of muscle. There will be this circular muscles and there is this longitudinal muscle. So see, in the case of infantile hypertrophic pyloric stenosis, it is the circular muscle which is being hypertrophied. Yeah, previously it is known as 𝗡𝗶𝗄𝑠. Now it is known as infantile hypertrophic pyloric stenosis. Fine. And there will be multiple episodes, and because of this vomiting, there will be loss of this. Yeah, good Dr. Naresh, good Dr. Gautam. And because of this, what will happen is that there will be this loss of this ions which is in the acidic component. So it will lead to this hypokalemic, hypochloremic, metabolic alkalosis. But instead of this metabolic alkalosis, instead of maintaining, the kidney will reach out, or kidney will send more acids to the outer side to save this kalemia component, which is this potassium component. So it is known as what? Hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Fine. And for the treatment, I told it is a dehydration. So we need to treat the dehydration component, which is this normal saline. Next, for treatment of choice, we'll use Ramstead pyeloplasty. We'll do this Ramstead pyeloplasty. Just remember. Fine. Yeah, it is due to the inner circular. Yeah, guys, that's it. Then we'll move on to this gastric ulcer. In gastric and duodenal ulcer, you need to know about the complications. There are a few complications which may include. It may cause eroder to the arteries, and it may cause bleeding over it. Okay, it may cause bleeding. And second is, it can also erode and it can cause perforation over these regions. So it can cause perforation and also bleeding. Okay, so it can cause perforation and bleeding. Fine. So if there is any complications like bleeding, the most common complication is of this peptic ulcer, it is the bleeding one. Okay, whereas perforation, it is the most common for this gastric ulcer. Okay, perforation is the most common complication which is most commonly seen in a case of gastric ulcer. And there is one more complication which is known as gastric outlet obstruction. Means because of this ulcer, there will be what? There will be this scarring, and because of this scarring, the stomach may turn and it can cause gastric outlet obstruction. And see, if there is bleeding, we need to know which artery is bleeding so that we can control. For example, in the case of juvenile nasopharyngeal angiofibroma, we know the artery which is responsible, it is what? It is this sphenopalatine artery. Likewise, if you see here, this duodenal artery, the most commonly involved artery for bleeding in duodenal ulcer, it is what? Is the gastroduodenal artery. So in a case of bleeding from this duodenal ulcer, we need to go and ligate, or we need to repair around this gastroduodenal artery. So just mostly this artery will be lying behind this duodenum. So that's why it is seen in case of posterior ulcer perforations, whereas anteriorly it will lead to this perforation, whereas posteriorly it leads to this bleeding as a complication. Okay, fine. And this, for this treatment of this bleeding duodenal ulcer, what we can do is that we'll ligate the bleeding vessel, and what else we can do is that we can do truncal valvotomy. Okay, because there is increased acid secretion because of this PEG supply. If you cut out this supply, then there will be no acid secretion. So we can do truncal vagotomy to prevent recurrence, and we can do this pyeloplasty to prevent the stricture. So this is in a case of bleeding. Whereas if there is any perforation, in a case of perforation, what we can do is that if there is any here perforation, we can bring the nearby omentum to this place and we can suture them out with this perforation. How if there is a tire punctures, then we are bringing out something when we are keeping as a patch. So likewise here using this ओमेंटल पैच रिपेयर, अगर हम ओमेंटल पैच रिपेयर हम यूज कर रहे हैं तो इसको बोले कि हम ग्राहम्स रिपेयर, इट इज नोन एज ग्राहम्स रिपेयर. ओके, जस्ट रिमेंबर इट इज नोन एज ग्राहम्स रिपेयर. और इसमें हम वैस्कुलराइज्ड पेडिक्यूल ऑफ मोमेंटम यूज करेंगे. मींस it should be viable because once it starts healing, you know that this healing it need to be continuous. अगर ये भी नेक्रोस हो गया तो दोबारा परफोरेट होने के चांसेस ज़्यादा है, तो इसीलिए it should be having a viable and its own blood supply. इतना याद रखो. Good, Dr. Anar. Fine. Then we'll move on to this type of gastrectomy. This type of gastrectomy include this first one, which is this gastroduodenostomy, which is this Billroth one. Whereas in a case of Billroth 2, you see this gastrectomy, and followed by which there is this gastrojejunostomy. There is this gastrojejunostomy. And next, if you see, there are a few more gastrectomy. If you see, this is known as 𝗼𝗏. So what we'll do is there are two ruminants. So mostly this is done as a case of either in a case of restriction from the food intake or because of some complications of this ulcer. Fine. So what we can do is that usually this esophagus connected to this gastric pouch. Then what we'll do, we'll cut out at the level of jejunum. So what we can do is that one jejunum, we have this two jejunum, this end and this end. So what we'll do, we'll bring this jejunum to here. Once we bring this jejunum to here, we'll attach to this to this small part. So it is what is this gastrojejunostomy. And the leftover part of the jejunum will take this jejunum and will go and connect with this one more jejunum. So it is what? It is this gastrojejunostomy and jejunojejunostomy, and it will be forming this type of Y limb. It is known as Ru-and-Y limb. Okay, and one of the complication of this gastrectomy, it is dumping syndrome. Okay, there will be two dumping syndrome: early dumping syndrome, late dumping syndrome, and there will be this phenomena over this limbs. Okay, just remember. And as a bariatric surgery, or to reduce the weight or to decrease the secretions, what we can do is that we can remove some part of the stomach like a sleeve. So okay, we'll pass the stapler and we'll cut and remove it. So it is known as what? It is known as sleeve gastrectomy. Okay, yeah, early and late. Yeah, early it will occur in a few minutes, and late it will occur after a few hours. Okay, just remember. And next they will give this X-ray image and they will ask you which of the following is this? Is this a small bowel obstruction or large bowel obstruction? See, first, to differentiate small bowel and large bowel obstruction, you need to know what is the useful or what is the initial clinical findings. If you see in a case of small bowel obstruction, if you see, mostly it will be presenting with features of vomiting, abdominal pain, and along with this GORDing and rigidity. Whereas in a case of large bowel obstruction, it will be presenting with constipation or obstipation. Yeah, good Dr. Annar, obstipation. So it will be having this constipation or obstipation or complete loss of, there will be no motion will be passing and there will be no gas which will be passed here. So it is known as constipation or obstipation. Okay, along with this pain and GORDing and rigidity. Fine, this will be seen in a case of obstruction. Then followed by which we need to diagnose like whether this is small bowel or large bowel. If we see in a case of small bowel obstruction, it will be mostly placed central. Okay, it will be mostly placed centrally. Whereas if you see about this large bowel obstruction, the bowel loops mostly lie in the peripheral part. It will lie in the peripheral part. Okay, so in a case of small bowel, it will be center. See, remember F for S, it will be in central. Yeah, good. In a case of small bowel, especially in a case of jejunum, good Dr. Rahul, yeah, good Dr. Anar, good Dr. Kwanin, they will be having this 𝗷𝗵𝗊𝗺 conventis. It is known as 𝗷𝗵𝗊𝗺 conventis, which will be having this circumferential ring-like pattern in the jejunum. So like this will be there. So it is what? It is this 𝗷𝗵𝗊𝗺 conventis. It will be seen in a case of jejunal obstruction. It will be seen in a case of jejunal obstruction. Whereas in a case of large bowel, usually it will be having a dilated bowel which is around more than 6 cm, and along with this it will be mostly peripherally placed, and here you will be able to see this presence of horstations as well. So horstations you will be able to see in a case of large bowel, whereas in a case of small bowel, especially the jejunum part, you will be able to see this 𝗷𝗵𝗊𝗺 conventis. Okay, yeah. And if it is causes the obstruction, then there will be this air fluid level causing this step ladder pattern of air fluid level, especially in a case of small bowel obstruction. Okay, that is how you will able to differentiate this small bowel obstruction from the large bowel obstruction in an X-ray. Okay, right. Then I told you there are one gastric surgery we already discussed, and next we'll see. So if you see, instead of doing a difficult surgical procedure, what we can do is that we can go laparoscopically and we can go and put this band. So this is what this is the adjustable band means. You'll put a band and it will cause maximum weight reduction because they are eating less. Obviously, they will having this weight reduction. So at certain point, you feel that no, it still need to be reduced. Then you can reduce the volume. You can just bit pull up. And if you think no, it is not enough, then you need to increase it. Then you increase it. So it is known as what? It is known as laparoscopic adjustable gastric banding. It is known as laparoscopic adjustable gastric banding. Okay, yeah, it is reversible. Then if you see about next one, it is this sleeve gastrectomy. You remove this part of the stomach, okay, and left with the sleeve. It is known as sleeve gastrectomy. Next, we discuss the same Roux-en-Y. It can be done there also. Here also we can do in a case of bariatric surgery. So what we'll do is the same gastrojejunostomy and jejunojejunostomy. Fine, gastrojejunostomy and jejunojejunostomy. And we will do one more procedure which is known as duodenal switch. Which is known as what? Duodenal switch. What we'll do? We'll be having this initial connection with it, whereas instead of taking this jejunum, we'll take up to this ileum. So that what we'll do, the connections and the secretions will be continue till here. Okay, continue till here. So here will be continued with duodenum, whereas here it will be switched with this either jejunum or mostly in a case of ileum. So it is this biliopancreatic diversion. So what we'll do, this biliary and pancreatic secretions will come here, but before that this food particles, they will enter into the small intestine, so there will be less absorption because there is no pancreatic and bile enzymes which are present in there to absorb this food material. Okay, it is the thing. Yeah. Okay, then we'll move on to the next part. You saw this child who is presenting with these features of, here the child who is presenting with the features of bilious vomiting. Here the child will be present with the features of bilious vomiting. Why? Because this obstruction mostly happens at the level of D2 of this, or D2 or between D2 and D3 of this duodenum part. So in these cases, what will happen is that because of this obstruction, the child will be having the vomiting. So as I told you, whatever the small intestinal complications, it will be presenting with vomiting. So the child will vomit out. Once the child is vomit out, okay, you did this X-ray. You did this X-ray where you will able to see this 1 and 2. Where you will able to see this dual bubble appearance, double bubble appearance. So there will be this double bubble appearance. This double bubble appearance is characteristic for this duodenal atresia, okay, if it is infants. Whereas in later part of age, it can be due to some other complications, like for example annular pancreas as such. Fine. So next, the treatment, like here the duodenum it is, yeah, good. It can be associated with Down syndrome. Yes, Dr. Quinin. Yes, Dr. Anar and Dr. Gautam. Yeah, good. Okay. Next, if you see this duodenum, here there is this atresia. So now what you will do, you will just take up this duodenum and you will join it together. Okay, removing this by excising this. So it is what it is, this duodenostomy. So you will do this duodenostomy, or you can do duodenojejunectomy. So mostly we will prefer duodenostomy, remember. So it will be showing this double bubble appearance. Okay, fine. And if it is triple bubble appearance, it will be classically seen in a case of jejunal atresia, and multiple air fluid levels are like a apple peel will be seen in a case of ileal atresia, remember. Right? This annular pancreas, it is associated with this Down syndrome, and the same atresia also associated with this Down syndrome. Fine. Next we'll come to this complication which is known as intussusception. Now there is a child who is presenting with after a history of vaccination, like after a history of rotaviral vaccination. There is a history of rotaviral vaccination. Yeah. In the case of this rotaviral vaccination, now the child is complaining of pain in the abdomen, and along with this passage of mucus and this blood stained stool, which is known as red currant stools, jelly stools. Okay, where we studied red currant jelly sputum? Yeah, guys, where we studied this red currant jelly sputum? We studied in a case of 𝗶𝗶𝗃 pneumoniae. We'll study in a case of 𝗶𝗶𝗃 pneumonia. Fine. So here, if you are able to see this one loop of the bowel, it is what it is being herniated into this other loop. It is being herniated into the other loop. So most commonly, it is due to this Peyer's patches which is causing this intussusception. So the most common site, it is what? It is this ileocolic. The most common site in children, it is what? It is this ileocolic. It is the most common type. Fine. And the most common lead point here, it is what it is, mucus diverticulum, and in a case of rotaviral vaccinations, there will be this hypertrophy of this polyp. So this is being telescoped into this. Okay, this is being telescoped into this. Fine. Then on ultrasound, yeah, good. On ultrasound, yeah. Here the air enema, this barium enema will be therapeutic as well as diagnostic. Yeah, good Dr. Anna, good Dr. Gautam, good Dr. Quinin. Fine. So in a case of ultrasound, you will be able to see this type of sign which is known as Stargardt sign. And next you will be able to see this type of sign which looks like a kidney, which is known as kidney sign. Fine. So kidney sign and Stargardt sign. Okay. And here there will be few more things you will be able to see. Sausage marks will be mostly present in this right lumbar region, and mostly this right iliac fossa will be empty because there is this telescoping. So this telescoped loop, it will go up. That's why it will be empty right iliac fossa. Okay. So for treatment, what we'll do? Yeah, donut sign also will be known as also donut sign. So and in barium enema, you will see this claw clenching, this deformity. There will be this coiled spring deformity. All of them will be seen. Fine. Here what we'll do, we'll give this air enema. With this air enema, there will be this intussusception. It will got reduced. Once you start giving air from here, it will reduce. So this is this intussusception reduction. Fine. Remember. Good Dr. Rahul. Yeah. Good doctor. Yeah. There is the sign of dance. Yeah. Good Dr. Quinin. Gautam. Yeah. Good. Fine. Next one is this two valvulus, sigmoid valvulus and cecal valvulus. If you see about the sigmoid valvulus, remember it is always anti-clockwise in nature. and it will be having the feature of coffee bean. It will be having the feature of coffee bean, okay, and it will usually originate around this left iliac fossa and it go to this opposite side, fine. And on barium enema, I will able to see there is the presence of this A substrate site, okay. And for diagnosis, what he will do, he will go colonoscopically and he will detorsify this, and he will detorsify this, okay, and detorsify it, and he will remove this sigmoid component, okay, sigmoid colon component. So usually after detoxification, like detorsion, what we will do, if it is viable, then no issues. If it is not viable, then we need to do the surgical part, okay. Yeah, good, Dr. Gautam. Yeah, it will be showing this coffee bean side, fine. Next, about the cecal valvulus, it will be mostly what? It will be clockwise in nature. It will be clockwise in nature and it will be having the feature of kidney. It will be having the feature of kidney. So remember, here you can see classical kidney, right? So this is the classical feature of kidney. So this is seen in a case of cecal valvulus. So ISMED treatment, it is not the detorsion, because colonoscopic, it will be difficult for them to go till this iliac level, okay, to the cecum level. So that's why what we'll do, we'll do resection at the level of ileum, cecum and ascending colon. Yeah, good, Dr. Anar. Yeah. Next, there is a child who is presenting with complaints. Now you got a child who is presenting with complaints of, presenting with complaints of delayed passage of meconium. So the mother bringing the child and with the features of constipation. And while asking history, the mother also tell that the baby was passed his meconium after 48 hours of birth. So this is classically seen in a case of Hirschsprung disease, where you will see this normal component which is being dilated, whereas this abnormal which is became shrunken, and it is due to this absence of A ganglions or congenital A ganglionosis of this Meissner's and Auerbach's plexus. Meissner's and Auerbach's plexus, yeah. This delayed passage of mechanism is especially what? It is more than 48 hours. 48 hours. Usually it is usual timing, it is within 24 hours the baby will pass its meconium. Remember. And see, whatever this affected part, it will be what? It will be constricted, whereas normal part it will be dilated. Fine? Yeah. That is known as A ganglionosis. Yeah. Because of this congenital A ganglionosis, there will be no ganglions for this nerve supply. So that's why there will be no passage of meconium. So there will be no movements of this rectal and the small, means large intestine part. Fine. And the investigation of 𝗧𝗵𝗶𝘀, it is this rectal biopsy, rectal suction biopsy more than full thickness biopsy. Fine. Yeah. Good, Dr. Kwanin. Then management, we have 3 surgeries: Snessen, Duhamel and Save. Snessen, Duhamel and Save. These are 3 surgeries for this Hirschsprung disease. याद रखो. फिर उसके बाद आगे बढ़ते types of, like how you differentiate this ileostomy from colostomy. If you see about this ileostomy and colostomy, see on outside it looks similar, whereas if you see this ileum, it is what? It is the small intestine. We know in the case of ileum, which is small intestine, the food material will be liquid in nature. So if you make them to open, into this surface, then what? Then this secretions will flow here like this, and it will cause erythema. Okay. So the likewise for that only, in the case of ileostomy or in the case of small intestine, what we'll do? We'll make this sprout so that we can attach a bag here. So it is what? It is this ileostomy. Whereas in the case of colostomy, if you see this colostomy, it will be having this what? It will come with this formed stools. So we don't need to attach this to the outside. So we can attach to the skin because it will cause less excoriation. Then we can attach a bag and we can collect the fecal matter. So remember, this sprout will be classically seen in the case of ileostomy, whereas colostomy will not have the sprout. Can anyone tell me what is this? Is this ileostomy or colostomy? A good, Dr. Naresh? Is it ileostomy or colostomy? Yeah, good, Dr. Rahul. It is this ileostomy. Okay, it is this ileostomy. It is this ileostomy, which is actually a type which is known as what? Double barrel ileostomy. Double barrel ileostomy. No, it is not colostomy. See, we are having this loop, means which is sprouted out, means which is coming out. See, this is how this colostomy looks. We'll be able to see or differentiate from the outside, or you see it is attached to the wall. Whereas colostomy will be like this. You can see it, right? It is sprouting from the outside. So this is how this ileostomy and this is how this colostomy looks like. Fine. So this is this double barrel ileostomy. So good, Dr. Abneet, and good, Dr. Anath, good, Dr. Rahul. Good. Try more Gautam. Fine. Next, there are different types of fistula. You need to know, like base of the sphincter, there will be like intersphincteric fistula between these two sphincter. Then there will be this sphincter which is passing these two sphincters. So it is what? It is this transsphincteric. If it is above, it is suprasphincteric, and if it is completely outside of the sphincter, it is the extrasphincteric fistula. So all of them, these are these types of anal fistula. And usually they will be having the complaints of soiling of clothes, and along with the soiling of clothes, what they will have? They will have this discharge, foul swelling discharges. Okay, foul swelling discharges. And there is a rule which is known as Good-Sal's rule. It is known as what? It is known as Good-Sal's rule. This Good-Sal's rules tell that whatever this fistula, if its fistula is originating from this anterior part, it will come and open parallelly. Whereas if the fistula originates posteriorly, it will form in a circular fashion, and it will come and open at the level of 6 o'clock level. So posterior fistula, it will come and open at the 6 o'clock level, whereas anterior fistula, it will come and open directly in the same axis. Yeah, okay, in the same axis. Okay, fine. Next, about this fissure. This is how this anal fissure looks like. Mostly this anal fissure, it will be seen in a patients with chronic constipation. So remember about this fissure in ano means this will be very painful conditions, because this while the stool comes, it will come and erode this mucosa of this rectum, which causes this anal fissure, and it will be very painful. So this perrectal examination will be contraindicated. The perrectal examination will be contraindicated in the case of anal fissure. Fine. And about cholecystectomy, whenever we remove this gallbladder, we'll call them as cholecystectomy. Fine. And there are different types of choledocholithiasis. Choledocholithiasis means the presence of stones in the bile ducts. Okay, in bile ducts, if there is presence of stones, it is known as choledocholithiasis. Whereas if it is present in the gallbladder, it is known as cholelithiasis. So here there are different types of stones. Either the stones might be formed from there, or it can be formed in the gallbladder and being slipped off into this common bile duct. See, if there is a retained common bile duct stone, when we'll tell if it is detected within 2 years. For example, you did a cholecystectomy, and if any stone inside this duct is detected within 2 years, it is known as retained common bile duct stones. Whereas in a case of recurrent stones, it is detected after. So if it is within, it is known as retained. If it is after 2 years, it is what? It is this recurrent stones. It is recurrent stones. Fine. And there are two more types. It is primary stone, secondary stone. In the case of primary stone, it is usually formed in the bile duct. So primary stones of this choledocholithiasis, it will be formed in this common bile duct. Whereas in the case of secondary stones, it will be formed in the gallbladder. Once they formed in the gallbladder, they will slip off into this common bile duct. Okay, so itna yaad rakho. Then about this classification of this choledochal cyst, which is known as Stodani classification. So the most common one, it is the type 1. Here what we will do, you will see this, there is only one solitary extrahepatic cyst. Then instead of cyst means it is a dilatation, right? Whereas instead of dilatation, if you see, it is outpouching. If it is outpouching, yeah, it is outpouching, it is this extrahepatic. And next, if you see this type 3, which is a choledochal cyst, which is one of the simple cysts. And this choledochal cyst, what the management will do is that we'll just remove by cystectomy. Right? We'll remove by cystectomy. Fine. Yeah. Then if you see about this type 4A and type 4B. If you see type 4A and type 4B, in type 4A there will be both extrahepatic and intrahepatic. Both ducts will be there. Both cysts will be there. It is extrahepatic and intrahepatic. Whereas in the case of type 4B, there will be only extrahepatic ducts. This will be there. Fine. Whereas in the case of type 5, only intrahepatic will be there, which is known as Caroli's disease. It is known as Caroli's disease. See, so in the case of type 1, it is just solitary. It is single and extrahepatic. If it is single, but it is like a outpouching, it is known as diverticulum. And third one, it is choledococele. It is choledococele. And the fourth A, it is this extra and intra. Both will be there. Whereas in 4B, it will be what? It will be extrahepatic only. And it is multiple in nature. And in 5, it will be multiple intrahepatic cysts, and it is known as what? Caroli's disease. Fine. So these are the things you need to remember. Next, you saw a patient who is having this pain in the left epigastric region and along this left hypochondric region and along with this epigastric pain. And asking the patient still, he also feels the same pain which is being radiating to the back. And under an evaluation, you will be able to see on CCT this kind of inflammation over the pancreas. So it is what it is, this acute pancreatitis. It is acute pancreatitis, and the causes of this acute pancreatitis include, the most common one, it is this gallstones, followed by this alcohol. And in a case of children, there might be this blunt trauma, like for example cycling trauma, which causes pancreatic head injuries, or pancreatic injuries which causes this pancreatitis. Fine. And there are like few viral infections like 𝗏𝗏𝗏𝗏𝗏, 𝗏𝗏𝗏𝗏𝗏 and mumps virus. All of them, it will cause this pancreatitis. We know in a case of pancreatitis, there will be elevation of this serum markers like serum amylase, serum lipase. Fine. And in a case of post ERCP, endoscopic retrograde cholangiopancreatography, what we'll do, we'll put up a probe. Okay, we'll put up a probe, a stent inside, to see the component into this biliary tract. So in such scenarios, or in such cases, what will happen is that this pancreatic duct, via pancreatic duct only we need to go. So this may damage the pancreas and can cause pancreatitis. Fine. So this is the pain in the epigastrium, and it is radiating to the left side of the back, especially, and it will be relieved by sitting. Okay, there will be this Prayer sign, also known as Mohammedian Prayer sign. It is known as Mohammedian Prayer sign. Yeah, this question has been came many times, okay, about this pancreatitis. So you should be vigilant enough. Fine. And this pancreatitis can lead to this kind of complications. In a case of hemorrhagic pancreatitis, you will be able to see this type of signs. If it is around this umbilicus, it is known as Cullen sign. And if it is around the flank region, it is known as what? It is known as Gray Turner sign. Around the flank region, and it is known as Gray Turner sign. And there is also one more sign around this inguinal region. It is known as Fox sign. Okay. Then this pancreatitis, they can cause this paralytic ileus. And because of this paralytic ileus, there are a few features which include your cut-off sign of the colon. There will be a sign which is known as cut-off sign. The colon appears that it is being cut off from the rest part of the colon. So colon cut-off sign, it is typical for this pancreatitis patients. Fine. And the investigation is CECT. And for treatment, what we need to do, like enteral nutrition is better. In a case of mild to moderate, the enteral nutrition, it is better than the TPN. Okay. Next, we need to provide them with multiple fluids, because this pancreatitis patient also, they will proceed or they will present with the features of vomiting. Fine. And as there is a pain, we need to provide analgesics like methimazole and buprenorphine. Fine. And what are the indication of TPN in a case of pancreatitis? If you see here, like you need to give TPN in a case of shock, or in a case of any severe pancreatitis. In a case of severe pancreatitis shock, you need to give this TPN, because in a shock also the patient cannot eat, and in a case of severe pancreatitis, if he drinks a sip of water itself, then he will be started having this pain. Okay, remember. Okay, just remember these things. Next, about this few malignancies: insulinoma, glucagonoma, and 𝗵𝗶𝗄𝗏. Okay, insulinoma, glucagonoma, and 𝗵𝗶𝗄𝗏. This insulinoma, we know it produces the insulin. So if it produces the insulin, it will cause hypoglycemia. So it will be characterized by a triad which is known as Whipple's triad. There will be symptoms of hypoglycemia, and the symptoms of hypoglycemia, it will reverse once you give glucose. Okay, the improvement of symptoms after taking the glucose, फिर उसके बाद the blood glucose level will be at the level of hypoglycemia. So there is a symptoms of hypoglycemia, and there is an actual blood glucose level which is less, and along with this there is an improvement symptom which happens after the taking the medications, or especially the oral glucose. Fine. And next, this diagnosis. The diagnosis, what we can do is that we can do 72 hour fasting levels. Fine. And for management, we can use diazoxide, and along with this we need to give hydrations. Okay. And as a main modality, this insulinomas, we know this insulinomas will arise from the pancreas. So either if it is at the tail, we can just cut off and remove the tail, or if it is at the head, what we can do, we can remove by enucleation. If it is at the level of head, we can remove by enucleation. Remember. Fine. Next one, it is what it is, this glauconoma. Yeah, good, Dr. Starek. Good. Next, this glucagonoma, it will be presenting with this peculiar type of rash. We know this glucagon, it will cause increase in blood glucose level. So it will cause increase in blood glucose level, and it will cause this type of dermatitis, which is known as necrolytic erythema migrans. It is known as necrolytic erythema migrans. So in which of the following tumor or which of the following conditions you will see this type of necrolytic erythema migrans, it will be classically seen in a case of glucagonema. It will be classically seen in a case of glucagonema, remember. Sorry. Next, if you see the next disease, which is known as vasoactive intestinal peptide tumor. This kind of vasoactive intestinal peptide tumor, also known as VIPoma, it is also known as Werner-Morrison syndrome, also known as pancreatic cholera, also known as Vada syndrome. It is also known as Vada syndrome. See, in this scenario, the patient will be experiencing this watery diarrhea 4 to 6 times a day. So it is lead to this electrolyte loss of sodium, chloride, potassium, and bicarbonate. Okay, all of these things will lead to this increased, along with this increased blood sugar levels and hyperglycemia, along with hypercalcemia, and hypercalcemia. So it's dono hoga. So remember, it is the VIPoma which mimics this cholera, and along with this cholera, there will be a presence of this loss of sodium, chloride, potassium, and bicarbonate. Along with chloride, potassium, sodium, and bicarbonate. So all of this following will be seen along with this diarrhea, and this is the typical for this VIPoma, which is also known as WDH, Vada syndrome. Okay, yeah, Vada syndrome. Next, we'll move on to this general surgery component. Do you have any doubts? Yes, do you have any doubts? Yeah, for GRD, we use 24-hour pH monitoring. Okay, guys. Okay, Gautam. Yeah, I guess there is no any doubts. We'll proceed ahead. Yes, more than 30 minutes. Yeah, fine. We'll take around more 10 to 15 minutes to finish up the surgery. 10. Okay. If you see this general surgery part, okay, you need to know about the sutures. The sutures, few of them they are non-absorbable, and few of them they are absorbable. So remember about this non-absorbable suture. The natural non-absorbable sutures include silk, nylon, okay, silk, nylon, and steel also it's a natural. So remember about this silk and nylon. Whereas synthetic one, it includes this polypropylene, polyester, and Dacron. So remember these 3 points: polypropylene, polyester, and Dacron. And absorbable natural one, it is this catgut. Okay, we know this catgut, it is absorbable and it is natural in nature. And synthetic one, which includes polyglycolic acid and polygalactic A. Okay, this 2 one. And finally this PDS. So remember. So in VIPoma, as I told you, right, there will be features of diarrhea will be mentioned, and there will be features of this electrolyte imbalances, and hyperglycemia and hypercalcemia will be given. So if you try to rule it out, you will be able to get these things correct. Okay. Then about the suture techniques. If you take a bite, if you take an individual bite, so this is known as what? This is known as simple interrupted suturing. Just one bite, after one bite you are tying, after one bite you are tying. So this is simple interrupted. Okay, whereas in a case you took a bite and you are continuously doing it, so it is what? It is this simple continuous. It is known as what is known as simple continuous. And there are 2. Yeah, catgut is from this ship gut. I guess, guys, few of you is not in live. I guess just press this live button so that you will be in par with this class. Fine. Then there is 2 mattress, horizontal mattress and vertical mattress. If you see this mattress, just remember about this. Yeah, Dr. Pratik, it is still available. About this vertical mattress, remember about this one mnemonic. This dur dur se pass pass means you take a bite means distant to the wound or distant to this incision site. Then you cover it up, and when you take outside, you took up the next bite which is near to it. So you took a bite, you came along, and you took up the needle, and you took up the next bite, and you took up in, and you took out the needle. So you just pricked and you went along, and you taken the bite here, you opened up, and then you just went here, and from here you just came nearby, and then you tied it. Okay, so see, so it is what? It is the wound. So you took up this bite, like you put the needle here, and you went along inside, and you took up out the needle. So ठीक है, जैसे तूने ऐसे किया तो बाहर निकला, तो you just took it out. So you just pulled out the string, and then what you do, you prick again. Okay, you prick again from here. So here to here. Okay, here to here you pull out, and when you pull out, you will have 2 ends, right? From starting end and this end. Then you tie here. So this is known as vertical mattress. So this is known as what? This is known as vertical mattress. So okay, dur dur se pass pass se. Okay, this is known as vertical mattress. Whereas opposite of this, it is this horizontal mattress. Horizontal mattress, it will be done in this side. Okay, it will be like this. Then you take from here, you merge it. Okay, like you took a bite, okay, you came along and you took a bite here, then you came along and you tied here. This is how in vertical mattress. So in horizontal mattress. So just remember this vertical mattress. So that you won't get confused with it. So you can solve this another one easily. Fine. And there are two knots. One is known as square knot. Another one is known as granny knot. How will you differentiate these two knots? You just draw a intersecting line. If you see here, they will ask you means which of the following suturing techniques has been used in this condition. So you need to identify whether this is horizontal mattress or vertical mattress. They will give you which surgical technique has been performed: subcutal suturing, surgical mattress, vertical mattress, or horizontal mattress. Like that they will ask you. Here about this knots, if you see, mostly you need to draw this line. If you see, if the same color is present, okay, see here it is red color which is above, red color which is above. So it is what it is, this square knot. But if you see here the violet color is above, here the pink color is above. So if two different colors are there at this intersecting junction, it is granny knot. So this is square knot, which is also known as a reef knot, which is one of the stablest knots. Okay, yeah, stablest knot, remember. Fine. Next we'll move on to this classification of burns. If you see about this classification of burns, in the case of first degree burns, it is just involvement of the superficial epidermis. So there will be just erythema will be there and it will be painful in nature. Whereas second degree partial tear, there will be formation of this blisters. There will be these vesicles and the blister formations will be there. Okay, especially this blisters formation will be there, and it also will be painful in nature. Partial in second degree partial will be painful in nature, whereas type 3 it will be around the same or less painful in nature, less painful, and there is a presence of this pain prick sensations will be present in a case of third, means like second degree deep burns. Whereas in a case of third degree burns, which is deep burns, there will be no sensations. Okay, whereas if it is involving till the muscles and this bones, then it is the fourth degree burns. Okay, fourth degree burns. This is how you will classify the burns. And after that classification, you need to calculate this fluids. How much amount of fluids you will give. Previously we used to use this Parkland formula. Now we are using this ATLS formula. We are using this ATLS formula. For this ATLS formula, remember, for adults who is more than 14 years of age, in most of the scenarios it is 2 ml into body weight into kg in percentage of burn surface area. Okay, it is the 2 ml in 2 into body weight into percentage of body surface area which is being involved. Whereas if it is child is less than 14 years, if the body weight is less than 30 kg, then it is 3 ml. So 14 children, it is third alphabet, so 3 ml, and are less than 30 kg. Here also 3 is there, so it is 3 ml. Or if it is an electric burns, will be what? Will be having this 4 ml. So see, if it is adults, it is 2 ml into same body surface area which is involved along with this body weight. Okay. Then if it is electrical, it is 4, and if it is child, it is 3. Child 3, adults 2, and electrical 4 burns. Okay, remember, this is the thing you need to remember. Next, about this type of graft, CPC, this is the partial thickness skin graft, and it will be having the gaps so that you can stretch and you can cover the maximum surface area. But only problem here is that it will be having a maximum secondary contraction. So because of this maximum secondary contraction, what will happen is that this will have this very less or very poor cosmetic outcome. Okay, very less or very poor cosmetic outcome. Next one, if you see this type of full thickness, this type of graft which is known as full thickness skin graft, and it is known as 𝗔𝗵𝗔 graft. It is known as 𝗔𝗵𝗔 graft. Here the cosmetic appearance will be better. You can see, right? Here the cosmetic appearance will be better because of this less secondary contraction. Fine. We'll move on to the next part. If you see the ulcers, if you see there is no any blood, without any blood, and this gaiters area, around this area where there is most common venous ulcers occur. So it is what it is, this venous ulcer. And if you see this type of necrotic base, it is what it is, this arterial ulcer. And if you see around this area, around this foot, okay, around this foot, which is because of this loss of sensation, this ulcer occurs. It is what it is, this neuropathic ulcer. It is this neuropathic ulcer. And next, if it happens at this pressure areas, for example, if someone is lying, if it is someone is bedridden, then he will keep his leg like this only. So this causes this ulcer, which is known as pressure ulcer, also known as decubitus ulcer. Fine. And next, in born patients, you will see this type of ulcer, which is known as Marjolin's ulcer. They'll be mentioning, this Marjolin ulcer. Okay, Marjolin ulcer, and this Marjolin ulcer, it is be pre-malignant for this squamous cell carcinoma. Okay, a good parole. Yeah. Next, you need to know about this type of parotid gland malignancy. The most common overall, it is this pleomorphic adenoma. And this pleomorphic adenoma, P for P, remember, it will be having the pseudopodia projections. So you should be careful enough to remove. While removing this, you should be careful enough, and you cannot do enucleation. So you need to do complete excisions in such cases. Okay, okay. And it is most commonly at this tail of parotid glands. And Warthin's tumor, remember, it is most commonly or exclusively seen in a case of parotid glands. It will be exclusively seen in a case of parotid glands. Fine. And it has a defined capsule. So unlike pleomorphic means adenoma, it will be having this pseudopodia extension. So it will be having this neural involvement as well. So we cannot do enucleate and excis. Whereas Warthin tumor, it will be having this capsule. So we can do enucleation and we can remove it. Fine. Just remember. And then this mucoepidermoid cancer, it is the malignant tumor. It is the most common malignant tumor of this parotid glands. Okay, and it will be associated with this lymph node metastasis, and it will be associated with this lymph node metastasis. Fine. And next one, it is this adenosystic. Adenosystic, it is the most common malignant tumor of submandibular gland. It is the most common malignant tumor of this submandibular gland. Okay, so just remember about this few parotid malignancies, it can be asked. And about this management of this cleft palate. Okay, we see about this cleft palate, this unilateral cleft lip. If there is just only unilateral one, remember, it is 5 to 6 months. If it is bilateral, it is 4 to 5 months. So if it is bilateral, it is 4 to 5 months. And if it is cleft palate, if it is soft cleft palate, remember, it is around the same, it is 6 months. Whereas if it is hard palate, if it is hard one, we can replace later on at 18 months. At 18 months. Okay, fine. Next, you say a cleft palate. Okay, you say a cleft palate, which is means if there is any cleft palate along with this hard palate and soft palate, then we need to do two different surgeries. For example, if there are hard palate involvement or hard palate cleft also, soft palate cleft also, so we cannot do at simultaneously. So we need to do one by one. So see, soft palate S for S will be done at usually at 6 months. S for S it done at 6 months. Yeah, it is due to the non-fusion of maxillary and medial nasal process. Yeah, good, Dr. Abhijit Singh. Good. Fine. And about this hard palate, it will be done at around this same, around the 18 months. Fine. Whereas if there is lip, where there is lip, cleft lip which is being associated, remember, the first thing we need to do, it is this, which is this lip along with the soft palate. So we need to do lip along with the soft palate, along with this hard neck, followed by this hard palate. So first is the soft palate with the lip, and second is the hard palate, as usually we do. So hard palate, it is same, it is 18 months. So don't need to bang your heads on hard palate, which is 18 months, everywhere. Whereas in the case of unilateral one, see, if it is unilateral one, see for this unilateral one, which is the most earliest. See, the both soft palate at 6 months and unilateral, it is around 5 to 6 months. So whichever is the earliest will take up in. So unilateral means the earliest it is 5 to 6 months. So we'll write as 5 to 6 months. Fine. Whereas in the case of bilateral, usually bilateral cleft lip itself we need to do at 4 to 5 months. So here also we'll do at 4 to 5 months. Okay. So itna yaad karo. So if it is unilateral cleft lip matlab 5 to 6 months. If it is bilateral, then it is 4 to 5 months. And if it is unilateral just soft palate means S for S and S for 6, it is 6 months. And if it is hard palate means, remember, it is 18 months. So itne sare aapko yaad rakhna. Then about this TPN. If you see about this TPN, mostly in a case of pancreatitis which is intractable, we will use it. So we'll see what are the complications or what are the indications for use. If there is a bubble is small, if we will call them a short bubble, so we'll use this TPN, and we also use one more drug which is known as what? Teduglutide, which is known as teduglutide. Yeah, okay, teduglutide. Next about this ECF, if there is enterocutaneous fistula which is having more than 500 ml of output per 24 hours, then we will use this total parenteral nutrition. And if there is any acute and active IBD, like acute active Crohn's disease, then we'll use this TPN. So we already discussed, we just go and see. Okay. And about this initial stages of pancreatitis. And if there is any prolonged ileus for more than 72 hours, then we will use this. And what are the complications? Either there might be two complications, either how we are feeding, it may complicate the patient, or how we are putting the line which are putting for the center line, it may have some complications. The feeding complication, it is known as re-feeding syndrome. You are feeding them, it is known as re-feeding syndrome. So remember, in re-feeding syndrome, most of them it will be decrease. So it is what? It is decrease in PCM. It is decrease in phosphate, potassium, and magnesium. So there will be decrease in phosphate, potassium and magnesium, or else remember it as PM. Don't get confused. So it is this phosphate, potassium and magnesium. Okay. So here the main culprit is hypomagnesemia. Okay. And about this line may, about this line related means this line may undergo infection which causes this sepsis, which is the most common cause for this removal of these lines. And while doing this line, we can puncture the pleura, which is this pneumothorax, or else we can do, means while doing, if there is an entry of air, it is this air embolism. Fine. Next one, it is this thoracic duct injuries. It can, while inserting, we can injure the thoracic duct, or we can injure the cardiac tamponade. Fine. Heart will lead to this cardiac tamponade. Fine. Next, we'll see some extra age topics. See about the CEAP classifications. Remember one thing: C0, it is no dilatation. C1, it is just small dilatation, which is known as telangiectasia. C2, remember this 2 for V. So V means for, it is what? It is this varicose vein. Fine. And C3, it is what? See, make this 3 into like this. So it is what? It is this presence of edema. So edema, it is C3. Fine. And C4A, initially, if there is any venous pooling, there will be formation of pigment. So first one, it is this pigmentation. So if there is pigmentation, then the macrophages will come and they will form this scar inflammation. So it is known as what? It is known as lipodermosclerosis. In B, it will be forming this lipodermosclerosis. And C4C, it will cause us corona phlebectotica. It causes corona phlebectotica. And C5, it will be what? It will be this healed ulcer. C5, it is the healed ulcer, whereas C6, it is the active ulcer. Okay. So remember, it is C2, it is varicose vein. C3, it is the edema. C4A, it is the pigmentation. And C4B, it is what? It is this lipodermatosclerosis. And C4C, it is the corona phlebectotica. And C5, it is the healed ulcer, whereas C6, it is what? It is this active ulcer. Remember. So these are the things you need to remember in the case of varicose veins. Fine. And if you are able to see this type of pneumobilia, small bowel obstruction and gallstone, it is seen in a case of gallstone, ileus. Okay. This triad is known as Rigler's triad. Okay. Fine. Next, about this vascular things, if you see, if there is any aortoiliac obstruction, it will be having this claudication at buttock, thigh. Okay, buttock, thigh and calf, and along with this there will be erectile dysfunction, which is known as Leriche syndrome. So if it is at the level of aortoiliac bifurcation, so it is at the level of, it will cause claudication in buttock, thigh, also erectile dysfunction. Okay, it is known as Leriche syndrome. Just remember. Whereas if it is at the level of common femoral vein, it will cause at the level of thigh and calf. Okay, whereas rest disease, the rest are below to this, it will cause only calf coagulation. Okay, calf claudication. So if it involvement of this femoral, then there will be what? There will be thigh claudication as well. Whereas in the case of aortoiliac disease, what will happen? It will cause even buttock claudication, and there is a presence of this impotence, which is known as what? Erectile dysfunction causing this impotence, which is known as Leriche syndrome. It is known as Leriche syndrome. So remember. Yeah. Right. Next, about this Boyd's classification, if you see this grade 1, it is for this Buerger's disease, which is this thromboangiitis obliterans. Okay. So in grade 1, there is initial pain, but he can continues to walk. Whereas in grade 2, the patient can walk, but he will be still having the pain. Whereas in grade 3, the pain compels the patient to take rest. Fine. Whereas in grade 4, in rest also there will be a pain. So this was asked in the previous FMGE examination. Remember. And this is this, which is used to prevent the DVT, which is this pneumatic compression device, and this is this negative pressure wound therapy. Okay, for improve the wound healing. Fine. Yeah. Then there are a few instruments. This is the Joel's thyroid retractor, which is used to retract the thyroid gland. Next, it is this abdominal wall retractor, and this is the proctoscope. And there are a few more retractors. If it is flat, it is this Morris retractor. If it is like a question mark, it is known as Diever's retractor. And if it is looking like a N, it is known as Doyen's retractor. Rowen's retractor. Fine. And next, if you see this small one or this L-like retractor, it is known as Langerback retractor. And if you are able to see this type of tooth, it is known as Alice tissue forceps. And this is the bipolar cautery, which is having this two. And if it is just one, it is this unipolar cautery. It is this unipolar cautery. And Babcock's forceps, it will be like this heart. So it is this Babcock's forceps, which is used to handle the spermatic arch and fallopian tubes. Fine. And next, this is this artery forceps. And this is the Humbee's knife, which we use to extract or which we use to take the skin graft. Fine. And this is the needle holder. And needle holder will be having a central depression. Okay. Central depression. Remember. Very confusing IBQ. Which one? And this is this linear stapler. And this one, it is the stapler remover. Stapler remover means we use for this closure of this abdominal wall, closure of the skins. Fine. And this is this circular stapler, okay, which is used for this bowel, especially this bowel anastomosis. Fine. Then this is what? This is this 𝗏𝗵𝗶𝗀 drain. And this is the open drain, which is this corrugated drain. And next, this is what? This is the semi-closed drain, which is what? Which is this Jackson Rate drain. This is this T-tube, which is used for cholangiogram. Fine. And next, if you see this one, this is what? This is this harmonic scalpel. Harmonic scalpel. Okay. And this one can cut and seal at same time. Seal at same time. Okay. That's it, guys. That's it about the surgery part. Okay. I will have this gynecology part left. I will do the gynecology part. And if you have any doubts, please let me know. We'll discuss it once. Fine. Do you have any doubts? Like, yeah, like means which one you have? Like, if you have any doubts, please let me know. Means about this retractors you're asking? Yeah. Thank you. Yeah, thank you, guys. Thank you, Dr. Starix. Yeah. A graph, there are two graphs. Like there is one, this which is known as, yeah. Okay, fine. Yeah, there is no any issues, I guess. Yeah. In graft, what do you need? Like in graft, what do you need? I couldn't get you. In graft, if you see, there is just partial thickness and full thickness skin graft. In partial thickness graft, you will do this more openings and it will be more stretchable. Okay. And it can cover most of the surfaces. And wherever you harvest, you can harvest for multiple times. And see, this will be, this won't be having a proper, this won't be having a proper cosmetic appearance. It will be having a improper, or it will be having less cosmetic outcome because of this secondary contraction. Means it undergoes this contraction. Because of this, it won't look good. Whereas in a case of full thickness skin graft, you will bring this full thickness and you will keep it. So the cosmetic outcome will be better. Okay. That is the thing you need to know. I guess you got it. Fine. We'll move on to this gynecology part. Fine. And with this gynecology, we'll end for the day. I'll try it. Fine. And the same, like surgery medicine means there will be few things you need to think, like what is the next step, like that you need to think and answer. Whereas obstetrics and gynecology, let me tell you, like you read this file, it has most of the things which you need for your examination. In gynecology, it is not mostly like what is the next step kind of, there is very less kind of next step. Everything, it has a conceptual meaning. If you just understand and click out these concepts or click out this important keywords, then you can make them in line. Once you make them in line, you will get this correct answer. No, means I'm not, Dr. Abneet, I'm not sure about this PVQ session. Like, let me clarify with the team and I will update you back. Fine. Yeah, look, means in surgery, that's what, like in each questions you need to get the grasp. Like, for example, let me tell you, like what are the mistakes which we do during solving of questions. There are 3 levels of mistakes can happen. 1, you don't know the stuff. Okay, keep it apart. 2nd, you know the stuff, but you are unable to apply it. 3rd, you know this stuff and you try to apply it, but you got confused between 2 options. So these are the three various levels. So if you don't know, then you need to study. If you're unable to get the catch, then you need to study or you need to do multiple questions, so that you need to get the grasp or the keywords from the question. And third, like if you're getting confusion means, then it is a small point of delineation. You need to go back to a topic and try to make a differential point between option A and option B. Okay, if you make these three things correct, then you will able to solve most of the questions correct. Okay, this is what I tell for the most of the students, and it actually works, and you can also try it. Okay, this is my personal opinion. Fine. Fine. Okay, guys, we'll move on to this gynecology part. First, you saw this female who is presenting with these features of this swelling, which is around the level of anterior 2/3 and the posterior 1/3 of this labia majora. Okay, you saw this swelling. So what do you think of? Which cyst is this? It is what? It is the cyst at this Bartholin's gland. It is the Bartholin cyst. It is a Bartholin cyst. And the most common complication, like our most common presentation, is that it is flocculent. It is flocculent and it is not intercilling. It is like if it is something is there, right, it will be having this kind of foreign body sensations. Okay, so because of this insecurity, the female will be complaining and they will be coming off. So usually it will be flocculent and without any tenderness. Whereas if it gets infected, if this Bartholin cyst becomes an infected abscess, okay, then it will be causing painfulness. So if there is just this cyst, then we'll do marsupialization. Whereas if there is presence of this abscess, then we do incision and drainage. As like in breast abscess, we do ultrasound guided multiple aspirations. As like here as well, what we do incision and drainage. Means first we do marsupialization followed by this incision and drainage. Fine, just remember. Next, you saw this 15-year or 16-year-old child who is presenting with this well-developed breast and well-developed hairs and everything. But her mother complains that she didn't attend her periods yet, but she complains that every month she is having this lower abdominal pain. Okay, so you plan to do an evaluation. So you did a visual examination where you can able to see this type of bulging out or bluish bulging out type of hymen. So it is the classical case of good Dr. Gautam, good Dr. Anara. It is what it is, this cryptomenorrhea. It is cryptomenorrhea. It is what it is, this cryptomenorrhea, which is because of this imperforate hymen. Imperforate hymen. Okay, and usually it is imperforate hymen. Okay, see this is the marsupialization which are doing here for this Bartholin's cyst. Fine, and this is the cryptomenorrhea, and there are mostly it is because of this imperforate hymen, and sometimes it might be because of this persistence of this transverse vaginal septum. Okay, in those cases we need to go abdominal and remove it, but mostly it will be imperfect hymen only. So in this we'll do a cruciate incision. We do this cruciate or X-shaped incisions so that it won't heal it back. Okay, so that it won't heal it back. And in the case of this, we won't do per vaginal examination. We'll do per rectal examinations. When we go and do this per rectal examinations, you will able to see there is this bulging of this anterior wall of the rectum. And in anterior wall, you will able to see the bulge, or you will able to feel the bulge. Okay, so you won't do this per vaginal because she is child, right? You cannot do PV in her. So you do per rectal examination. Fine. And then how will you differentiate this primary amenorrhea? So mostly mostly in a case of primary amenorrhea, like mostly there will be findings given. First, the karyotype. So if the karyotype, if she is female, fine, then what we need to look is we need to look into the uterus, like whether and secondary sexual characteristics. Fine. If there is the presence of uterus, if the uterus is present, but if it is an infantile shaped uterus, okay, and the gonads are streaky gonads, it will be classical case of Turner syndrome. Fine, it is a classical case of Turner syndrome. Next, if the uterus is absent, but the secondary sexual characteristics like breast development is there and pubic hair and axillary hair are there, then you will think of which disease? Yeah, guys, you will think of Mullerian agenesis. Because hair is present here, but only this uterus is absent along with this blind end vagina. Fine. Whereas in the case of testicular feminization syndrome, there will be well developed breast, but there will be absent of this pubic and axillary hair because that testosterone is not acting. This dihydrotestosterone is not acting on the receptor. Okay, so there will be absent of pubic hairs. Okay, there will be less breast development will be present. breast will be present. Okay, that will be proper development of the breast. Then in a case of Swyer syndrome, it is the 46XY chromosome along with the streaky gonads. Here the uterus also present. Okay, but see, there is also vagin also normal developed, but they won't come into this secondary, so they won't have this proper secondary characteristics because there is this streaky gonads. There is this streaky gonads. So remember, it is the Swyer syndrome. Fine. Whereas in the case of Kallmann syndrome, whereas in the case of Kallmann syndrome, it will be associated with this. All FSH and LH will be decreased. Along with this, it will be presented with anosmia. Yeah, it is this hypothalamus problem. It will be having this anosmia as well. Yeah, good guys. So these are the few points you need to remember. Like if there is uterus present and all the hairs present and breast development is there, but uterus is absent, you will think of Mullerian agencies, which is this 𝗵𝗶𝗃 syndrome. Whereas if uterus is absent and breast is there, but there is no pubic and axillary hair, then you will think of androgen insensitivity syndrome. Whereas in the case of Swyer syndrome, the chromosome will be 46XY, but there is a presence of uterus, but the streaky ovaries and loss of secondary sexual characteristics, it is the Swyer syndrome. Whereas in the case of Turner syndrome, there will be this shield-shaped chest along with this widely placed nipples, and along with this, they will be having this short stature and streaky ovaries, 45XO chromosome. 45XO. Turner it is, yeah, 45, it's 45XO. Yeah, no, if you ask me, Dr. SNH, yeah, it is one of the approach which we can use, but make sure you are having a proper revisions with your notes once. For example, if few subjects you will be having a more grip on your own notes. Okay, so make sure you are having them revising one more time. Okay, just make sure you are revising one more time, or once revising your own notes, make this notes read. Okay, so revise your notes one more time and read these notes along with it. Fine, because if you read these notes, it is completely new for you, right? And it is difficult for you to read this thing and remembering for 40 days. But you already read your previous notes, and you read your previous notes and read my notes. And you will be able to correlate between here and there. Then after that, you read my notes. Then it will be the correct approach so that you can get this mark correct. Okay, that will be the correct approach if you ask me. Okay. Fine. Next one, it is what it is this ambiguous genitalia. Okay, that should be there. Fine. Okay, because it is new, because content is available everywhere. In your main notes only from I prepared, like around the same will be here, will be there. Okay, but thing is that it is how concisely we are taking up. Fine, because if you read it new and you are unable to correlate, there is no mean of having and reading this. Okay, so I want you to correlate from your main notes to these notes, and once you have this proper correlation, if you read this note, it will be enough. Okay, that is my part. Fine. ET score shattered my confidence. No, it's okay. No, there will be few disappointments will be there that you should accept. It will make you to grow. It will make you to grow for sure. Okay, and once you complete your GT and see these papers, like it will be asked, means if you read these notes, you will be able to score better in the GT. That's I can assure you. But you should know the concept as well, and these concepts are better built on your main notes. So read one more time and read this. That is the absolute correct way. After this, you can have multiple revisions. Then your points are already connected. Once it connected, it will be the best source of revisions for you. That is my assurance. Okay, don't worry. There will be disappointments in your GT score and everything will be there. Okay, but when you progress and when you do the smart work and hard work enough, you can come out of this. Don't worry. Don't worry. Okay. Okay, don't worry. Okay, there's two more things you will do it. Don't worry. I take all your topics with my notes. Yeah, okay. Yeah, good. So you can read from there also, and as a revision source, you can use this. Okay. Don't worry, we'll get through this time. Okay, just put see where you are lacking. Fine. Next about this ambiguous genitalia. Means ambiguous genitalia means the presence of, like with this genitalia, you cannot identify whether this is male or female. For example, in a case of ambiguous genitalia in males, the most common cause, it is what it is this testicular feminization syndrome. Whereas in females, it is most common cause, it is what it is this congenital adrenal hyperplasia. It is this congenital adrenal hyperplasia. Just remember. Okay, there's 2 points. In a case of, the most common one, in a case of congenital adrenal hyperplasia, it is what it is this 21-hydroxylase deficiency. It is the 21-hydroxylase deficiency. Fine. And next, if you see this semen analysis. They will ask. Yeah, it is good. It is good. You can use it as a source of liver revision. 21 hydroxylase deficiency. Fine. Next, if you see about the semen volume, the normal it is around 1.4 based on the new update, and total sperm number it should be around 39. Okay, 39, around 39, and total motility should be around 42%. Okay, previously it was 40, now it is increased to 42. Now on the progressive should be 30, and the main one it is the forms, which is this morphology. The morphology should be 4%. Okay, morphology should be 4%. Okay, then you should know about few terms. One is what? One is known as aspermia. Remember, it is not aspermia. It doesn't mean that absence of sperms. Aspermia means absence of semen. Okay, if it is azoospermia, it is absence of sperm. Absence of sperm. Remember. Okay, it is the absence of sperm. Okay, asthenospermia means the motility is impaired. So there is no proper progressive motility. So just remember all these terms so that if they ask, you will be familiar with it. Fine. And next, about these 3 diseases, and one should be asked in your examinations, or sometimes 2 can be asked in your examinations. Okay, fine. If I have first patient who is presented with this features of this strawberry cervix, and here you see this trichomonas. You know this trichomonas, right? Trichomonas, what is the color of discharge? So remember this, our flag is Tiranga flag, so the tricolor flag. So the third color is what? It is the green. Okay, third color is kya? It is the green. So remember, it is the green frothy discharge. Okay, third color here are in the LED, means in the traffic light there will be red, yellow and green will be there. Third color it is kya? It is the green. So remember, it is the green. Okay, third color kya? It is the green. So this trichomonas, it will be what? It will be this green frothy discharge, and the pH will be more, and it will be having this strawberry vagina. And we know this strawberry vagina, it is caused due to this trichomonas vaginalis, and it will be having this twitching motility. It will be having this twitching motility. Okay, twitching motility. And for this cultivation, we can use this Diamond's media, and for this treatment, we'll use metronidazole. So trichomoniasis, green frothy discharge, and there will be this what? There will be this strawberry cervix, and for culture, we'll use this diamond media. And this culture will use this diamond media, and there will be twitching motility, and treatment will use metronidazole. Okay, and then about there will be this old, means pregnant patients who is our OCP pills patients, who is a diabetic patients, now presenting with cardioid discharge. Presenting with this cardioid discharge with more pruritus, and while checking the pH is less than 4.5. The disease which is mainly associated with this less pH and showing this cardioid discharge, it is seen in a case of candidial vulvovaginitis or candidiasis. And in candidiasis, you know, this will show this budding yeast, okay, and pseudohyphae formation as well. And this can be cultured in seborrheic dextrose agar. And we know it is what? It is this candidiasis. So we will use what? We'll use this fluconazole. We'll use this fluconazole or clotrimazole pessaries. Fine. Next, if you see this bacterial vaginosis, it is what? It is dirty white. Remember, it is bacterial vaginosis. It will be having this dirty white discharge. Dirty white discharge, which will be foul swelling in nature. And this dirty white discharge, if you see on examination, you will be able to see this type of cells. Means this epithelial cells having this lot of bacilli. Yeah, good Dr. Naresh, good Dr. Anna. Yeah, good Dr. Gautam. So it is what? It is this clue cells. These clue cells, they are exclusively are mainly seen in a case of this bacterial vaginosis, and we'll use this criteria which is known as Amsler's criteria to diagnosis. There will be this grayish white or this dirty white discharge, along with this pH will be more than 4.5 and presence of clue cells, and there will be this WIP test will be positive. There will be this fishy odor, and adding KOH, you will be able to see there is the smell of fishy odor. So this will be seen in a case of bacterial vaginosis. So treat this bacterial vaginosis, will use metronidazole. So remember, trichomoniasis and bacterial vaginosis will use metronidazole, whereas in a case of candidiasis will use fluconazole. Yeah, good. We'll use this Amsler's criteria. फिर आगे बढ़ते हैं. You have a patient who is having this features of dysmenorrhea. there is a painful menstruation, okay, painful menstruation, and on evaluation, you will be able to see there is this globular enlargement of the uterus, means the symmetrical enlargement of the uterus, and on histopathology, you will see the presence of endometrium in myometrium, presence of endometrium in myometrium, okay. So it is what it is this, yeah, it is the feature of this adenomyosis. It is the feature of this adenomyosis. The most common symptoms include this menorrhagia or increased menstruation, okay, then dysmenorrhea, pelvic discomfort, and the backaches. So pelvic discomforts, all of these things. So you will see there is a symmetrical enlargement. It is not irregular, it is a symmetrical enlargement of the uterus, but this enlargement will not exceed 14th week size. So it should be always less than 14 weeks. So this is the case of adenomyosis. So in such a cases, agar patient is fertile, okay, the patient want to preserve fertility, तब हम क्या दे सकते हैं? We can use this NSAIDs for the pain, or else we can use this LNG like Mirena to be kept inside to decrease this hormonal action, okay. So this is we can use if the patient wants to be fertile or wants her uterus. If not, the final management, it is what it is, this total hysterectomy. It is the total hysterectomy, fine. It is this adenomyosis. It is a regular or globular enlargement of this uterus. Whereas if we see this type of irregular enlargement of this uterus, and the patient is also complaining of menorrhagia, and this size of this uterus, it is exceeding, or if it is more than 14 week size also, it is what it is, a classical case of fibroids. It is a classical case of fibroids, and we know this fibroids, it is also known as leiomyoma. It is also known as leiomyoma. It is the most common benign tumor. It is the most common benign tumor of the uterus, and the most common type it is yeah, it is what it is, this intramural or the interstitial type of fibroid, okay. Whereas the submucosal fibroid, it produces more symptoms. It produces more symptoms like menorrhagia. Whereas the most common type, it is the intramural. This fibroid can undergo degenerations. The degenerations may include hyaline degeneration and other red degeneration, which is seen in pregnancy. Hyaline means just hyalinization, okay. Whereas in red degenerations, it will become red beefy appearance, and there will be increase in ESR. So there will be what? There will be increase in ESR and red beefy appearance, okay, red beefy appearance, and all of them will be seen during the second trimester of pregnancy. It is known as red degeneration, and the main management इसमें क्या करेंगे हम? Conservative management करेंगे, and rest and analgesis will give, okay. So this is a case about this red degeneration. Next, this is an ultrasound image where you will be able to see this hypoechoic mass, which is actually the fibroid, fine, okay. So you use initially ultrasound for management, and if there is infertility, if there is a cause of infertility, then we'll do this myomectomy, or okay, or if it is causing some pressure symptoms, then we'll do hysterectomy. Remember, so if it is case of if the female is presenting with history of fibroids, which is mostly submucosal or any other or intramural type of fibroids, but all other causes of this infertility are being ruled out, then next you should do it is the myomectomy, okay. So you can do like hysteroscopic myomectomy as well, okay, hysteroscopic myomectomy as well, based on the location of this fibroid, fine. And if it is old age patients having this pressure symptoms, causing this urinary symptoms, this constipation, then in such cases you can do hysterectomy, fine. So the asymptomatic patients, nothing do. If it is symptomatic, we can give some of this medical managements like OCPs. Then if it is asymptomatic, rapidly growing or pedunculated, means then we can go for surgical options, okay, because this pedunculated, they can undergo torsion. They can undergo torsion and unexplained infertility, because all other causes of this infertility are ruled out. In such cases, we'll go for definitive surgery management, which is this removal of this fibroid and or removal of the uterus, fine. Next, about this endometriosis. If you see in the case of endometriosis, the patient will be having a typical complaint. क्या बोलेंगे? There is a feature of painful menstruation, and there is a painful during intercourse, there is a painful, which is known as dyspareunia, and there is a features of infertility. So all of them, they are the classical features of endometriosis. Endometriosis, it is the presence of endometrium. It is the presence of endometrium outside the uterus. Endometrium outside the uterus. Yeah, good Dr. Gautam, good Dr. Finance. See, adenomyosis, we saw this is the presence of endometrium inside the muscle layer. Whereas in the case of here, it is the presence of endometrium outside the uterus, for example, in the around this peritoneal layer, which is causing this type of matchstick head colonies, matchstick head sign, or this type of in ovary, it produces this type of cyst, which is known as chocolate cyst. Fine. And this leads to this retroversion of the uterus, and this adnexal mass means around this uterusal area, it will be fixed in nature. Fine. So to diagnose this, we'll use this method, which is known as which is the laparoscopy. So with laparoscopy we'll diagnose it, and we'll take up a sample and we'll do histopathology examination and we'll confirm it. So the gold standard investigation is the laparoscopy along with this histopathological examination. Fine. For medical management, the patient is complaining of pain. Okay, fine. So pain is because of this estrogen progesterone cycle. So we'll give COC, combined oral contraceptive pills, which is having this progesterone action. Or else we can create a pseudo menopause state with danazole or GnRH agonist, Yeah, fine. Then we go for the surgical management to prevent if there is adhesions of the fallopian tubes causing this infertility. We'll remove the adhesions. And if the cyst, if it is more than 3 centimeter, this cyst is more than 6 centimeter, then we'll go for this laparoscopic cystectomy. Yeah, good question. We'll go for this laparoscopic cystectomy. Fine. Next, about this PCOS. If you see about this PCOS, it is also known as Stein-Leventhal syndrome. And here there will be increase in androgens and decrease in sex hormone binding levels. Here usually, in a case of menstrual cycle, first there will be increase in FSH followed by increase in LH. Okay, so the follicle need to grow, then only it is able to go for ovulation and it can mature back. Fine. Whereas here the follicle is not growing. The follicle is not growing because of decreased FSH and increased LH. So the FSH to LH ratio here it will be 1:2. So there will be decreased FSH and increased LH. So all of these follicles, it will remain in a very small size. Fine. So, and for diagnosing this condition, we'll use this criteria, which is known as Rotterdam's criteria. We studied in a case of bacterial vaginosis. What is the name of the criteria we'll use, guys? Yeah, what is the name of the criteria you will use in a case of bacterial vaginosis? What's the criteria? Yeah, good Dr. Anar, good Dr. Gautam, good Dr. Kwanin, good Dr. Killer Mafia. It is what it is, this Amsler's criteria. Whereas in a case of PCOS, we'll use this Rotterdam criteria. So what is Rotterdam criteria? Will tell, like good Dr. Naresh, good Dr. Bhargav, good Dr. Last option. Yeah, good. Yeah, good Dr. Kwanin. See, in hirsutism we use this Perryman-Galloway-Skerry. Okay, remember. In the case of Rotterdam criteria, there will be this ovulatory dysfunction, which includes this oligomenorrhea and amenorrhea, and hyperandrogenism, which includes this hirsutism, acne, and alopecia. And there is the feature of this polycystic ovaries on ultrasound. In ultrasound, you will be able to see there is a presence of central stroma. This is the differentiating features. There is a presence of this central stroma. Yeah, producing this string of pills, and there will be more than 12 follicles, and all of these follicles, they are very small follicles, and these small follicles, it will be having a maximum volume. It should be always mostly less than 10 ml. Okay, so less than 10 ml of this ovarian volume, which is this type of small follicles which is forming with central stroma, is typical for this PCOS, and the female will be having this type of skin tags and blackening, which is known as acanthosis nigricans. Yeah, there is one more syndrome which is known as hair on syndrome. That is also will be there. Here, if you see, we'll manage them based on that. For example, if a female who is just 15, 16, 17 years female, she is coming for her irregular periods. Her friends are having this regular periods, but she is having irregular periods. So to regularize her periods, we'll start her on OCP. Okay, so irregular periods में हम OCP देंगे. So based on the need, we'll treat them. Next, about this obesity. Obesity is mainly because of this insulin resistance. So obesity will give metformin. Okay, and for insulin resistance, we'll give metformin. Whereas if they come for hirsutism, we can start with combined oral contraceptive pills followed by this cyproterone acetate, or followed by this additional progestins. Whereas in a case of infertility, in a case of PCOS, the preferred drug now, it is what it is, this letrozole. It is the letrozole, and followed by which we can use this HMG and HCG for the ovulation induction. So these are the drugs we'll use. Fine. why there is obese patients? This obese patients will be having, because of this insulin resistance. Because of this insulin resistance, they will be having this 𝗏𝗏𝗀𝗃𝗃 nigricans. There will be more adipose tissue, and more adipose tissue will be exposed to this more insulin resistance and will be having this 𝗏𝗏𝗀𝗃𝗃 nigricans along with the skin tags, guys. Fine. And hirsutism will use this cyprosterone acetate, and for hirsutism scaling, for hirsutism will categorize based on a score which is known as Ferryman-Galway scoring. Okay. There is one more syndrome which is known as metabolic X syndrome. Okay, metabolic X syndrome. Yeah, all of the following metabolic disorders like PCOS will be there. In the case of type 1 diabetes mellitus, it will be having this 𝗏𝗏𝗀𝗃𝗃 nigricans. Good, guys. Then PCOS, it is related to this metabolic X syndrome. Around here, if you see, there is this abdominal obesity which is more than 88 centimeter, and triglyceride level will be increased more than 150, and HDL will be, which is the good cholesterol, which will be less than 50, and BP will be more than 130/85, and there is this fasting blood glucose which is mostly impaired, which is 110 to 126. Okay, and here it also will be, after 2 hours it will be around 140 to 199. Just remember these things. Okay, yeah, everything will be high in the case of metabolic X except this HDL. HDL will be less. Remember, HDL will be less. Don't think that HDL also will be more. Okay, HDL will be less. Remember. Next, about this ovarian hyperstimulation syndrome, it looks like this PCOS, but if you see, there is no central stroma. No central stroma. Okay, so in the case of ovarian hyperstimulation syndrome, there will be no central stroma, and these are those patients who are being treated for the infertility, and because of this more beta HCG, what will happen? It will form this theca lutein cyst. It will form this theca lutein cyst, and it will present with these features of vomiting and hypotension. Vomiting and hypotension. Yeah, vomiting and hypotension because of this third space loss. So this is the classical feature of this ovarian hyperstimulation syndrome, and if it happens, then we need to intervene accordingly. Sometimes it can go under for this torsion, so we need to intervene immediately. Fine. Next, about this next condition, which is this genital TB. So we saw this kidney TB as well. Here we see this genital TB. So genital TB, it is also a secondary TB which spread via this hematogenous route. So most common site kya? It is the fallopian tube, and in fallopian tube maybe ampulla. Ampulla is the most common tube. So usually in the case of TB, we won't advise this investigation, which is this hysterosalpingography. Like in accidentally for infertility, we use this as one of the modality. So it is being done. So once this TB in which it is done, it will show this type of appearances. One is known as beaded appearance of this fallopian tube, and there will be this kind of appearance which is known as tobacco pouch. This kind of appearance which is known as tobacco pouch appearance. So there will be beaded appearance, there will be sperm head appearance, there will be tobacco pouch appearance, there will be other, for example, sometimes there can be a carnal block, but mainly these two, like beaded appearance and tobacco pouch, you should remembering of. And we know this is because of the TB, so we need to confirm it. We can either take their samples from during their menstrual bloods, or we can take some samples from the uterus. Okay, so we can do some endometrial biopsy, or we can do curettage and menstrual blood samplings. And finally, we will need to do IVF after clipping the both end of the tubes, and we need to provide ATT. Yeah, good, guys. Fine. And next, about this urinary fistula. If you see about this urinary fistula, the most common cause of urinary fistula in India, it is what it is, this obstruction of the labor. The most common cause of urinary fistula in India, it is this obstruction of this labor. Fine. And in a case of urinary fistula, if you see, there is a continuous dribbling. It won't stop. Okay, urine won't stop. There is a continuous leaking. Okay, it is like it will be like from tap how it will drops, right? Like this, there will be a continuous dribbling of the urine in a case of vesico-vaginal fistula. Whereas in a case of stress urinary continence, it will be under stress. For example, if you are laughing loud, or if you are taking any stress, or if you are taking any weight, okay, or if you are having recurrent coughs, and in those moments, the bladder, like this will be like a bladder, and this will be the neck, and this neck will become hypermobile. And because of this mobility, once you cough, this will mobile, and there is spillage of this urine. There will be spillage of this urine because of this increased intra-abdominal pressure. Okay, so it is known as stress urinary incontinence. There will be involuntary leakage of this urine will be there. Fine. It is mainly because of this bladder neck descent or urethral hypermobility. And for this diagnosis, we'll tell the patient, we'll keep this tip in her urethra, and we'll tell her to cough. And if this angle is less, that is normal. If the angle is more, we'll tell there is a bladder neck hypermobility, and this is because of this stress urinary incontinence, and we'll tell them to do exercises. Fine. The first line, it is what it is, pelvic floor exercises. If it is not controlled by this, then we'll do this definitive management, which is the surgery. This surgery we can go for abdominal approach or vaginal approach. If it is abdominal approach, we'll do breast Kolpo's suspension or Marshall-Marchevit-Katz methods. If not, we can do some of these sling surgeries to prevent this bladder neck hypermobility, and we can treat this. What? We can treat this stress urinary incontinence. This is the stress urinary incontinence. Fine. And next about this cervical cancer. So read about the staging of the cervical cancer. It is very much important, and its management, because that is the most common cause of post-menopausal bleeding in India. Okay. Then here also the patient will be having what? Bleeding, foul smelling discharge, and there what? And they will be having dyspareunia. Okay, dyspareunia. Okay, yeah. There will be a post-coital bleeding. Yeah, this bleeding is post-coital bleeding. After sexual intercourse, they will be having this bleeding. So these are the few features which will be seen in a case of CA cervix. In a case of CA cervix stage 1, it is limited to the cervix. 2A, it is this upper vagina. Okay, but it is less than 4 cm. 2B, it is the parametrial. It is the parametrial involved, but it is not involved yet involved this pelvic wall. Okay, in the stage 3A, it is this lower 1/3 of the vagina which is being involved, and 3B, remember it is a 3B, it is the most common stage, because when it involves this kidney or the ureter, it will cause this hydroureteronephrosis. It will cause this hydroureteronephrosis, and because of this hydroureteronephrosis, it will happen because of this parametrium involvement and this ureter involvement, and it is seen in a case of stage 3B, and it is the most common stage of presentation, and it is a late stage. Okay, itna yaad rakho. And C1, yeah, and C1, remember it is this lymph node. C1, it is the pelvic lymph node. C2, it is the para-aortic lymph node. C2, it is the para-aortic lymph node. Fine. And next 4A, it is the bladder and bowel involvement, and 4B, it is this distant metastasis, and 4B, it is the distant metastasis. Fine. And treatment, if you see for stage 1, mostly we do the conization, because it is just the cervix involvement, right? We do just conization or LEEP. Okay, we'll do. Then in a case of stage, in a case if the patient is not unable to follow up, then we can do hysterectomy. In the case of stage 1, 2 or 1B, 1, 2 or 1B, okay, there are like few differential stages. Then we can do radical hysterectomy or Wertham's hysterectomy. Whereas if there is after this stage 1B2 or 2A1, 2A2, we can do this Wertham's hysterectomy, and along with this, we need to start this intermittent radiotherapy and chemotherapy. Whereas in 2B, after 2B to 4A, 2B to 4A, we need to give this chemo radiation, and along with this brachytherapy. Okay, along with this brachytherapy. In chemotherapy, we'll give this cisplatin. Okay, 4B mostly will give this palliative care along with this chemotherapy and radiotherapy. Okay, so see, there are 2 points which we use for this radiotherapy in the case of cervix. Okay, there is point A and point B. There is this point A and point B. If you see about this point A, it is 2 cm above and 2 cm lateral. It is 2 cm above and 2 cm lateral to this external os. Whereas point B, it is what? It is this 2 cm above. It is 2 cm above, but it is 5 cm. It is more 3 cm distant or 5 cm lateral to the external os. Okay, so usually in the case of point A, will give around 7,000 to 8,000 Gray of radiations, whereas in point B, will give around 2,000 to 4,000 centigrade of radiations. Bas itna yaad rakhna tum. Okay. Then about this ovarian tumor. In ovarian tumor, mostly you need to diagnose it. Like they will give this clinical scenario. In this clinical scenario, you need to diagnose which of the following condition or which of the following type of ovarian tumor is this. Okay. If we see about this ovarian tumor, the staging of this ovarian tumor, it is mostly done on laparotomy. Like while doing surgery only, we'll do this staging. So it is known as surgical staging. Fine. And there are different types of ovarian tumor. That is epithelial ovarian tumors. Okay, like serous adenoma and mucinous carcinoma, and there are some germ cell tumors and sex cord stromal tumors. Fine. This epithelial ovarian tumors, they are the most common tumors. Okay, and usually they are bilateral in nature. And this example, this serous adenoma will be having this concentric bodies, which is known as pneumoma bodies. Okay, this is this serous cyst adenoma. It is a serous cyst adenoma. Fine. And next, if you see this mucinous cancer, it will be having this entire, or it will be having this huge amount of mucin, and it will be multiloculated, and it can result into a condition which is known as pseudomyxoma peritoneum. It can cause this pseudomyxoma peritoneum. Fine. And there is one more syndrome which is known as Brunner syndrome, and this Brunner syndrome, it is made up of this transitional cell, also known as 𝗲𝗏 inclusions. Okay, so the next of these transitional cells, they are known as 𝗲𝗏 cells. So remember, this Brunner cell, there will be increased level of estrogen. So Brunner cell, it will produce increased level of estrogen. Fine. And these are the few epithelial tumors you need to know: the serous cyst adenoma, the mucinous cancer, and the Brunner cell, which produces this estrogen. Next, about this germ cell tumor, the most common one, it is a teratoma. And we know in the case of teratoma, there will be presence of this like multiple lineage of tissues. For example, hair will be there, there will be a tooth will be there, there will be a fat will be there, and there is a protuberance will be there, which is known as 𝗏𝗏𝗏𝗏 protuberance. Okay, yeah, if that will come, yeah. So if you see in a case of germ cell tumor, it will be mostly in a case of young woman. It will be mostly seen in a case of young woman, and in teratoma, it will be derived from this endoderm, mesoderm, and ectoderm. So it will be having this 𝗏𝗏𝗏𝗏𝗏 protuberance. Once you remove it, you will be able to see this hair grows over there, and it is most commonly seen during pregnancy also, and it can undergo torsion, and it can produce pain. And about this yolk sac tumor, you just remember, it will be increasing, it will be having this increased alpha-fetoproteins. It will be having this increased alpha-fetoproteins, and here you will be able to see this Schiller dual bodies. Here you will be able to see this Schiller dual bodies. Fine. And next, about this germinoma, and it is this most common germ cell malignancy. It is the most common germ cell malignancy, whereas in males it is the counterpart of this seminoma. It is the counterpart of the seminoma. Fine. And about this sex cord ovarian tumor, okay, you need to remember about this granulosa cell tumor. And in granulosa cell tumor, you will be able to see this 𝗏𝗏𝗏𝗏 nuclei, and here it is also an estrogen producing. Okay, and it leads to this hyperplasia and carcinoma of this endometrium. So they will be asking which of the following ovarian tumor which can cause this estrogen production, and it can cause this endometrial hyperplasia. Your answer should be this granulosa cell tumor, and here you will be able to see these bodies which are known as 𝗏-Exner bodies. They will be having this nuclear grooving which is known as 𝗏-Exner bodies. Fine. And the marker you will use, it is the incumin, and here there will be arranged in a rosette formation. Fine. And if there is a presence of this ovarian fibroma along with this ascites and pleural effusion, so fibroma, ascites, and pleural effusion, it is known as mixed syndrome. So it is seen in a case of fibroma. Fine. And next, if there is virilization, breast atrophy, and along with this amenorrhea, it is seen in a case of Sertoli cell tumor. Okay, Sertoli leading cell tumor. Remember, it is seen in a case of virilization, breast atrophy, and amenorrhea. So all of this virilizing are this increased testosterone features. These are seen in a case of leading cell tumor. Fine. And the most common genital malignancy showing metastasis, it is what it is, this CA endometrium. CA endometrium can come here and as a metastasis. And even the stomach cancer, they can come into this ovary, and if it come into this ovary, then there is an ovarian enlargement. And if there is an ovarian enlargement here, it will be a symmetrical ovarian enlargement. That will be what? There will be a symmetrical ovarian enlargement. And this type of tumors which is coming from this gastric glands or this breast, they are known as Krukenberg tumors. They are known as what? They are known as Krukenberg tumors. Fine. And now you got this HSG image where you will be able to see this filling defects inside the uterus. And if there is, if there is any, good guys, it is the abdominal meds. Yeah, good Dr. Anar, good Dr. Bhagav. Fine. If there is any filling defects inside the uterus, then like you will ask the history. And history, there is a history of abortion, and she has undergone dilatation and curettage. And after which she is experiencing a feature of amenorrhea, which is this secondary amenorrhea. So what is the disease you will think of, guys? What is the disease you will think of? You will think of this. This is which is lead to the formation of adhesions into the uterus, which is known as what? Which is known as Asherman syndrome. Asherman syndrome. Okay, the female with secondary amenorrhea and previous history of DNC, it is suggestive of this syndrome, which is known as what? Asherman syndrome. Yeah, good Dr. Gautam, good Dr. Bhargav. Yeah, good. Okay, fine. And next, if you're able to see, yeah, good Dr. Anar, yeah, good Dr. Parul. So next, if you see this HSG image, you need to differentiate whether this is septate uterus or a bicarnivate uterus. See, if the septate uterus in HSG, if it is more than 4 centimeter, then it is a bicarnivate uterus. If it is less than 4 centimeter, but now it is what it is, this septate uterus. But now we started using this more advanced modalities like MRI and 3D ultrasonography, so that we can detect is like easily or more advanced. Fine, whether it is bicarnivate uterus or septate uterus. Remember, see this septate uterus, the septum is inside. So if our management of this septate uterus, we can go for this hysteroscopic lysis. Hysteroscopic lysis. Centimeter what? Yeah, it is, yeah, like see the interdistance, there is two things. One is the centimeter, like what is the distance, the centimeter, or this angle. So if the centimeter, if it is more than 4 centimeter and if the angle is more than 75 degrees, it is the bicarnivate uterus. If it is less than 4 centimeter and the angle is less than 75 degrees, it is the septate uterus. Okay, these are the both two things. Okay, the means between these two, what is the length? See, I'll show you back. Okay, you got it, I guess, right? So see, this is the angle and this is the length. Okay, this is the angle and this is the length. Fine. And if it is septate uterus, we'll go for hysteroscopic septal lysis or septal ablations. Whereas in a case of bicarnivate uterus, what we will do? We'll do in a case of bicarnivate uterus, what is the name of this metroplasty? We'll go for this Strassmann metroplasty. Remember, it is known as Strassmann metroplasty. Okay, the final, the one part of this means gynecology is going to complete. So endometrial carcinoma also you need to know the like mota staging. So if it is stage 1, there will be no myometrial involvement and there is no need of any treatment. Whereas if myometrium is half or 50% is being involved, okay, in such cases 1 to 2 vaginal irradiations, radiotherapy is being done. Whereas if it is more than half of it is involved, it is grade 3 and there will give this pelvic irradiations. Okay, and if it is stage 2, will give for whole abdominal irradiation, and in a case of stage 3 and 4, will go for this individualized chemotherapy and radiotherapy. Okay, so we'll remove this uterus, along with this will give both chemotherapy and radiotherapy. Will give for both chemotherapy and radiotherapy. So just mota yaad rakho, in the case of endometrial cancer, if it is stage 1, there are different stages. So initially, if it is no myometrial involvement, we don't need to treat. If it is less than one or half or 50% involvement, then we'll give for vaginal irradiation. If it is more than half, then it is pelvic irradiation. If it is stage 2, it is what it is, this whole abdominal irradiation. If it is stage 4 or later stages, what we'll do, we'll go for individualized chemotherapy. Okay, individualized chemotherapy and radiotherapy. But itna yaad rakhna, you need to, these are the things you need to remember from this gynecology part. Here we'll move on to this obstetrics part, and obstetrics part I guess we'll do it much faster than this. Okay, we'll finish up by usual time, within 30 minutes we'll finish it up. Okay, that is our motto. If you have any doubts, please put up in the chat box. Do you have any doubt, guys? I guess no. Okay, fine. Okay, Gautam. Okay, Dr. Gautam. Yeah, okay, Dr. Anna. Yeah. We'll move on to the next part. This obstetrics part, you need to know few things. For example, in physiological changes, we know the blood volume will be increasing and plasma also will increase. Yeah, because obstetrics, it is more of conceptual one, whereas gynecology, like half of the part, it is just memorizing and remembering things, whereas rest the staging and things. Okay, so it will be like that only. So every subject will be having this conceptual part and memorizing part, conceptual part and memorizing part. So you should be equal in both of them. Okay, you should try to be equal and in good norms with them. Fine. So here the RBC mass also will increase, and see here the mother hemoglobin will decrease because it will be given to the child. Fine. The question will be asked from this fibrinogen. See, all of this fibrinogen and clotting factor, it will be increased during pregnancy, except this classic clotting factor 11 and 13. Except clotting factor 11 and 13, all of this clotting factor will be increased. Fine. And albumin will be decreased here, and proteins will be increased. So this albumin to other proteins ratio will be maintained. Okay. So remember, Then about this cardiac output, mostly the cardiac output during the pregnancy, it will be increased and it will maximum around 30 to 32 weeks, fine. Whereas it will be increased more than this on the postpartum period. It will increase more than 70% of this in the postpartum period, remember. And in respiratory system, there will be no increase in the respiratory rate, whereas there is a reduction in this functional residual capacity and inspiratory capacity. So this is one of the important points. So if you want to remember two things, remember this and remember this. Okay. So reduction in this FRC and inspiratory capacity, whereas there is a increase in this TLC. Increase in the TLC. Okay. Total lung capacity. Fine. Then there are few important signs. This Chadwick sign. This is this bluish discoloration of the cervix and the vagina. It is known as Chadwick sign. And okay. So it will be around 6 to 8 weeks. And Osiander sign, remember it is the OC, it is the pulsatility. It is the pulsations which is felt around the cervix, the lateral wall. It is also around 8 weeks. And Goodell signs, it is the goody cervix or the soft cervix. It is the softening of cervix. It is also around 6 to 8 weeks. And Hegar's sign, okay, the isthmus will be softening here. Okay, then fetal movements will be felt by the woman. Woman around 16 to 18 weeks. Around 16 to 18 weeks, it is known as quickening. It is known as quickening. Okay, and in multigravida it will be around 16 to 18. In primary gravida it will be around 20 weeks. Fine. And they also able to feel this Hicks. Bottom Hicks means the baby kicks. Fine. Just remember. Because of this contractions. And about these types of pelvis, the most common one, this is this gynecoid pelvis. Whereas if you see this flat pelvis, it is known as platypod pelvis. So in pelvis where there is this type of pelvis, it is this platypod pelvis. Fine. And android pelvis, it is a triangle shaped pelvis. It is a triangle shaped pelvis. So most common one is the gynecoid pelvis and the least common one it is the platypod pelvis. And next if you see this only pelvis with AP diameter, with this AP diameter which is actually more than this transverse, it is what is this anthropoid pelvis. And because of this will be going under arrest. It will be going under this type of delivery which is known as phase 2 pubis delivery. Phase 2 pubis delivery because of this persistent of posterior occipital position. Persistent of occipito-posterior position is seen in a case of anthropoid pelvis. So easily there will be a delivery of phase 2 pubis deliveries. Yeah, phase 2 pubis deliveries. Fine. And next, this thing which is known as deep transverse arrest. So in a case of android, it will go for hanging, right? So remember, hang. It will hang. Okay. So the phone will be hanging. So this DTA, this deep transverse arrest will be seen in a case of android pelvis. Fine. And platypod pelvis will result in this posterior acinctulum. Fine. And there are two types of pelvis. Nuggles pelvis. If one wing of the sacrum, if absent, it is known as Nuggles pelvis. If both of these wings, if both the wings of this sacrum, if both of them they are absent, it is known as Robert's pelvis. It is known as Robert's pelvis. Remember. Then you need to know about this just number of these conjugates. This true conjugate, obstetrics conjugate, and diagonal conjugate. So once you put a hand from the pubis tympicus to this sacral promontory, you will able to measure this true conjugate. And from this, if you minus it, it is this obstetrics conjugate, and if you add it, it is this diagonal conjugate. So just remember. Okay. This conjugates are being used to know whether the pelvis is adequate for delivery or not. Whether the pelvis is adequate for the delivery or not. Fine. And we'll move on to this type of abortion. We'll call them abortions. Means if the delivery of the baby if the delivery of the baby happens, then the baby should be live outside. Then we'll call them as death. But if non-viable fetus is being born, we'll call them as abortions. Fine. So mostly, DC -1. Yeah, that's correct. Mostly the spontaneous abortion. The spontaneous abortion, what we'll do? Means it is unexplained. It will happen by its own. Okay. And most common cause of this spontaneous abortion scare, it is this chromosomal abnormalities. It is this chromosomal abnormalities. And there are different types of abortions. Recurrent abortions means it is defined as 3 or more consecutive spontaneous abortions before 20 weeks. We'll call them as recurrent abortions. And there are few more type of abortions like threatened abortion, inevitable abortions, complete, incomplete, and missed. So there are few delineating factors. Threatened means it will threaten you. Means like it will threaten you. I will be abort. But nothing will happen. How will you threaten? Like they will threaten with small spotting of bloods. So if you just see the os of the cervical os will be closed. Okay, there will be slight bleeding, but there will be the uterus will be of normal size and the os will be closed. Whereas in a case of inevitable abortions, okay, there will be a bleeding, but the hose will be open. So if because of the hose will be open, we cannot make them close. So it will be obviously it will come, it inevitably it will abort. So that is this inevitable abortion. Okay. Right. Next, about complete abortion, there will be the history of passage of this means clot, small clots, or this fecal means fetal parts will be passed. Okay, and the uterus size will be less than this gestational age. Okay. Yeah, dar ki wajah se darwaza band. Yeah. Then that's also nice, Dr. Abhijit. Fine. Here the cervical internal hose is also closed. While in a case of incomplete abortions, here also passage of some fleshy material. Whereas while doing ultrasound, there will be a presence of this materials, and even the cervical hose will be open. In complete abortion, it will be closed. Whereas in a case of incomplete, the hose will be open because there is more content inside. They should come out, right? They should come out. Then about missed abortion, it is the dead or retained fetus in the uterus. That is the dead or this dead fetus inside the uterus. Fine. And usually this missed abortion, it won't be having this features of bleeding, it will be having the features of delivery, like there will be this regression of this breast changes, and there will be no morning sickness or no morning vomiting. Okay, and the uterus also will become small because it's not growing, right? So it should grow based on the gestational age. Since it is not growing, so it will be usually less than the gestational age. Okay, here also the hose will be closed. Okay. Then about this act, which is the MTP Act 2021. This MTP Act 2021 tells if to do an abortion till 20 weeks, okay, you need a permission from one RMP. To do an abortion from 20 to 24 weeks, you need a permission from 2 RMPs, fine. And then you can do this delivery or do this abortion in a case of rape, in a case of contraceptive failures up to 20 weeks. So in a case of contraceptive failures, it can be done up to 20 weeks. Whereas in a case of rape, it can be done up to 24 weeks. So in a case of rape, it can be up to 24 weeks. Whereas in a case of contraceptives, it is still 20 weeks. Fine. And even after 24 weeks, this can be done if there is any fetal abnormalities are present, or if there is any problem for this mother, or if there is any death threats to this mother, then in such cases, these abortions can be performed. ठीक है, आपको याद रखना. So mostly they will play with this rape and this contraceptives. So contraceptives we can do till 20th week, whereas for rape we can do till 24th week. Okay, इतना याद रखो. And for this MTP हमें किसका consent चाहिए? Yeah guys, we need the consent of woman, or only woman, or woman's guardian, or husband, or both husband and wife. Whose consent we need, guys? We need the consent of, yeah, good Dr. Abhijit, good Dr. Anar, good doctor, yeah, good. It is what it is, the woman only. So we need consent from only woman. Yeah, good Dr. Gautam, good Dr. Sadaf, only girl consent. The woman consent only which needed, yeah. If mentally challenged, yeah. If the female is mentally challenged, then we need the consent from the parents. Fine, consent from the parents. Good guys. Fine. Only woman or only girl, only wife. Fine. Next, about this ectopic pregnancies. And about this ectopic pregnancy, if we see, there are different types of ectopic pregnancy. There can be ruptured ectopic pregnancy. Because this ruptured ectopic pregnancy, the patient will be presenting with features of pain and hypotension, because bleeding is going on, right? Hypotension. So in such cases, we need to go for immediate laparotomy with selfingectomy, and along with this hypotension, we need to resuscitate the patient. Fine. Whereas in a case of unruptured ectopic pregnancy, we need to measure the beta HCG levels. If the beta HCG levels are less than 1,000, and if the ectopic mass is less than 3.5 centimeter, then we can go for this expectant management. Expectant management is yesterday it's 1,000, or yesterday it is 1,500, today it is less than 1,000, tomorrow it is 800, means it is gradually decreasing. Then we can go for this expectant management. Whereas this medical management done in a case where the heart activity is absent and the mass is less than 4 centimeter and the HCG level is 5,000. It is less than 5,000. So in such cases, we go for this medical management. Yeah, good Dr. Anar will use methotrexate. We'll use methotrexate for this ectopic pregnancy as a medical management. Okay, for medical management, we'll use this methotrexate. Fine. Next, for surgical management, if there is presence of this heart, if there is presence of heart activity, and if it is more than 5,000, if it is more than 5,000, and if it is diameter is more than 4 centimeter, or it is not in compliance, or it cannot be terminated with the medical methods. In such cases, we'll go for the surgical management. So we'll try to save the fallopian tube, usually by salpingotomy, but in unfortunate situations, we'll go with salpingectomy. Okay, we'll go with salpingotomy, or else we go for salpingectomy. Fine. Yeah, correct, guys. Fine. Next, about this hypertension management in pregnancy. You know, in a case of pregnancy, if there is hypertension from previously, it is known as chronic hypertension. Whereas if hypertension happens after this 20 weeks or more than 140/90 of blood pressure after 20 weeks, we'll call them as pregnancy induced hypertension. And if any associated symptoms, if there is any proteinuria associated with this pregnancy induced hypertension, we'll call them as preeclampsia. And if there is any seizure associated with this preeclamptic findings, it is known as eclampsia. So this is the three delineating features. Yeah, good Dr. Annar and good Dr. Bhargavi. Okay, yeah, Bhargavi. So if you see the drug of choice for this hypertensive management in pregnancy, it is the labetalol, and it is the drugs which are being contraindicated include ACE inhibitors, beta blockers, and furosemide. All of them, it will cause intrauterine growth retardation. So based on it, for example, if it is pregnancy induced hypertension, we can give alpha-methyl-dopa, or mostly we can use labetalol. Okay, whereas if it go to this preeclampsia, then also we can give IV labetalol. Whereas if it is going to eclamptic seizures, then we can go for this magnesium sulfate. If it is impending preeclampsia or impending eclampsia, then we'll go for this one, which is this magnesium sulfate. Okay, so treatment of eclampsia, it is the magnesium sulfate, which is given in this Picard's regime. So dosage 14 grams, loading this 4 grams IV देंगे और 10 grams in each buttocks. 10 grams in 10 grams को 5 grams में each buttock में देंगे. ठीक है, remember. Then delivery means like, so one of the main reason for this pregnancy induced hypertension kya hai? It is because of this second, means failure of invasion of this secondary villus. Okay, secondary villus ka invasion ki wajah se ye hota hai. So because of this fetus, there is this thing is happening. Okay, so because of this fetus, this thing is happening. So if you remove the fetus, then everything will be resolved. So see, so the definitive management kya? It is the delivery. Okay, it is the delivery, it is the definitive management. So what we need to do, it is what it is the, initially we need to continue with this magnesium management, and we know once we give this magnesium sulfate in a case of eclampsia or if any seizures occurs, then uske baad hame kya karna? We need to monitor for this magnesium toxicity. And what are the, how we'll monitor? We'll monitor with this patellar reflex. Patellar reflex is the first thing to be lost in a case of magnesium sulfate toxicity. फिर उसके बाद हम उनका respiratory rate देखेंगे, क्योंकि there will be respiratory depression will be there, then the urine output, because magnesium will be excreted through the urine. So तीनों चीज देखेंगे, the patellar reflex along with the respiration and the urinary output. ठीक है, so remember. So in a case of BP control के लिए हम क्या करेंगे? IV labetalol. So if it is mild, then there will move on to few scenarios. If there is mild preeclampsia patients managed with fetal monitoring, and hypertensives like labetalol can be given, and if it is mild, we can go up to 37 weeks. Fine. If it is severe, like more than 160 BP, 3+ proteinuria and signs of end-organ damage, okay, then we need to give magnesium sulfate because they can have seizures, and second, we need to control the hypertension. At the moment, we'll give this labetalol, and definitive management क्या है? सब में बच्चे को बाहर निकालना, ठीक है? To terminate the baby, if it is more than 34 weeks, we'll give steroids and we'll terminate it. Fine. In case of eclampsia, where convulsions have been already occurred, our main role is to give magnesium sulfate, फिर उसको जल्दी से जल्दी उसको निकालना, ठीक है? So it is one of the indications for the cesarean section. Okay. In patients of this type, there will be a features which leading to this hemolysis, elevated liver enzymes and low platelets. So hemolysis, elevated liver enzymes and low platelets. All of them they will lead to this syndrome, which is known as HELP syndrome. So in such cases, we need to terminate the pregnancy, which is around means if it is more than 34 weeks, then we need to give steroids. Yeah, as told, will in India mostly will prefer dexamethasone, or else we can also give betamethasone. Okay, dexamethasone 6 doses, 6 mg for 4 doses with the variation. Fine. Whereas betamethasone will give 12 mg 4 doses. Okay, 24 hours apart. Whereas this is 6 mg 4 doses 12 hours apart. Okay, this is the dexa. Then about this, top in all this case, vaginal or CS, is that important? Yeah, no, like in a case of most of this pregnancy, what we'll do, like if you see about this pregnancy, in a case of hypertension, हमें जल्दी से जल्दी बच्चा बाहर निकालना है. So mostly what we'll do, we'll go for this cesarean section if there is any convulsions are taking place. But if it is manageable, then we'll go for usual normal vaginal delivery. Fine. If it is being controllable, fine. If not, we'll go for this cesarean section. Okay, based on that. Okay. So one of the main indication, as I told you, right, if there is eclamptic seizures happening, the female is taking seizures, then it is one of the indication for cesarean section. Whereas if there is any no fetal distress, just hypertension, then we can manage the hypertension, we go for labor. So this is the delineation point. If eclampsia, like if you want to remember one thing, remember if there is eclamptic seizures going on, then we need to do cesarean section. If not, we need to go for usually normal labor delivery by controlling this hypertension. Okay? Yeah, that is the thing. Then about diabetes management in pregnancy, usually we can initially start with this diet chart or diet management. Okay, then followed by which mostly we'll use oral, means we'll use insulin. If you want to use oral hypoglycemic drugs, the metformin is preferred. Okay, this is simple definition. If you see, and we screen all the pregnant females in their first antenatal visit itself. Okay, and if it is normal, then we'll repeat around 24 to 28 weeks. Okay, so it is one step screening. We'll give 75 grams of glucose. We'll take the fasting level, 1 hour level, and 2 hours level. Okay, fine. And if the fasting level is more than 126, or if the fasting level is more than 126, we'll call them as over diabetes. Whereas if the fasting level is more than 92, 1 hour level is if this more than 180, or if the 2 hour level is more than 153. It is like just around this twice, like 90 into 90, it is 180. So you just remember first two, it is 92, 180 after 1 hour and 153 after 2 hours. This is the diagnosis for this gestational diabetes mellitus. Whereas if it is more than 126, if the fasting itself, then we'll consider it is a over diabetes mellitus. And remember one thing, none of these congenital anomalies will happen in a case of gestational diabetes mellitus. All of them will be happen in a case of over diabetes mellitus. Okay? And what are the complications can happen? This include hypoglycemia and hypocalcemia. So they will ask you, yeah, mother is delivered a baby, a diabetes mellitus mother has delivered a baby, and what are the following electrochemical abnormalities you will check? You will check for hypocalcemia, you will check for hypocalcemia, fine. And next you will check for hypomagnesemia, and there will be polycythemia, and hyperbilirubinemia will be there, and mainly there will be maxillomasomia. And if it is a case of over diabetes mellitus, then it will lead to this abnormalities like transposition of great arteries, which is more specific a heart anomaly, whereas overall most specific it is the sacral agenesis. It is the sacral agenesis. Itna yaad rakhna. Next about this management part, like as I told you, we need to restrict their calories. Usually हम 30 calories per kg देते हैं, लेकिन diabetes के लिए 24, and we can restrict up to 20 kilocalories per kg per day दे सकते हैं. ठीक है? And the drug of choice is insulin. अगर आपने oral hypoglycemic agents देना है, तो we can give either gleburide or metformin. ठीक है? और fundus examination करेंगे if there is a presence of any retinopathic features or any features of proliferative retinopathy. ठीक है? And timing of delivery. If you see gestational diabetes mellitus, अगर उन्होंने बस डाइट पे कंटिन्यू किया तो 39 वीक तक हम ले जा सकते हैं. अगर if it is gestational diabetes mellitus, if it is controlled on medication, then we can continue till 38 to 39 weeks. Means around 30, after 37 weeks will deliver around 38 weeks. If it is over diabetes mellitus, continued on insulin. Insulin मतलब more than 37 weeks हम delivery करेंगे. And if it is over diabetes mellitus, if it is not controlled, फिर around 34 weeks हम क्या करेंगे, steroids देंगे तो बच्चे को बाहर निकालेंगे. ठीक है, steroids देके निकालेंगे, बस इतना याद रखो. Then about this management, which is this postpartum hemorrhage. You know, postpartum hemorrhage, if it is more than 500 ml in a case of cesarean section, and if it is more than 500 ml in a case of vaginal delivery, or if it is more than 1 liter in a case of cesarean section, we'll call them as postpartum hemorrhage. And in postpartum hemorrhage, usually there will be a decrease in hematocrit by 10% or 1% decrease in their hemoglobin level. Okay, 1% decrease in their hemoglobin level. And one of the most common cause of death in pregnancy death in India, it is what it is, this 𝗶𝗶H, which is the maternal mortality in India, it is 𝗶𝗶H. Okay, and there are different causes for it. We know this tissue tonicity, and there will be trauma, and there is this clotting factors. So all of them, they can lead to this 𝗶𝗶H. So most common cause it is the tonicity. That's why we give oxytocin to induce this tonicity. इतना याद रखना, ठीक है? So then if 𝗶𝗶H occurs, how will you manage? First, to improve the tonicity, we'll give oxytocin, followed by this to improve it, we'll give carbitocin. तो उसके साथ साथ उसी टाइम हम क्या करेंगे, ट्रानक्सामिक एसिड भी देंगे, ठीक है? Then we'll give this methylergotamine. लेकिन there are few contraindications. For example, this carbitocin, it is contraindicated in the case of bronchial asthma. Okay, because it causes bronchoconstriction. This methylergotamine will be contraindicated in the case of hypertension and any cardiac condition. So methylergometrin will be contraindicated in the case of any of these cardiac conditions or any of these heart diseases, and along with this RH negative pregnancy. Kyunki this methylergometrin, it won't produce this symmetrical contraction, it will produce this vigorous contraction. So because of this vigorous contractions, this RH negative pregnancy, it may alleviate the RH negative pregnancy, and it may damage this heart again. Okay, and heart cannot pump this much fast, right? And next, about this misoprostol also can be given. Okay, either in per rectal we can keep it, fine. And carboprost, which is the go-to drug. If nothing works, then we can use this carboprost. Remember. Then if none of them works, what we can do is that we can use some of these tamponade methods. Like this is known as Becquerel balloon, where we can give compression with 500 ml. Okay, which can use as a pressure stem. Yeah. No, like that I will tell you. Like in a case of actives, that I will tell you, Shadaf. Okay, see, just wait. And if you see, and next, first we'll give this Becquerel balloon. Along with this, we can use other methods like condom catheter, or we can do this specific uterine artery embolization if they don't want to preserve fertility. So all of these methods initially we can do. So if none of them works, then we can go take them into laparoscopy, take them into this OT, and we can do this suture, which is known as B-Lynch suture. Okay, this type of B-Lynch suture, or else we can do this Heyman suture or this box suture. Okay, then followed by this, if you see, if the patient is stable, then we can go for this uterine artery devascularization. Okay, so we'll give this pressure compression. If nothing works, then if availability of this artery embolization, will go for it. If not, we'll go for this OT, and we'll go for this Heyman suture and B-Lynch suture. If nothing works, we go for this uterine artery devascularization, or OB काम नहीं किया, because if this bleeding from this ovarian artery parts, then we'll go for this hysterectomy. Fine. The final one, it is what? It is the hysterectomy. Okay. And next, one of the antepartum hemorrhage, it is what? It is this abruptio placenta. In a case of abruptio placenta, it is the blood from the female part. It is the blood from the female side. So if you see this abruptio placenta, the female will be having this tense abdomen. The female will be having this tense, tender abdomen. If you touch it, will be painful, and she will tell she is unable to feel the fetal movements. Okay, and tense, tender abdomen, unable to feel the fetal movements. And there will be two methods. Two types. One is known as concealed type of abruptio placenta, and another one is known as revealed type of abruptio placenta. See, this concealed means it is occurring behind this placenta. So it is known as concealed. Whereas revealed means it is occurring on the side, so that the blood clot is visible as bleeding. So here there will be a thing which is known as pallor, which is out of proportions to the bleeding. So there is a pallor in the female, but it is not proportion to the bleeding. The bleeding is less, but the pallor is more. Okay, there is a pallor which is usually out of proportion. Okay, and there is abdominal pain, bleeding perivaginum, abdominal pain and bleeding PV, okay, and there is this loss of fetal movements, fine, and the uterus will be tense and tender. And sometimes this blood may go and enter, this concealed varieties can go and enter into the myometrium and to produce this type of uterus, which is known as what? Which is known as 𝗃𝗃𝗃 uterus. It is known as 𝗃𝗃𝗃 uterus. Okay, it is known as 𝗃𝗃𝗃 uterus. So in the case of abruption placenta, the main management it is what? It is what? It is the delivery. Mostly we deliver by normal vaginal delivery. Okay, we'll do this artificial rupture of membrane and we'll give this oxytocin drip and we'll do vaginal delivery here. Okay, okay, just remember. And if the baby is under stress or if the baby is very much immature, then we'll give this steroids for this lung maturity and we'll try to do by mostly we'll try to deliver by this normal vaginal delivery. Okay, and sometimes it may lead to the causage of disseminated intravascular coagulation. Okay, if the baby is dead also, then we go for this normal vaginal delivery only. So in very unfortunate situations where the baby is under very stress or very fetal distress, then only we'll go for cesarean section. Whereas rest in most of the cases in abruptio placenta, we'll go for normal vaginal delivery, fine, with ARM. And next about this placenta previa. Usually the placenta will be upper and posterior in location, whereas if instead of this, if it is located near this os, we'll call them as low-lying placenta. Okay, or placenta previa. So initially it will be low-lying placenta. If it is touching the margin, we'll call them as marginal placenta. If it is coming half of it, we'll call them as partial placenta previa. And if it is completely obstructing the os, it is known as complete placenta previa. Okay, so itna aapko yaad rakhna. Then there is a sign which you see, if you press or compress the baby, then it will go and compress this umbilical cord and it will cause what? It will cause decrease in the heart rate. So this is known as what? This is known as stall for this side. It is known as stall for this side, fine, okay. And in a case of this placenta previa, see this placenta is lying on the internal os. The placenta is lying on the internal os. So if you do this perivaginal examination, you will go and hit and it will cause bleeding. So in such scenarios, mostly what you will do, you will do cesarean section as a part of management. In case of very low-lying placenta, you can try. Whereas in the case of partial placenta and complete, you will try for the cesarean section. Okay, cesarean section, even if the baby is dead. Okay, you can try one method in the case of this type of marginal, where you can have this OT setup and you can go for this gentle PV examination. If bleeds, then you can just cut open and you remove the baby. Okay, and what are the indications of this management, which is known as expectant management? It is known as, yeah, usually we won't do PV in the case of placenta previa. Good Dr. Atosho. Okay, it is known as McAfee and Johnson's regime. It is known as McAfee and Johnson's regime. So what are the indications? There should not be active bleeding. It should be, the patient should be hemodynamically stable and the gestation age should be less than 37 weeks because for this maturity part, and CTG should be reactive and no fetal anomaly should be seen on the ultrasound. Fine. Next about the stages of the labor, we know the initial first stage of labor, it is divided into two parts, the latent one and the active phase. In latent phase, okay, latent phase, it is what it is, this pain up to 3 centimeter dilatation, and from 3 centimeter to this complete dilatation, for what it will call them as active phase. We know this latent phase, it can go up to 20 hours in primary gravida or 40 hours in multigravida. So if it is more than 20 hours, then only we'll call them as prolonged first stage of labor or prolonged latent phase of this labor. And if it is more than 14 hours, we'll call them as prolonged latent stage of labor in multigravida. Fine. Whereas in the case of active phase, it will be sudden in nature. And second stage, if you see, it will be in primi, it will take 1 hour, whereas in multigravida, it is just 30 minutes. It is just full dilatation followed by coming out of the head, okay, coming out of the baby, okay. Then about this third stage, it is the expulsion of the placenta, okay. It will take around approximately 15 minutes, and if it is more than 15 to 30 minutes, then we'll consider that is a retained placenta, okay, fine. And fourth stage, it is the stage of observation. Fourth stage, it is the stage of observation, fine. And this is here we take this active management of this third stage of labor. In the case of active management of this third stage of labor, what we'll do administer the oxytocin. Like once this placenta is delivered, once this baby is delivered, then we'll give oxytocin. Okay, we'll give oxytocin after immediate delivery, and after that we deliver this placenta by one hand you will put into this uterus, and with another hand you will with the corkscrew motion you will gently drag this placenta. Okay, with this corkscrew motion, it is known as gentle traction, and followed by this, what you will do, you will do delayed cord clamping. Until unless there is an indication, you will do delayed cord clamping. And as per the WHO protocol, the uterine massage, to increase the tonicity, uterine massage is not mentioned. Okay, but it can be advised, but uterine massage is not mentioned. But okay, it is uterine massage. Remember, it is not fundal massage, it is the uterine massage which can be done to prevent this tonicity. But usually it is not done as per the WHO protocol. Fine, remember. And what are the methods of this breech extraction? So in the case of breech delivery, you know the sacral will come first. So to remove this head, we'll use this maneuver which is known as 𝗏𝗏𝗄𝗠𝑆𝑚iley maneuver. So in this case, remember, we smile with this maxilla. So it is known as 𝗏𝗏𝗄𝗠𝑆𝑚iley maneuver. Fine. And next, to deliver this head, we can deliver in arc fashion. Like you keep a hand like this and you will deliver like an arc. So in a case of arc fashionly, if you deliver this child, okay, it is known as what? It is known as Marshall's technique. Marshall's technique. Okay, yeah. Then if you are able to see, if you rotate the child, to remove this shoulder button to come, it is known as what? It is known as 𝗏𝗏𝗀𝗏𝗏 maneuver. Okay, and you went in and तुम पीछे से गए हो और इनका पोप्लिटल फोसा में उंगली रख के इनका पैर को निकाला, तो पीछे से पोप्लिटल फोसा से देन पैर को. So all of this PP1 will be seen in a case of Pinard's maneuver. Pinard's maneuver. So it is the Pinard's maneuver. Yeah, good, Dr. Anna. Then this is the episiotomy. So remember, in the case of episiotomy, there are two types of episiotomy. This is midline episiotomy and this is the mediolateral episiotomy. So we perform mediolateral episiotomy. Yeah, mediolateral episiotomy. And remember, episiotomy, it is not mandatory, it is optional. It is optional. Okay, it is optional. Okay, it can be done, it is not always recommended. Okay, remember. And then there can be degree of perineal tears. For example, during the delivery, you need to give support to the perineal body. But if you didn't give support, then it leads to the formation of this perineal tear. This perineal tear, if it just vaginal mucosa is getting eroded, if just vaginal mucosa is getting eroded, then it is the first degree. If along with this vaginal mucosa, there's the muscles of this perineal body is getting involved, it is the second degree. If along with this vaginal mucosa, along with these muscles, if the sphincter is involved, okay, if the sphincter, anal sphincter is involved, it is the third degree. If along with this muscles, mucosa, vaginal mucosa, and along with this sphincter and along with this rectal mucosa is involved, it is the fourth degree. It is the fourth degree. And whatever, yeah, and whatever is this perineal tears, it should be repaired immediately. It should be repaired immediately. But if the patient comes after 48 hours, we'll tell them to wait for 3 months. Okay, then we'll repair it. We won't repair immediately. We'll tell them to go for this secondary healing. Fine. And there are few normal puerperal changes. If you see about this normal puerperal changes, this lochia will be the secretions, lochia rubra, serosa and alba. Lochia rubra, serosa and alba. Fine. And usually the pulse will be increases because there will be increased blood supply, because previously the baby is also receiving blood supply. Now the entire blood is circulating into the mother, so there will be increase in heart rate initially, and there will be loss of weight because of this diuresis, and then the blood volume will start to decrease. Then the fibrinogen and ESR remains high. Okay, cardiac output, as I told you, it will increase more than 60 to 70%. Okay, 60 to 70% more than the pre-labor value. Then in urinary tract, there might be retention of urine and there might be a constipation in the GIT tract. Okay, fine. And they will ask you, after 2 days, how much distance the uterus will be. After 2 days, like every day it will reduce by 1.25 centimeter per day. So after 2 days, it will be around 2 centimeter. It will be 2 fingers from the umbilicus. Okay, itna yaad rakhna. Okay, and it will become a pelvic organ by 2 weeks. And it will become a pelvic organ by 2 weeks. Okay, and we'll move on to this few instruments. This is this iris spatula, and this is this cyto brush. Iris spatula, it is for this ectocervix, it is for this ectocervix. Whereas this cyto brush, it is for this endocervix. Yeah, a good, Dr. Anna. Whereas this one, this is this cytobroom. With cytobroom, we can scrap both ecto and endocervix. Ecto and endocervix. Yeah. Fine. And this is known as, it is known as visual inspection under acetic acid. Visual inspection under acetic acid for this CA cervix. Fine. And next we'll use this 3 swab test for vesicovaginal fistula. See, in the case of vesicovaginal fistula, we need to check from where there is a leakage. So we'll put 3 swabs, 1, 2, 3 swabs. Okay, and we'll instill some dyes. And when we instill this dye, we'll see, like if there is from this ureter direct connection, then it will it will come, the urine color will come. But if it is from the bladder, and if it is coming on the first, it is what it is, this vesicovaginal fistula, and if it is below, it is this urethrovaginal fistula. So it is different types will follow. Then this is what, yeah, good, we'll put this methylene blue dye, yeah, good guys. Then this is this menstrual regulation syringe, okay, and this is the manual vacuum aspiration, and for this we'll use this cannula which is known as Carman's cannula, fine. We'll use this Carman's cannula, fine. We'll move on to the next part. These are the few instruments you need to know. This is this episiotomy scissor, and this is the Hegas dilator which we use during this incompetent cervix to see whether the cervix is dilated or not. And this is the ovum cervix, ovum holding forceps. Yeah. This is the ovum holding forceps. This ovum holding forceps we use to remove this debris during the DNC. Okay, during DNC. Okay, and it will be without lock. It will be without the lock. Okay, and this is the uterine curette. It is the uterine curette, and this is this Casco's self-retaining speculum. And finally, this is this Valsalem forceps. This is the Valsalem forceps, and there are few more forceps. If you see this kind of knob, it is this Killian forceps, and if you see this type of perineal curve, it is this outlet forceps, fine. And this is the Sims forceps, and this is N-shaped one, it is the Doyne's retract. Okay, retract. We'll see this, we'll see this contraceptives, and we'll see few extra aids, and that's it for the day. Okay, so about this emergency contraception, okay, we'll be having this combined OCPs, either two methods, 𝗶𝗶𝗶𝗀 method and 𝗬𝗬𝗀 methods, which will be used less than 72 hours, and we'll use this pill which is known as I pill, which is this LNG having 1.5 milligram. Okay, it is this emergency pill also known as I pill. Okay, this is the progesterone. If we can use just progesterone only pill, it is for less than 72 hours, and IUDs like intrauterine device we can use till 5 days. And mifepristone also we can use, which is this less than 72 hours. And actually this progesterone, so that's what, there is a few differentiating factor will be there. Like you see them, like most of them you just rewind and see once more. Most of them I'll told you some mnemonic. For example, curette, it looks like your tongue cleaner, whereas the ovum forceps it will be without the lock and it will be having this scoop, fine. Whereas this Valsalem it will be having this tooth. Okay, this Casco's, it is a self-retaining, means if you just click on this, screw it up, it will be self-retaining. So one will be having their peculiar features. So you try to see once more time, you will get it, fine. And mifepristone we can use it, and next high dose estrogen also we can use it. So but most commonly used it is this LNG pill, which is this 1.5 mg. Okay, yeah. The Sims forceps what we'll use means you need to wet rack. For example, you need to examine the vaginal wall. So then what you need to do, there are two Sims forceps. There is anterior vaginal wall and posterior vaginal wall. So what you will do, it will be like this. Okay, it will be like this. So what you do, you hold and you will retract the vaginal wall. Okay, that is how the use of Sims. Okay, fine. Then about this few irreversible contraceptions, if you remove this fimbriectomy, it is known as corners fimrectomy. Okay, and if you remove the tube, okay, and you bury this mesosalpinx into the serosal layer, it is known as Uchida-'s method. Uchida-'s method, you will bury inside, you will bury them. Then if you cut like this, it is known as what? It is known as modified Pomeroy's technique. Modified Pomeroy's technique, right? And there are few more contraceptives. If you see, this is the male condom, which is marketed as Nirodh, and this is the female condom, which is having this 1 and 2 rings. This is the 1 and 2 rings, fine. It is this female condom. And using of this, with this use of the cervical mucus, if you are assessing this fertility period, it is known as Billings method. Okay, and this is the diaphragm, and this is the diaphragm, fine. And there is good Dr. Gautam, good Dr. Anna. And there are two malas, mala N and mala D. Mala N is for free and mala D for $. It is around 3 rupees per packet, and both of them will be having this ethinyl estradiol of 30 30 mcg and leave an azistral of 150 micrograms. Fine, 150 micrograms, out of which 21 will be having this combination of this hormones, whereas the last 7 will be having this iron tablets, because for this withdrawal bleedings. Fine, withdrawal bleedings. Yeah. Next about this, which is known as what? Anthera. In the case of Anthera, it is the DMPA, dipomedroxyprogesterone acetate. It is an injection formulation, okay, and it is in injectable form, and it is given once every 3 months, okay, once every 3 months of 150 milligram. Fine. And about this, there is this 𝗏𝗏 tablets, which is the what? Which is a non-steroidal tablets, non-steroidal one, okay, and it is marketed as 𝗧𝗏, and previously it is known as 𝗧𝗵𝗶𝗀. 𝗧𝗏 is actually what? Which is this ormeloxifene, and it is a selective estrogen receptor modulator, and it is a non-hormonal pill. It is a non-hormonal pill, okay, remember. And it is also once a week pill, whereas for first 3 weeks it is twice a week, okay. After that it will become once a week, okay, twice a week for first few weeks. And next, this is this Lippel's loop, and if presence of copper in the arm, it is 380A, and it will be for 10 years, whereas it is what? It is this multi-load, yeah, a good doctor Bhagov, good doctor, yeah, Anar, yeah, it is multi-load 375, it is for 5 years. And next one, this is the Mirena, which is this LNG secreting one, okay, and it is also for 5 years, remember, it is the Mirena. Yeah, good guys, good Bhagov. Fine, these are few extra GVs you should know. This chorionic villi sampling, it is done around 10 to 13 weeks, okay, and we'll aspirate this chorionic villi, and amniocentesis we do after more than 16 weeks, whereas chordocentesis we'll do after 16 weeks. So 16 to 18 weeks we'll do amniocentesis, 10 to 14 weeks we'll do chorionic villi sampling, whereas more than 18 weeks we'll do chordocentesis. Fine. And shoulder dystocia, last time they asked, this time they may ask. First, for shoulder dystocia, what he will do? He will bring the female to the table, and he will make her hip to flex, okay, he will make her hip to flex, okay, like this. So it is known as Mac-Roberts maneuver. First he will do Mac-Roberts maneuver, followed by this, what he will do? He will give suprapubic pressure. This is the pubic symphysis, he will give pressure here, so it is known as suprapubic pressure, okay. Then after giving this suprapubic pressure, okay, suprapubic pressure, okay, he will also again he will press the leg, so it is known as Rubin's two maneuver. So first he will bring the female to the end or the corner of the table, then he will flex her hips, so give the mobility so that the head can come out, okay. Shoulder dislocation means like after delivering the head, the shoulder should come within 30 seconds to 1 minute. So if it is taking more time, it is what? It is known as shoulder dystocia, okay. So for that, first you need to bring the female to this corner of the table. Once you bring the female to this corner of the table, then you flex the hip, okay, flex the hip, then you will give the more space. Then what you will do? You will give the suprapubic pressure along with this pressing, okay. And after that, what you can do more is that you can do one more maneuver, like where if nothing helps, for example, you brought them and if you still giving pressure, the baby is not coming out, then what you can do is that you can do this 𝗏𝗏𝗀 maneuver, so that you can correct and you can bring this shoulder to the outside. So if nothing, if then works, you can make her like a dog. So it is what it is known as to roll on a 4 limbs. It is known as Gaskin's maneuver. And finally, if nothing helps, then you can restitute the head and you can push inside, which is known as Zan-Wellis maneuver. And you push the head in and you do cesarean section. You push the head in and you do cesarean section, okay. Just remember, first it is the Mac-Roberts maneuver, and followed by this you do this Gaskin's maneuver, Mac-Roberts maneuver, then suprapubic pressure, followed by this you do this 4 limbs, which is this Gaskin maneuvers, and followed by which you do this Zan-Wellis maneuver. You do this Zan-Wellis maneuver. So remember, okay, these are the maneuver which we do for this shoulder dystocia, okay, fine. And next, if you see, this has 2 twins. If you see this type of thick septum, okay, between these 2 tens, it is known as, see, this is the thick twins, thick one, okay, and it is known as lambda sign. Okay, remember how you will remember this? Remember it as मोटी, okay. मोटी को हम प्यार से लड्डू बुलाते, okay. So remember, in the case of dichorionic diamnionitic twins, there be lambda sign, Okay, there will be this lambda sign in a case of dichorionic diamniotic twins. Amniotic twins. Whereas in monochorionic twins, there will be what? There will be this thin membrane. Thin membrane. This thin membrane is known as what? It is known as which sign? Yeah, it is known as T sign. Yeah, good Dr. Abneet and good Dr. Anar, good Dr. Baba. Good. Fine. And finally, this variations of the placenta, if you see side, instead of attaching to the center, if it is attaching to the side, it is known as battledore placenta. And if there is any thickening of this placenta, it is known as circumvallate placenta. And if you are able to see two lobes, there is one primary lobe and secondary lobe, it is known as succinturate placenta. Yeah, placenta. Yeah, good Dr. Parul, good Dr. Gautam. Yeah, good. And in this succinturate placenta, it can lead to this secondary ppH. And next, if instead once joining only this this umbilical cord should start separating. If it separates before itself, if it starts separating before, okay, then it is known as what? Then it is known as velimentous insertion of cord. It is known as velimentous insertion of the cord. Yeah, good Dr. Gautam. And this can lead to this placenta, means this can lead to this 𝗲𝗄 previa. Means in a case of 𝗲𝗄 previa, the bleeding from the child will be there. Fine. And next, about the cervical incompetence. Cervical incompetence matlab means the cervical will be short, so that there will be a recurrent abortions will be happening. So usually it will be the second trimester abortions, and the cervical length it will be less than 2.5 centimeter. If it is less than 2.5 centimeter, then the baby will automatically come out. So this is known as what? Cervical incompetence. So in such cases, we'll do this cerclage, which is known as McDonald cerclage. We'll do this cerclage, which is known as McDonald cerclage. Okay. Fine. Finally, this Leopold's maneuver. If you see this Leopold's maneuver, there are 4 maneuvers. This one, it is known as, we'll see this fundus. What is the presenting part? Like based on it, if it is head is here, head is on the fundus, then we'll think, yeah, when the baby is sitting, it is a breech presentation. If multiple irregularities is there, then it is what? Then it is limb, then it is a cephalic presentation. So Leopard 1, it is to assess which is the presentation. And then based on the lie, like if it is both this with in relation to the female spine, we'll check. If it is like this, if the baby is like this, okay, then it is transverse lie. If it is like this, it is the longitudinal lie. And if it is the oblique lie, and it is the longitudinal. And in third, we'll check whether what is the presenting part, whether the head is there or sacrum is there again. So if head is there, it will be a single palatable mass, whereas sacrum, there will be multiple parts will be there. Whereas in fourth, we'll see whether the baby part, which is presenting part, is engaged or not. So if two hands meet, then the baby is not yet engaged. So see, if two hands meet, means that baby head is still here, it is not engaged. Whereas all of this first, second and third, it will be facing the woman. The final one, the fourth part, will be facing the foot of the female. Yeah, correct. Okay, this one is this first pelvic grip. Okay, this is the second one. Okay, remember. And here, if two hands meet, it is not yet engaged. If it is not meeting, means the head is engaged and is going to deliver. Fine. And finally, the final one, it is this molar pregnancy. And this molar pregnancy will be having this no chrome appearance. If only mole is there, then it is what? Then it is complete mole. If it is mole, along with this fetus, it is the partial mole. Remember, it is the partial mole. If it is only mole is there, it is the complete mole. Okay? And we know in the case of molar pregnancy, there will be more vomiting because of increased levels of beta HCG. Okay, we'll do this beta HCG monitoring to check for choriocarcinoma as well, and we'll tell them which of the following contraceptives is contraindicated here. Will contraindicate, means the contraindicated IUDs, intrauterine devices, IUCDs, there will be contraindicated in the case of molar pregnancy because the uterus will be soft, it can lead to the perforation. Okay guys, these are the most important must-know topics from the gynecology and obstetric perspective. I guess you got some understanding from it, and if any queries, I will open to it, and just have one thing in your mind, that you can do it and you have the will to do it, and just stay consistent for next few more days and you will be doing it. Fine. If you have any doubts, please connect with us, or else we'll catch up tomorrow. Fine. And your final day. If you have any doubts, do you have any doubt, guys? Yeah, thank you, Dr. Anna Rajwade. Thank you for being, repeats are mono and dichorion. So, Dr. Ambika, it's nothing. See, if you see this, you remember by this mnemonic. Thank you, Dr. Bhargav. Thank you, Dr. Sadaf Khan. Thank you, Dr. Parul. Thank you, Dr. Abneet Singh. Yeah, fine. If you see about Dr. I guess the previous days videos are already available. You can check it once. Okay. Are these PYT? Yeah, this is PYTs. PYTs are most important topics. Yeah, it is based on this PYTs. Yeah, correct. Skims forceps, like for example, see, this is the vagina. So in vagina, what you will do, it will be collapsed, right? See, this will be vagina which will be collapsed. Now you need to, for example, you need to examine the cervix. How will you examine the cervix? How will you examine? So what you will do, you will put up the Sims speculum, okay, Sims forceps or Sims speculum. You will retract this. See, this is like this Sims, right? So what you will do, you will retract it. Once you retract it, what will happen? Once you retract this, you will be able to see this vaginal wall, right? You will see inside what is inside. So this is how the use of the Sims speculum. Okay, I guess you got it. Fine. And about this monocorotic, just remember, if this between these two twins, this is one twin, second twin, in active stage of labor, why should you need massage? No need of massage. It is contraction. In a case of active management of third stage of labor, as per WHO protocol, there is no need of massage. But if it is done, it can be done. Okay, because WHO didn't mention don't do it. Okay, it mentioned it is not there. That's it. Okay, if you are doing it, it's good only, but it is not mentioned, so we won't tell. Okay, we won't create controversies. That's it. Okay. Yes, sure. About the notes part, I will call them and I will connect to it. Okay, don't worry. Okay. So about these twins, you just see if it is. Other professors will do subject wise. No, I couldn't get Dr. Pratik Mani. Thank you. Welcome, Dr. Anna. Yeah, it is really warm to have you here. Like, you are really very much interactive. Like all of those, like the shows, Anna and Shubham, Vishi, Bhargav, Abhijit, Sadaf, Bhargav, Parul. Yeah, good. Gautam. Yeah, rest of you guys. Okay. And if it is between two twins, if there is thick membrane, remember it is the lambda sign. So it is what? Remember it as Laddu. So lambda signs in a case of dichorionic diamniotic twins. Whereas this monocorionic twins, you will see this membrane, see, this membrane is very small, right? This intermembrane is very small. So it is what it is known as T sign. So remember it as MOT. So monocorionic twins will be having this thin membrane which is known as T sign. Okay. I guess it cleared your doubt. If any, please reach me out tomorrow, and we'll be meeting you tomorrow, guys. Tomorrow is our last date. If you have any other queries, please return come. Okay, so that you won't forget, and we'll address you. We'll help you out. Okay. See you guys. Bye bye.